So good morning, everyone. My name is Dr. Kumarasamy. I'm the Vice President of AIDS Society of India. Along with me, we have got my two scientific co-chairs, Dr. Tripti Gilada and Professor Satish Rao. On behalf of AIDS Society of India and the Governing Council of AIDS Society of India, we welcome you to this ASICON 2026. I think it's the 17th ASICON. We have an excellent program which has been developed by a committee which comprises of we three co-chairs and several other members from our governing council, which Dr. Tripti will walk you through what we have put up in this to welcome you.
Good morning, everyone. Welcome to ASICON 2026. As you all know, the theme for this conference is adding life to years with science and solidarity. And that theme has actually guided every decision we've made while designing this program. We've consciously tried to build a program that is comprehensive, integrated, forward-looking, and spanning the entire continuum, right from prevention strategies, diagnosis, PrEP strategies, advanced disease care, also looking at cure research, and a lot of emphasis on non-communicable diseases that we're now seeing. This science is evidence-based and constantly evolving, but it also recognizes something very essential, that the progress that we make cannot happen in isolation. It will have to happen together with communities, together across specialties. And with that idea, we also had a pre-conference workshop yesterday talking about interpreting reports. And we also have a post-conference workshop on International Women's Day on 8th of March, that's Sunday, integrating HIV/STI care into women health. We are trying a few initiatives this time. We have, in the era of AI, we've tried to use AI. You will see a lot of introductions which are AI-based. After the end of the session, you will get an AI summary of each of the talks that you attend. We are really attempting to keep this a very eco-friendly conference. So we've really tried to go no paper, no plastic. And we hope to get better at that. The other thing that is that we are a little sad about is just the entire global scenario. And while we do celebrate the richness of the scientific program, we acknowledge that a lot of our international faculty could not make it to the conference at the very last minute. They had to drop out because of the scenario. And we deeply value their support and we hope to connect in stronger times. But it's also a reminder for all of us to strengthen our local and regional collaborations. We will put up a slide, but the entire program is on a web-based app. So we would encourage all of you to get onto that web-based app, which will help you seamlessly navigate between sessions, help you interact with questions, quizzes, also to download the certificate at the end of the conference. We have some wonderful papers that came in for oral and poster presentations. It was slightly disheartening that the numbers have dwindled, which is a reminder to all of us that we need to encourage the younger generation to keep their interest alive in ID and HIV. But we've selected some excellent posters that are right at the back, and we will have 6 oral presentations tomorrow. So we really hope that we have an engaging 2 days, and we look forward to learning together, interacting, and building newer collaborations. Thank you so much, and I would now request Dr. Rao.
Good morning to all of you. As it has been already told, I would request you to freely actively participate in the conference, where we expect all diverse ideas to collide and generate that spark, which could be a future innovative idea. So with this, we start the conference now. And I request the chairperson for the first session of the day, which is HIV Epidemiology in India 2026. Who are we still missing? I request our president of AIDS Society of India, Dr. Glory Alexander, to take over from now. And I also request Dr. Sunil to take the chair.
Good morning. So we start with our first session for the day, which is HIV epidemiology in India 2026. Who are we still missing? The chairs, Dr. Glory Alexander is here and Dr. Sunil Bhokre.
Good morning to all of you. We welcome you to this first day of the flagship event of AIDS Society of India, which is ASICON, the 17th ASICON, being held here at Mumbai. And we are very happy that the hall is a quarter full, and as time goes on, I'm sure it will get filled up. So let's just go ahead and begin our first session, which is HIV epidemiology in India 2026. Who are we still missing? And it's very obvious that we are still missing some people because we are just not able to hit that 100% of the first component of 95. And we need to reach out to those people who are still missing. And we are very happy to have some experienced speakers here who will give us also some ideas. So the speakers for this session are Dr. David Bridger from UNAIDS, Mr. Sharad Ugade from MDAX, and Dr. Rakesh, two of them, right? Have I got the wrong? It's correct?
Suswagatam, welcome Mr. David Bridger to ASICON 2026, Mumbai. Mr. Bridger is a development economist with over 25 years of experience in international development and has worked for the United Nations for over 20 years. He has served as the UN Resident Coordinator in Armenia and as the Resident Representative of the United Nations Development Programme, UNDP, in Armenia. He is a strong advocate for human rights and gender equality and is passionate about ending the AIDS epidemic. We look forward and hear him talk on update and outline of new global AIDS strategy.
Sorry about the confusion, just give us a few minutes.
Today. I wanted to share with all of you a very brief presentation on the new global strategy, a framework for the HIV response going forward to 2031. I hope this sets a starting point for further reflection today on where the response in India needs to go over the next 5 years. India, after all, has the second largest population of people living with HIV globally, so we are definitely not going to achieve the goal of ending AIDS as a public health threat if India doesn't get there as well. Why are we here and why does it still matter? I think we would all agree in a world consumed with conflict at the moment, from the Middle East to the Ukraine, Sudan, and so on, we can see crises, human rights erosions, political uncertainty, and some are quietly asking whether ending AIDS is still possible, whether it's still realistic, whether it is still a priority. And of course, our answer collectively must be clear and courageous. Yes, ending AIDS is still possible, but only it will be possible if we don't give up. That's why we need a strategy, not because the world is calm, but because the world is turbulent. This is not a UNAIDS strategy. This is a strategy uniting the world. It's a roadmap showing that what it will take to end AIDS as a public health threat. Why now? We are at a historic crossroads. The science exists, the tool exists. Communities have never been more resolved. But political will and financing are fragile, and the window could close. This moment may be our lost opportunity to align the global momentum and end AIDS once and for all. This strategy is not about maintaining systems, it's about transforming them. It's not about incremental change, it is about decisive action, and it calls on all of us, governments, donors, civil society, communities, and leaders to choose courage over fatigue and hope over resignation. Now, the strategy was not developed behind closed doors. It was shaped by thousands of voices across regions, identities, sectors, and experiences. It came from people living with HIV, young people, key populations, governments, donors, researchers, parliamentarians, and UN partners alike. Through surveys, regional dialogues, virtual consultations, and deep lived experience conversations. If we look at the diagram on the screen, in Asia Pacific alone, we held consultations which involved 96 civil society organizations and 18 governments, often just representatives from governments in those consultations. Now, the strategy was actually built on 4 building blocks. First of all, we undertook a midterm review of the previous global strategy, and that was reported as our global report back in July 2027, where we gave a progress update on where the strategy was and what was needed to go forward. We also undertook a process where we looked at what the recommended global AIDS targets would be required for 2030, 2031. And a special working group was built 18 months ago to look at those and develop them. And then we also drew on a number of countries who are developing sustainability roadmaps. And we used those as the foundation for developing a great theme along sustainability in the strategy. And you'll also see, of course, that we've had a number of consultations throughout countries and regionally as well. So what's new? The new global AIDS strategy is not business as usual. It responds to the world we are now in, a world of overlapping crises, widening inequalities, shrinking civil space, and new health and economic shocks. What is new is not only the framing, but the level of ambition. We have a sharper focus on inequalities, structural barriers, and people who are most left behind. A deeper commitment to human rights, gender equality, and decriminalisation. Stronger commitment to communities as leaders and decision shapers, and a better integration with broader health and development agendas, including universal health coverage and preparedness for future crises. Clearer lines of accountability, who must do what, by when, and with which resources. In short, this strategy is designed not just to sustain progress, but to close the gaps that are still costing lives. Now, the strategy sets out 3 priorities centered on ending AIDS and ending inequalities. Priority 1, sustaining the response. This is mapping out a country-led response that is resilient and ready for the future for people living with and affected by or at risk of HIV. Priority 2 are people-focused services, equity, dignity, and access for people living with, at risk of, and affected by HIV. And priority 3 is around community leadership at all levels of the strategy, from financing and integration through delivery of services and accountability. The Global AIDS strategy aims to be more focused and prioritized. Last time, I think we covered around 15 areas for action. This time, we're putting forward 8 result areas across those 3 priority areas that I just outlined in the previous slide. Throughout the result areas, from financing to HIV prevention, you'll find actions that aim to build sustainability of the response, ensure full community engagement, and strengthen country systems and health security. Let me, over the next several slides, take a deep dive into the 8 result areas. Now, I'll not go through all of the detail that are on the slides. I'll let you read those and maybe consult them at a later time. Here, starting with priority 1, the action area focuses on financing, systems integration, and data across 3 result areas. Now, result area 1 focuses on financing in the response to HIV, and it's essential for national strategic plans to be integrated within national structures for a coherent national response. Funding sources need to be diversified, especially domestic financing, and country-led responses should not result in increased user fees that might drive people away from services. Sustainability roadmaps will be critical and must involve communities. Result area 2 focuses on integration of HIV response into the national systems, particularly into primary health, as a clear priority. This involves investing in capacity building of health services. It also involves embedding a human rights-based approach to the integration of HIV services with stigma-free, gender transformative and youth response and key population appropriate services. Result area 3 focuses on strong data and information systems. These need to incorporate multiple sources to inform national responses, and community-led monitoring will be essential to measure the quality of those services and strengthen accountability. Under priority 2, the recommendations focus on the scale-up of essential HIV prevention, testing, treatment, and care services, but also on how to improve delivery. So here, result area 4 highlights the critical need to seize the opportunities of new HIV prevention and treatment options, like PrEP and long-acting formulations, quality diagnostics, and embedding services within communities through differentiated service delivery at all levels. Result area 5 focuses on HIV testing and recommends the acceleration and design and scale up of people-centered services that integrate HIV services with those of other co-infections and other infectious diseases. Sexual and reproductive health, STIs, cervical cancer, maternal and child health, NCDs, chronic diseases, mental health, and gender-based violence. It highlights the critical role of networks of people living with, affected by, and at risk of HIV to help design and implement programs that meet the needs of those who need them most. Result area 6 highlights that we cannot achieve our goals without lifting societal barriers and improving access to innovation. So this really focuses on multi-sectoral action, which is needed more than ever to ensure that all people can receive stigma and discrimination-free services and to lift criminalising laws. The strategy puts forward concrete actions to ensure that services reach the people who need them most. Result Area 7 emphasises the importance of improving equitable access to medicines and innovations and to leverage digital health. Priority 3, we look at Result Area 8, which proposes on how to better integrate community-led systems into national responses while promoting the key role of communities for leadership, service delivery and accountability, ensuring mechanisms for social contracting and monitoring the funding for communities are part of the concrete actions that can ensure this is translated into reality. Apologies, I know this is a very busy slide, but for those interested in global targets, it is an essential one. The actions recommended in the strategy are aimed at enabling countries to achieve the 16 top-line targets towards ending AIDS as a public health threat by 2030. And some of these targets are new. The consolidated HIV prevention targets, the integration and the financing targets have all been refreshed and are new, whereas some of them have been actually extended. So you will see again the 95, 95, 95 that takes us through the treatment cascade, the 10, 10, 10 targets on the enabling environment, and the 30, 80, 60 targets on community engagement and leadership in service provision. These are all refreshed and continued as they were not achieved in 2025. Now, our governance board asked us to also provide some regional specificity. And through regional and country consultations, 8 regional chapters are included. Now, these highlight the differences in regional epidemic and financial contexts, but also how the global AIDS strategy is relevant and can be taken forward in every region. As you can see here, the Asia Pacific region has the second largest epidemic globally, largely driven by new HIV acquisitions among key populations. It's also very advanced when it comes to sustainability and integration of services. Some of the priorities for the future include a strong focus on HIV prevention for people most at risk and young people. Now, I'm not going to go through the other 7 regions, but we'll leave the slides for anyone interested to access later. And finally, a reminder on our role through consultation with governments and communities in shepherding the following process forward over the past 2 years, and more importantly, the focus this year. This has been done through a 4-pronged approach, beginning with the global AIDS target setting 18 months to 2 years ago, which has now been translated into a strategy that I've just presented today. But critically, this year, we have a real big task ahead of us because we need to take this strategy now to a high-level meeting at the UN and seek a political declaration, a process that we hope will be undertaken in June at a UN special session of the General Assembly, and then the development of a political declaration which will hold member states to account and will help shape the respective national strategies and plans at country level. UNAIDS works together with countries and communities to monitor the targets. This is the UN's responsibility and promise to those living with and affected by HIV. So thank you. I'm sure that's enough from me on this morning. I hope this sets the scene for some discussion on where India now needs to go through its own national response and the uptake of critical innovations to assure it can also meet those 2030 targets. Thank you again. I look forward to the discussion as we move forward.
Thank you, Dr. Bridger. Questions will be taken at the end of the session. I'm happy to introduce my co-chairman, Dr. Sunil Bokre. He's Commissioner Urban, as well as belongs to MSACS, Maharashtra AIDS Control Society. Would you like to say?
Welcome all, and thank you for this honor.
The keynote speaker for today is Dr. Raman Ganga Kedkar, who is well known. Is that right? Before Dr. Raman Ganga Kedkar, we have how did Mumbai become India's AIDS control capital? The speaker is Mr. Sharad Ugade, MDAX.
Suswagatam. Welcome Mr. Sharad Ugade to ASICON 2026, Mumbai. Mr. Sharad Ugade, Project Director of the Mumbai District AIDS Control Society, Mumbai. A committed public health leader, he has played a key role in shaping Mumbai's HIV response through strong community outreach, focused prevention strategies, improved access to testing and treatment, and meaningful collaborations with government and NGO partners. Under his leadership, MDACS has strengthened HIV prevention programs across the city, expanded counseling and care services, enhanced partnerships. Today, he addresses, how did Mumbai become India's AIDS control capital?
Good morning, all. It's an honor to be here at such a prestigious platform. To begin with, if we think of Mumbai, and almost 2 decades ago, Mumbai was one of the cities most affected by HIV in India. At that time, many people believed that a mega city like Mumbai, with its dense population, lot of migration, social diversity, and then more than 40 to 50% people living in slum or informal settlement would never be able to control the epidemic. But today, I stand before you to share a different story. A story of how a city of over more than 13 million official population city with some of the dense slums in the world came together, government, doctors, NGOs, and communities to turn the tide against HIV. This is the Mumbai model of HIV control. I will briefly present Mumbai's journey in controlling the HIV pandemic. The presentation highlights epidemic trends, program innovations, and how partnership and the outcome. As we all know, the issues of Mumbai, it's one of the biggest mega cities, having a huge population, high density, and any challenges which any mega city of the world faces, Mumbai faces even more complex scenario. Despite this, there are many opportunities as well. Mumbai being a financial capital of India, and BMC being the governing body with highest support to health system. Over 8 to 10% budget of BMC goes to the health department, and with 5 medical colleges, major hospitals, 16 peripheral hospitals, more than 500 dispensaries, maternity home, clinics, we all are committed. If we see history of HIV in Mumbai, as we know, 40 years ago, there were first cases detected in India, and Mumbai was among the early affected cities. Initial infections were mainly identified among female sex workers and related to them only. Recognizing the emerging trend, BMC initiated early interventions. Strong collaboration began between municipal, state, and national HIV programs. This laid the foundation of Mumbai's structured HIV response. This chart describes the journey. Initially, in the early years of 2000, if we see the positivity trend, it was almost reaching to 15.67%, which was at the peak of year 2003 to 4. And with the dedicated interventions, now this has come down to almost 0.5%. Transmission was mainly concentrated among key populations of female sex workers, men who have sex with men, people who injected drugs. These situations required focused and targeted interventions. So this positivity trend shows the earlier scenario between the years of 2001 to 2, and then it started declining with the interventions. In the initial year, BMC has signed fast track cities. BMC is a fast track city. Mumbai became one of the first cities in India to sign the Paris Declaration in the year 2015. This commitment aligned the city with the Global Fast Track Cities initiative. The goal was to end AIDS as a public health threat by 2030. Strong governance under BMC enabled coordinated policy leadership and implementation. So, the key interventions and innovation driving impact, how we did this. So the first step was to reaching to the unreached. Mumbai adopted the innovation strategies to reach hidden population. Geospatial mapping helped identify high-risk clusters. Virtual outreach, it was used to reach MSM, transgenders, youth, and hidden networks. Additional to outreach, we included evening clinics in hotspots, mobile vans, and portable testing units. Outreach in spas, industrial units, and even to the police department. These strategies ensured no vulnerable population remained unreached. Then we had an integrated service delivery where Mumbai adopted a comprehensive client-centered service model. Integrated centers provided HIV, STI, NSD, and mental health services together. Family-centered ART services improved treatment adherence. Special initiatives included IS-STS screening camps for women living with HIV, OST clinics in Arthur Road and Baikula jails. This has ensured continuity of care of vulnerable population. Similarly, we adopted a lot of innovations for client-centered care, and several community-focused innovations were to the name Mitwa to support program for adolescents living with HIV, Anubandh for peer support of elderly with PL-HIV, Zindagi Kiosk, this is digital awareness modules, and Samvad app. This was used for counselors for the decision support. Social protections camp like linked with PL-HIV with health insurance, welfare schemes, and financial support. It was implemented. To further strengthening partnership, we believe in strong partnership is critical for the success, and hence we started engaging with private healthcare providers through IMA and MMC. It has improved testing and reporting pattern. Collaboration with other governments, including Women and Child Welfare Department, tuberculosis control program, NCD programs, and many more programs implemented at BMC. This multi-sectoral approach strengthened comprehensive care delivery in Mumbai. So with all these implementations and interventions, these are the some of the initiatives which I just discussed, like engaging with private healthcare providers, community-based HIV screening, sensitization workshops, virtual friendly ICTC, then intensified campaigns for HIV awareness, integration with TB control program, further digital and virtual outreach platforms for key population. These are the evening clinics in Baikala. Mobile testing vans, this has really created a good impact in the city. Anubandh for peer support, Zindagi kiosk, cervical cancer screening, which again has been launched in Mumbai. With all these interventions, if you see the current HIV scenario in Mumbai, so with the HIV estimates population, 62,571 is the PL HIV population. And the target which was set for 95, 95, 95, that means the 95% people knows their status, 95% people on ART, and 95% are virtually suppressed. In case of Mumbai, so far we have achieved 92%, 92%, and 98.3%. So this is the result of our dedicated interventions. Also, HIV incidence right now is 0.004 per 1,000 population, and around 332 pregnant women require EVTS services annually. This is the present situation. Mumbai with 20 ART centers treating more than 41,800 HIV, 82.2% of them are first line ART, and 98.3, as I said, viral suppression we have achieved. So these are the impact of the intervention and innovations. And if you see these results, decline in HIV prevalence and positivity over the effect of for last 4 decades, 82% decline in general HIV positivity over last 10 years, 89% decline in ANC HIV positivity over 10 years, more than 70% decline among key populations in last 10 years. These trends reflect strong prevention and outreach measures in Mumbai city. Now Mumbai has made significant progress towards 95, 95, 95, though we are not complacent with the results so far, and we are looking forward for further achievements. Initially, HIV testing was 4.7 lakhs. Now we have increased it to 6.1 lakh annually. Despite increase in testings, the positivity rate is very, very less, which was evident from the trends. And over 99, this 95, 95, 95 for in NACO's recent directions, we have been given directions of 95, 95, 99, which is a very, though it is difficult, but we are going to achieve this target where 95 people will be knowing their status, 95 will be on ART, and 99% will be virally suppressed. And we are working very closely on that. By 1st December 26, we have planned to achieve this target as well. And these, as per DG NACO sir, these are new guidelines, Surakshit Plus. So Sangharshashil, Saksham, Surakshit, and Surakshit Plus. So Mumbai is about to enter into this phase, and we are targeting to be here, Surakshit Plus, this year. So this is how Mumbai's story is. Mumbai's journey demonstrates the strongest leadership, innovation, and partnership between everyone here, between the government, private sector, the leadership, political leadership. And this continued commitment will help achieve epidemic control and elimination goals in Mumbai. Thank you very much.
Mr. Sharad, I request you to come and sit here, please. Questions will be taken at the end of the session. Our next speaker is who will be giving the keynote address is Dr. Raman Gangakedkar, well-known figure in the field of HIV. Doesn't really require an introduction. He will be speaking on last mile connectivity, achievements and challenges. And as you all know, he received the Padma Shri a few years ago. Welcome, Dr. Gangakedkar.
Suswagatam. Welcome Padma Shri Dr. Raman Gangakedkar to ASICON 2026, Mumbai. A distinguished epidemiologist from Pune, he has played a pivotal role in shaping India's HIV research, surveillance, and public health response through decades of work with the Indian Council of Medical Research. His leadership at the National AIDS Research Institute has helped translate science into impactful HIV programs across the country. Today, he shares insights on last mile connectivity, achievements and challenges.
Sorry. I'm really sorry that I have to sit and speak. Health reasons. Ilada has been kind. He told me yesterday that I have to give this keynote address. The first thing that came to my mind, I looked at the duration, I looked at the title of the talk. This is cricket season. He said ASDG is not coming, you give the keynote address. It was an unexpected event like a rain in cricket match. No? And I hurriedly read the whole thing. We could not decide whether it was T15, T20, and T stands for minutes. No? And finally, when he started objecting, I looked at it. It was my complete oversight. There's one thing which I would also like to say before we go further. The entire data comes from NACO, whether it is Sankalak, whether it is AIDS estimations. One of the careful balancing acts that I had to do was not to speak about NACP phase 6, because that is to be launched sometime after 31st of March. So let's try and see some things. This could be, there seems to be some glitch. I was actually envying yesterday all those who came here as participants, because I was the only one who had to struggle whether I should watch the cricket match or I should prepare the PowerPoints. I chose the difficult pathway. So all the night I worked on the PowerPoints and also saw the match. ASICON म्हणूनच नाव आहे. Yeah. This was the title which he gave to me. I just changed it to Achievements and Challenges. Now, we have to look at it in a slightly different manner. You know, whatever I'm going to critique, it is with constructive criticism, if at all. Now, what are the goals for AIDS elimination in 2030? You have to reduce new infections by 90%. The base year is 2010. Please remember this. And then you have to continue 5% decline per year after 2030. You reduce AIDS-related deaths by 90% from 2010. And sustainability is an issue which all of us know, which will become perhaps far more difficult to achieve once we cross 2030. Now, where do we stand in global comparison as of now? If you actually look at all the parameters, you will suddenly feel that perhaps we are far better off compared to the world. But is that a reality that we should feel that we are very happy with the progress that we have made? Perhaps, perhaps not. We have to remember we have still miles to run before we actually can rest where we are at this point in time. We know that India has a very low adult HIV prevalence rate of 0.20%. You have 25 lakh, 25.5 lakh people who are HIV infected that has been estimated so far. You look at change in annual new infections since 2010, suddenly it comes as a shock because now the figure drops down to 48%. Please remember this. You look at change in annual AIDS-related deaths, the drop is better, the decline is stronger. You are seeing it almost 81%, which means you are closer to 90% there. Now, if you look at the ART performance that we have, it's excellent. You have perhaps the most powerful drugs that have been introduced. Simplified regimen is there. And the impact is also seen because today, if you look in terms of how much scale-up has occurred, you have almost 800 centers, 17.5 lakh people who are receiving ART. You look at ART initiation and LFU, the blue line tends to talk about the LFUs. Even LFUs are dropping. And your coverage has increased dramatically as of now. This is among those who have been detected as HIV infected and have been linked to the services. You look at HIV-TB co-infection, perhaps the best example that the best support that we have provided to National Tuberculosis Elimination Program. But even here, there is some glitch that we have to look at. There is variability in TB prevention therapy, that is TPT as we call, that tends to exist between states. And that's something which is a major reason to worry. We may need to take efforts to strengthen the same. You look at HIV infected pregnant women, you will suddenly find the coverage rate among those who have been detected. I keep on telling the same, it is 97%. Now, if you are able to link 97% of those who have been detected to ART services, you are really doing good. But is that the complete story? Perhaps not. You look at the vertical transmission figures in 2024, there are certain learning lessons which we have to keep at the back of mind. We are looking at an estimated number of HIV positive women giving birth, 18 lakh people, right? So there is a room to improve on that performance also. You look at even those, let's say, the proportion of people who have been linked, that's far better than it was before. But you look at vertical transmission rate at 6 weeks, it is 3.75%. And you look at vertical transmission at 18 months and onwards, it comes to 10.25%. So what does it essentially tell? It tells you that we can improve coverage for testing and linkages. We also need to think in terms of reducing new infections by using this strategy. The more of these young women will be linked, perhaps you will find its impact on HIV incidence in the community. And what is also important is we need to strengthen ART counseling during breastfeeding. And perhaps that's one of the main reasons why you find that there is increased transmission rate after 6 weeks of 6 weeks after birth. And that's something which we have to worry. And why does it happen? Why am I mentioning ART counseling? Because essentially these women don't adhere to the treatment. and therefore they tend to transmit HIV infection to their babies. And this is very clearly shown by one of the slides where EID testing and ART coverage is looked at. You will find that only 57% of EID tests could be offered by 1 year of age. Now, which essentially means the risk of transmission will continue because you are able to diagnose, offer the test, and perhaps diagnose somebody who's infected only at the end of 1 year. That means our follow-ups have to improve, which could be beneficial for both the child as well as the mother. And this is likely to impact both. If it is mother, you will find incidence may reduce. If you look at the child, you will also find that the death rates would be improved to an extent. Now, when you look at EVTHS, elimination of vertical transmission, you will suddenly start finding that we are doing well in terms of offer of these tests, despite the fact that this is now linked to NHM, National Health Mission. We are still performing well. If you look at the HIV testing that is occurring, almost 84% of women are being offered HIV test. But when it comes to syphilis, we perhaps need to be jogging the memories of people who are managing these ANCs that they need to improve. Syphilis testing, somehow, these are more representative of public sector rather than private sector. But we need to inform them that both have to go well if we are looking in terms of elimination of these diseases. Now, what is our achievement so far? If you look at the summary slide, in 2025, what was it? Where were we? You look at change in new infections, there is a decrease. But many of you must have forgotten that the target was far higher for decline that is to be observed. So we need to worry about the new infections that are occurring in the community, and that should be a major botheration for all of us. If you look at change in AIDS-related deaths, perhaps the improvement is good enough. We are only to add 10% more, and this will perhaps happen the best way if we ensure that ART counseling is done well. More people are linked to ART. ART is too powerful. It will prevent deaths automatically. If you look at the incidence, overall incidence as we see in India, what is it that we are seeing? Please remember, incidence is for new infections. Prevalence is very different. Now, if you look at the incidence, you will find incidence is almost flat or declining in the last 10 years as such, if you look at annual rate. But does this tell you complete story? It doesn't tell you the complete story. If you look at the state-wise trend, now you will suddenly find that though large majority perhaps is showing a decline from 2010, you must remember that the variability is extremely high. So the states where decline has occurred less are a major botheration for us to worry about. We need to improve upon that. If you look at some of the states, which may have been smaller, but you look at the red line, there is no decline, but there is increase in HIV incidence per se, which is a major botheration because you need to look at comprehensive strategies that you will have to offer to people to ensure that the incidence tends to decline over a period of time. When we look at these estimated new infections by states, now if you look at this particular graph, you will find majority of these states are those which are highly populous states. No? If they are highly populous states, that's a worry because that also tells you that we need to strengthen on ART counseling that tends to occur. And that is an issue which becomes important because they are bearing the major brunt of HIV burden as such. This was the old Bruce Weniger's model most of us knew from core group population, which is not a very good terminology to talk about, but like sex workers, injecting drug users, MSM, They were grouped in core groups by him at that time. This is sometime in 1990-91. And they transmit, the hypothesis was they transmitted to mainstream population. The proxy was women and children through breech populations as such. But does this remain valid now is a question which we have to think. If you ask me why India succeeded, perhaps the reason we cared for our local evidences. Our strategies, programmatic strategies, revolved around those three circles. We tried to ensure that the infection is stopped in those three circles so that mainstream population is not worse affected. You look at HIV prevalence by subgroups today, you find PWID, that is injecting drug users, have the highest. You look at HIJDA and TG population, they have 2.84, which is far lower. But is this a true reflection? I don't think so. Perhaps we need to have representative sample to be talked about it. I think our coverage is not so good. You look at MSM, it is 2.12. And then you go down the line, you look at sex workers, it's only about 1.1% and a very low incidence overall among adults. But what is the worrisome data that you tend to see among them? You look at the estimated HIV incident infection among states in 2024. You look at sex workers, the graph that you see on the left side, FSW incidence is the highest in highly populous states in India, where the disease burden of HIV is high. So that means we have to worry even still about controlling the outbreak that is occurring among the sex workers. You look at MSM, the situation continues to remain the same, that is the middle bar. Wherever the population size is larger, you are still finding that the incidence is high, the new infections are occurring there. But what is furthermore worrying, if you look at injecting drug users or PWID, whatever you might call, newer hotspots are emerging beyond Northeast now. The ones on the left perhaps are a representation that we need to reflect upon this issue. How do I know where it is going to emerge, and what strategies do I adopt to ensure that we will be able to control the same? You look at the coverage for targeted interventions as NACO reports as of now for various typologies. And what is it that you are finding? The coverage that is estimated, reported is more than 95% for most of the typologies, excepting migrants. For migrants, it's close to about 55%. Now, this group is also important because they could transmit infection from the high HIV incidence states to the lower ones in the community. And that's something which we have to think about as to how would we go about doing this. One of the best methodologies which we must understand is to look at new infections and try and find out who is acquiring HIV infection through which route. One of the studies which NACO, with their own data, they looked at, what is it telling you? This is one of the best slides to my mind. Earlier, please remember those Bruce Vinegar circles. The entire infection was perhaps driven by sex work. You look at the last new infection cases, the mode of transmission, and what is it that you find? You find that 32% of those who are heterosexuals but having regular partner, no, that is the cause that the mode that they have described. 15.1% are heterosexual with casual partner. You compare the same with commercial partner, that is sex workers, you will find the prevalence is the attributable fraction is far lower. What does this mean? Today, this epidemic, I don't know whether we should call it as epidemic as of now with the numbers so small, but therefore sometimes I feel it could be endemic more often. Now, one of the things which comes to your mind that the Bruce Vinegar's three circles that we had seen, perhaps there is a change now. It has spilled over into mainstream population. And now it's no longer sex work driven, but it is sex driven. The sex could occur from the mainstream population, and that has an implication in terms of devising strategies to control the same. And it may pose a lot of challenges, so intensity of spread may not be so high, but we'll need to worry about it. If you look at another group that is worrisome, is you find that new HIV infections that are detected, if you look at that data, 15 to 24 years age group, that is adolescents plus young adults, are showing a rise. That is especially so in certain states, which were low prevalence states. So which essentially means this is going to pose another major challenge. You have very little in terms of preventive interventions and their coverage among adolescents and young adults at this point in time. But we need to be innovative. We need to devise certain programs, prevention strategies to cover these young adults. Sorry. Now you look at biological vulnerability. Now that's something which is extremely critical for us to look at. You look at what is the cause of concern. When you look at these particular charts, you will find our coverages for key subpopulations. They are fairly good. But when it comes to one factor, the one on the right side you should see, the number of clinic visits that they have made, and look at the STI episodes with which they came to the clinics, you find the STI episodes were 49. 49 is too high a number. That means today the biological vulnerability among sex workers who are under targeted interventions, that has increased dramatically. You look at MSM population, the red bar tells you that there are 13 episodes of STI which you are treating in a year's time among these MSM. That's also something which is worrisome. No, it means that biological vulnerability is increasing. Behavioral vulnerability is already existent because these are risk categories. So that is always a part of it. If I did not put up a slide because I thought this will make it too long, but if you look at condom distribution that is happening among these subpopulations, it's pretty low. There is a room to improve condom distribution per person who belongs to these risk categories at this time. If you look at the data that comes from for Hijras and transgenders, you will suddenly find that the numbers of STI episodes treated is 3.7. Now we all know their condom usage is low. We all know that their number of partners tends to be pretty high. We also know that they tend to travel long distances for having sex as such for their own commercial reasons for that matter. What does it tell you? That we need to strengthen our STI services, especially screening that tends to occur among TG groups at this juncture. You look at HIV syphilis data. What does it tell you? You look at HIV screening data, it is far low. If you look at percent test positivity, that is there in the first block, what you see in that table is it's only about 0.29%. But you look at syphilis, no? Whether it is male, female, or transgenders, you'll find that it is far higher compared to HIV. Now, what does that tell you? It also tells you when syphilis prevalence rates are high, it is a proxy of poor treatment seeking behavior in the community. Because this could be old syphilis, as we used to call in olden days, chemical syphilis. It could be anything. But what does it tell you? That these people are not seeking access to treatment. And that's something which is a botheration because that could be a biological vulnerability per se. Syphilis can be latent. We have no worries. No, once people could defend, they are not going to add to biological vulnerability. But one must remember, if you look at people who have been coming to DSRC and look at the syndromes with which they presented, it shocks you. because you have very large proportion that has urethral discharge. You still have genital herpes disease and non-herpetic syndromes that you are seeing, and anorectal syndromes continue to be smaller because to my mind that coverage is poor as of now. Now, what does this tell you? That biological vulnerability is increasing at its own pace. We either improve STI services or perhaps risk the emergence of HIV back again. You look at 95-95 status in 24-25. What does it tell you? It tells you that it appears really good. No? 83% of them, almost 84% know their status. It is 87% they are linked to ART, and on ART, those who are suppressed comes out around 98%. But if you actually calculate, you will find that only 72% of those who are in the community and are HIV infected are virally suppressed. So there is always a very high risk of incident HIV infection increasing. But there was a heartening feature when you look at differences in gender. Women tend to fare better in each category in a male-dominated setting. And I think that's a big surprise for all of us because we thought since majority of the infections are likely to happen among males, we thought perhaps they are in a male-dominated setting, their treatment-seeking behaviors may be affected, but that's not so. Though HIV testing, if you look at the number of tests that we are offering, please remove that 2020, which was COVID epidemic time, but it has been increasing consistently. But despite the fact, on the right side, if you look at it, you find that HIV testing is increasing, but the yield is getting lower. We do not know why this is happening. It could be a reflection of higher stigma that continues to linger in the society or lowered perceived risk for which people who are at risk do not come forward to go for testing. You look at partner testing, it continues to remain as a challenge. Now you look at the number of people, they were close to about 12 lakh people, index cases, who were offered that they should go and contact their partner and bring them for testing. How many accepted it? 89%. And finally, when you tested them, 4.1% was the positivity rate, which is fairly high to my mind. Now, if you look at it, how many of these who were 10 lakh people, 11 lakh people, they went back and actually their partners were brought and tested, it comes to 62%. Now, if you look at this 62% people, and the first component that we looked at, number of people, index cases who were offered HIV test, since they were index cases, you find that the testing, overall testing is only about 55%. So unless we improve upon partner testing, things are not going to be as good. And if you look at the states where this offer of index testing is better, they tend to come from high prevalence states, which essentially means the outbreaks that will occur or the endemicity is likely to move ahead in states which did not have high HIV burden. And that's another thing we need to think about. 5 minutes, 2 minutes, Shayad. The challenges that we face, we try to reflect upon them. What NACO has done in NACP phase 5, they have gone ahead doing district prioritization. Which are the districts where you should prioritize? But what is it based on? It is based on the HIV burden that the district is facing. But for NACP phase 6, what is most important? When you are going to go closer to elimination targets, you will find perhaps we need to have bio-behavioral vulnerability added to these districts. Only then you will go towards elimination of AIDS. Otherwise, you will find that the risk of re-emergence of HIV would always be higher. What is it that is important for us to recollect? Now, when you look at these states, when you rank them, you have a sizable number that falls in the trend which is deterioration in the ranks. So implementation of these strategies has to be improved if we are to move ahead. Whom do we provide preventive interventions? The other day, in the past, our radars were strong. You could go to the brothels, you knew where the business was on, and you could actually try and provide them preventive interventions. So our radars in today's wartime, in the olden days, were really strong. But these are the days where stealth technology, where radar cannot detect, where are these risk groups, that has become more common. To reach them is going to be a challenge. We need to be open to using newer effective antiretroviral regimen or drugs in treatment as well as prevention. We need to have novel approaches to cover the adolescents, young adults, and high-risk categories. Effective approaches to partner notification and testing, we have seen earlier. Communication strategies to reduce stigma are vital. Only then those who are at risk will come for testing. And a strong public-private partnership, which all of us have been trying to talk about in conferences like ASI. Perhaps the flag bearer is Dr. Gilada. We need to improve upon that. And for sustainability, convergence with National Health Mission, as the numbers will start falling down, it has to be mainstreamed with the program that we have, that is National Health Mission, and community mobilization. To my mind, you cannot eliminate any disease, you cannot sustain elimination if you do not involve community. Leprosy is perhaps the best example. So in conclusion, we have defied predictions and reached thus far. We have really done well. A huge credit goes to NACO for its progressive, dynamic, and effective policies. Last mile challenges can be many. They may require intensified efforts, but together, our efforts will make 2030 goals achievable. Thank you.
Thank you so much, Dr. Ganga Ketkar, for that very clear presentation on the progress that we have made and the challenges that we still face. As we are running about 15 to 20 minutes behind time, I'm so sorry, but we are not going to take questions. You can please meet with any one of the speakers during the tea break and ask your questions. So that brings us to the end of the first session. My apologies for the initial hiccups. We have so many variations of the agenda and I was addressing the wrong one. So my apologies for that. And thank you so much to everybody, the audience as well as the speakers for their input.
Thank you very much. We would now like to request the chair people to send a memento to our speakers, starting with Mr. Sharad Ugde. And Dr. Raman Gangakekar. We would also like to request Dr. Dilip Mathai to felicitate our chairpersons for today. Thank you very much. We will now start our next session titled More Than Just a Viral Load. I would like to call upon our chairpersons, Dr. Vanita Gupta from Chandigarh and Dr. Vijay Kanwad from IMSACS. We'd like to hand over the proceedings to our chairpersons.
Dr. Vijay Khandewar, is he not here? No? He's coming. So, good morning, everyone. It is going to be a very interesting 3 days from now. And the topic for this morning, this session is truly very interesting. I'm so glad that we are diving into this topic. It's crucial to understand not just treatment success, but long-term health outcomes as well. We have 3 very interesting topics today, which is going to tell us not just treat everyone, but treat safely and treat personally. So I'm just going to look at the program and invite the first speaker. The first speaker of this morning is Dr. Rajiv Karthik from Vellore. Dr. Rajiv Karthik from Vellore will be telling us about more than suppression, what CD4 and viral load really tell
A
us.
respected clinician from Vellore, he plays a pivotal role in advanced HIV care and long-term patient management. His work focuses on understanding what CD4 and viral load truly reveal beyond just suppression. Today, he speaks on More Than Suppression, what CD4 and viral load really tell us, uncovering the deeper story behind the numbers.
A very good morning to all of you. I think I'll get started while these technicalities are sorted out. So the topic for this session is more than just a viral load. And what I've been asked to speak on is what exactly does CD4 and viral load actually mean? Is it just a number? And what do we really interpret from these tests that we have conventionally used for HIV treatment for a long period of time? So CD4 and viral load have been used for a long period of time. And in many of our minds, when we say HIV, we think virally suppressed and we think job well done. But I would like to think of it a little differently and take CD4 and viral load as 2 dynamic biomarkers or 2 dynamic tests that have a very layered clinical implication in the patients. So I would like to just take you through two patients, patient A and patient B. So patient A is 42 years old. He's been on therapy for 5 years, virally suppressed, viral load is less than 20 copies. His CD4 now is 680 cells, and his nadir CD4 was 420. He has a CD4 to CD8 ratio of 1:1.4, and he has no significant comorbidities. Compare that with patient B, again about the same age, 44, on therapy for 5 years, adherent, virally suppressed, but his CD4 was 290 cells, and his NADIS CD4 was 28 cells. And he has a CD4 to CD8 ratio of 0.4. And in the past, he's had recurrent infections. So you're seeing the patient today, both of them are virally suppressed, both of them have CD4 counts that are above 200. So are these patients actually clinically equivalent? Are they the same? And what do we need to know about these patients? And so what I would like to take you through today is why viral suppression alone is not enough as a marker in assessing immunological outcomes in HIV. What does CD4 mean? Do we just look at the CD4 number as of today? What is the importance of the CD4 nadir? What is the trajectory? And what is the importance of the CD4 to CD8 ratio that I'll discuss? What is low-level viremia? What do viral blips actually mean? What is the mechanism of persistent immune activation? And this is something I'll be spending a little time on and trying to understand what does this really mean and what clinical implications that it has, and what risk stratified monitoring do we need to do for our patients who come for chronic care. So we'll first talk about the CD4 count. And some of the earliest information about when to start ART came from the Insight Start study in about 2015, where it looked at individuals with a CD4 count of more than 500 versus those with a CD4 count at less than 350. And there was a dramatic difference, one, in both opportunistic infections, there was a 70% reduction, but also very surprisingly at that point in time, about 40% reduction in non-HIV related infections. And this is one of the landmark studies that actually led on to early initiation of ART. So you can see that 70% less likely opportunistic infections and about 40% less likely to have non-HIV infections. So this is the trajectory of the two CD4 counts of the two patients I talked about. In blue is a patient with a higher nadir, and you can see that the trajectory is higher. And the patient in orange is patient B, who had a lower CD4 nadir. And multiple studies from that time, from the SMART study to the ACCORD study, all showed us that starting therapy early has significant implications, not only in AIDS-related comorbidities, but also in non-AIDS-related comorbidities. About 15 to 30% of those who are virally suppressed will have what is called immunologic non-response, where the CD4 does not rise, but they're still virally suppressed. So that is a population we need to keep in mind about. And this is largely dependent on the NADIS CD4 count. And I'll talk a little bit more about this. So this is how the CD4 reconstitution kinetics looks. On top in the green is the people who respond very well. The blue curve in the center is the average response. And you can see that the orange or the red curve are the immunological non-responders. And what are the real drivers for this? The real drivers for this poor immunological response is a low CD4 nadir. So if you start with the CD4 in double digits or single digits, then your progression, your improvement of your CD4 is going to be significantly lower. So the strongest predictor with an odds ratio of 3.2 was a low CD4 nadir. And that predicts the ultimate CD4 count. Older age that we know because of immunosenescence, we know that because of the thymic involution, naive T cells are not formed. So that can also be a factor. Late ART initiation and also viral co-infections. So hepatitis B, hepatitis C. We know in HIV, there's also EBV and CMV reactivation. So all of these can actually predict lower CD4. Okay, so another reason why we use CD4 counts is for us to understand about prophylaxis. So you know about PCP prophylaxis, toxoprophylaxis, when to predict opportunistic infections such as CMV or MAC. So that's another situation where we actually use the CD4 count. What about CD4 percentage? When do we use a CD4 percentage versus a CD4 count? There are situations where there's lymphopenia and the absolute CD4 count may actually be misleading. So situations where somebody's had chemotherapy or there's hepatitis co-infection, splenomegaly, steroids, there can be some racial variation also. So in these situations, it might be better to use a CD4 percentage rather than the absolute CD4 count. And there are some guidelines that tell us what is the percentage for an approximate CD4 count. And if you can see for about 200 cells is about 14%, and for more than 500 cells is about 29%. So we can use these interchangingly, but a CD4 percentage is also important in situations where you expect there to be some amount of lymphopenia. Okay, so next is we'll look at the CD4-CD8 ratio. And this is extremely important because we know that CD8 cells are actually present during the activation phase of HIV infection. And what I'm going to talk about soon is this persistent antigenic stimulation and immune activation that drives the CD8 percentage. And a high and a low CD4-CD8 percentage actually is associated with the chronic inflammation and other non-HIV related, non-AIDS related outcomes. So this is the range if you see. So 0.4, which was in our first patient, is very low versus 1.5, which is about normal. So even looking at a CD4-CD8 ratio can predict non-AIDS related morbidity and inflammatory outcomes. So overall mortality is more AIDS progression, non-AIDS malignancies, and cardiovascular diseases all are significantly higher when you have a low CD4-CD8 ratio. Going on to viral load, we know that viral load depends on your assay. And now most of the viral loads, they can, the level of detection is about 40 or 20 copies. Older tests had higher copies. And we talk about virological failure when the viral load is more than 200 copies per ml, and that is the definition of virological failure. What is low-level viremia? I don't think we can ignore that. And it is a viral load between 50 and 200 copies. And there is a significant risk of virological failure, 4 to 8 times more than a person who's well suppressed. This is associated with more immune activation and also neurocognitive disorders and the risk of developing drug resistance. So low-level viremia is extremely important for us to understand. What is a viral blip versus a low-level viremia? A viral blip is a single reading between 50 and 200 copies in an otherwise well-suppressed patient. And when repeated 4 to 8 weeks later, the virus is again suppressed. So if it's truly a viral blip, and in these situations, we need to repeat a viral load in about 4 to 8 weeks time. If it's truly a viral blip, really you don't have to do anything, just reassure the patient, ensure adherence. But if there is persistence, you think that this is low-level viremia, and you'll have to really look into resistance testing and see if there's any reasons for this. So this is a well-used graph to depict the natural history of HIV infection. And we know there's an acute phase with a high viremia. It sort of stabilizes at a set point, an asymptomatic phase at which the viral load stabilizes. And then many years later, there's a late phase. This is when people become symptomatic and actually AIDS develop. So interestingly, when you look at this, so this is two different graphs side by side. And this actually shows natural infection of the simian immunodeficiency virus in monkeys. And you can see that everything is the same in the acute phase. But in the chronic phase, there's a stabilization of both the viremia and the CD4 counts. And the CD4 counts don't actually fall. But in a pathogenic infection like HIV, or when this virus infects rhesus monkeys, you can actually see that after a chronic phase, after a period of time, there's an increase in the viremia and there's a reduction in the CD4 count. So there's some difference here between a normal host, a natural host, and a pathogenic host. So in the simian virus, there are high levels of viral replication, but there is no disease and there's minimal CD4 depletion. So something else seems to be driving the CD4 depletion that we're seeing in humans that is not there in the natural host. So this is what happens in the asymptomatic phase. There's a lot of CD4 cell depletion, and a slow decline of CD4 cells is a hallmark of the chronic phase. Okay, so why do CD4 cells, why do they drop? So one is a direct cytopathic effect. There is killing of infected cells by cytotoxic T lymphocytes. Also, there is significant amount of immune activation that causes apoptosis of uninfected cells. So this factor of chronic immune activation, which drives the CD4 cell loss, is what is important for us to understand, because that is what seems to actually drive the loss of CD4 cells. Okay, so CD4 cell depletion correlates very closely with immune activation than viral load. In sooty mangabees with SIV infection, there's actually no immune activation, and so they're able to tolerate very high viral loads without actually developing disease or a reduction in the CD4 count. So another important factor is the microbial translocation, because the gut is where most of the T lymphocytes are and the CD4 T cells are. So the gut microbial translocation, and these are all the factors that actually lead on to this chronic immune activation. So there's microbial translocation, HIV replication itself, and some of the antigens can cause this co-infections, persistent levels of interferon 1 and 2 that are elevated. All of this result in this common chronic immune activation that we see. So exactly what I was saying, gut leakage and microbial translocation, immune activation, and then you have susceptible cells that lead on to this chronic immunodeficiency. So if you look at the systemic inflammatory biomarkers and the time of HIV infection, you can clearly see that with time, your systemic inflammatory markers actually significantly increase. So what does this result in? And we use this term now more and more of inflammaging, which is basically chronic inflammation that results in immunological aging, making the person susceptible to a wide variety of metabolic, cardiovascular, and inflammatory disorders. So what are some of the main ones? We have cardiovascular disease, diabetes, you have renal disease, chronic kidney disease, non-HIV related malignancies, you have neurological disorders like dementia and depression as well. So all of these cause significant morbidity and physical disability as well. So there are a whole host of inflammatory markers that have been looked at, and I just highlighted some of the key ones: interleukin 6, D-dimer, highly sensitive CRP, soluble CD163, and soluble CD14. And these are some of the inflammatory markers that have been implicated in patients to signify that there is a chronic immune activation that seems to be going on. So what does antiretroviral therapy do to all of this? We know that ART significantly reduces viral replication, and because of this, there's a much better outcomes. But however, compared to a non-HIV person, there are still levels of immune activation that are higher than the normal individual. A whole host of agents have been studied looking at this, including steroids, other immunosuppressive agents. Statins have particularly found favor. We know the recent study where pitavastatin is shown to be having significant reduction in cardiovascular morbidities. Chloroquine, hydroxychloroquine, COX-2 inhibitors, aspirin, methotrexate, tocilizumab, which is an IL-6 inhibitor, canakinumab. All of these have been looked at as to whether they will augment or help with this chronic inflammation along with ART. But unfortunately, all the results are inconclusive or contradictory. So none of them have actually been indicated in addition to antiretroviral therapy. So in terms of clinical practice, do we routinely monitor any of these inflammatory parameters? And the answer is it is not recommended. So neither do we check IL-6 or highly sensitive CRP. Should we use any immunomodulatory or inflammatory therapy, anti-inflammatory therapy? The answer is again no. No studies have shown that these are beneficial over and above your antiretroviral therapy. It is recommended to start ART at the earliest, ideally in the acute stage itself, to prevent this from happening. Should we switch antiretroviral drugs? Should we change antiretroviral drugs for the sole reason of tackling this immune activation? And again, the answer, it is not recommended. As long as the person is virally suppressed, there's no indication to change antiretroviral therapy. Okay. The next concept is HIV replication in certain compartments. The CNS compartment and the genital compartment are two of the commonest scenarios that we see. And we know that CNS viral escape is sometimes possible, especially with drugs such as protease inhibitors, such as atazanavir and boosted atazanavir, we see CNS viral escape where the plasma viral load is suppressed, but you have CSF viremia. So I'm just going to sort of wrap up. Okay, so this is my last slide. What do we tell patients in terms of transmission? So transmission purely depends on viral load, and if you're virally suppressed, you know that transmission cannot occur because of we know that U is equal to U. So we can be confident in telling our patients that transmission is unlikely to occur. But what we should understand is viral suppression does not really eliminate long-term non-AIDS related risks. So I don't mean opportunistic infections, but things like cardiovascular disease, non-AIDS related malignancies, renal disease, neurocognitive disorders. All of these are driven by this chronic immune activation and low levels of inflammation. So the patients are not actually normal, but they are at risk for these and they will need monitoring. The CD4 nadir counts are important, as well as what is the current count. We need to keep screening for cardiovascular disease, especially in a country like ours, where we're at high risk for metabolic syndromes, cardiovascular disease. We do need to keep screening for them. At this point in time, we don't have an answer as to how to tackle this chronic low-level immune activation. No screening tests or methods of therapy have actually shown to be benefit, but they do exist and they cause a lot of non-AIDS related morbidity. So I'm going to stop. I'll just leave the slide on. These are the some of the take-home messages, but I won't go through them for lack of time. So these are our two patients. Patient A, we know is near normal immune reconstitution. CD4 CD8 ratio is very good, almost 1.4. Whereas the second patient, even though his CD4 count is good now, he had a very low CD4 nadir and a CD4 CD8 ratio only 0.4, which makes him high risk to develop non-AIDS related malignancies, cardiovascular risk, and neurocognitive disorders. So thank you for your time.
Thank you, Dr. Karthik. I request you to please come and take a chair here. I think as we are running a little late, we'll take questions at the end, considering what time is left over. So that was a wonderful talk, and we are reminded that both CD4 and viral load are not just numbers, but they are dynamic storytellers. The last two slides were so good. We wound up with a very nice take-home message. Even with undetectable viral load, suboptimal CD4 recovery, persistent inflammation, or blips can indicate risks for non-AIDS events, accelerated aging, and comorbidities. So vigilance can guide us towards earlier interventions and better long-term health. I think that was the summary of what Sir wanted to say. And now I have the greatest pleasure to invite Dr. Prapti Gilada. One second, please. Dr. Prapti Gilada from Mumbai, and she is going to tell us what are the red flags and the right tests in advanced HIV disease. A very important topic again. Yes, Dr. Prapti.
HIV disease management with a strong focus on recognizing critical red flags and choosing the right diagnostic tests at the right time. Today, she speaks on red flags and right tests in advanced HIV disease, highlighting when to suspect more and when to test smarter.
Good morning, and thank you for the scientific committee to invite me for this talk. Sorry for. So this was a study that was done in NEGM, which spoke about how advanced HIV is becoming a neglected disease. We are in the era of test and treat, and the focus on CD4 count in some countries is reducing. With our availability of viral load in a lot of setups still matching up, we are still doing CD4s, and it still holds a lot of importance because CD4 counts less than 200 is seen in a lot of population, and the deaths in those population go up to even more than 6 lakhs. Advanced HIV disease is driven more by treatment interruption and by disengagement from care. And this is something that we are seeing in our setups as well, where patients come up with low CD4 counts and they are not actually ART naive. They are patients who have been on ART and have come back to us with treatment interruption. And the limited access to diagnosis of OIs is still a concern in several setups here. So think before we test. The early detection of life-threatening OIs is important. The right sample, the right test is critical because we need to look at tests that have high sensitivity and high specificity. The point of care assays are something that we should prefer because they are going to give us rapid results with great sensitivity with some of the tests that I will take you through. The cost effectiveness and minimal invasiveness is something that we are looking at in all the setups, and they help us guide therapy and improve clinical outcomes. This is a study which shows that what was the most commonest cause of hospitalization in people living with HIV, and it was the AIDS-related conditions, most commonly being tuberculosis, PCP, and cryptococcal, which is something that we have been seeing in our setups as well. And the in-hospital mortality was almost 17%. The common opportunistic infections that we see in India, like everywhere else, is tuberculosis. And the data varies from anywhere between 23% to 60% in some setups. And oral and esophageal candidiasis in a level of 21 to 40%. There's chronic parasitic diarrhea with Cryptosporidium isospora and other bacterial diarrhea that we see. PCP, CNS and toxoplasmosis, and cryptococcal meningitis. Coming to tuberculosis, I'm very sorry for the, there's some mismatch in the slides that I've made, and it's finally the way it's presenting. So challenges in TB diagnosis, we see that there is atypical clinical presentation in TB. The chest X-ray a lot of time is either normal or it is atypical. There's possibacillary disease, especially in in HIV. And the diagnosis of extrapulmonary TB is twice as common in people living with HIV. There is difficulty in obtaining some of these samples, and there is poor sensitivity. We also deal with a lot of non-tuberculous mycobacteria, and it really becomes challenging where we see a tuberculosis picture, but none of our tests really come up with Mycobacterium tuberculosis, and that's the time where we really need to scratch our heads and think of NTM. And a lot of times there is TB in the background along with other co-infections in the same patient. So we need to keep our eyes and ears open. What is the sample that we prefer? It's sputum, and induced sputum even better. Induced sputum has been known to have a much higher yield than just expected sputum. And the extrapulmonary samples for a microbiology laboratory, we would say should come in sterile distilled water or normal saline, so that if needed, we can test it further and not in unsterile containers. What are the diagnostic assays that we have for tuberculosis? The X-ray and CT scans in radiology, detection of mycobacteria directly by sputum smear microscopy and culture. And we have the molecular assays like GeneXpert and LineProbe assay that are now available in most of the setups, and the antigen detection by TB LAMP. The GeneXpert is an excellent platform for extrapulmonary tuberculosis, where we see that the sensitivity for pleural fluids, even though seems low, is still better than a lot of other techniques by which we can actually get tuberculosis in pleural fluids. The Expert MTB RIF Ultra, the new cartridge that has come up, has increased the sensitivity of GeneXpert even more, where we see a 17% increase in the sensitivity. The Expert MTB XDR cartridge is like a game changer, where within 3 to 4 hours, we would have an entire panel ready with us. So we first run the Expert MTB RIF Ultra where we would have whether the tuberculosis is present, not present, and the rifampicin status of the patient. And once we know that if it is rifampicin resistant, we can do a expert XDR test where we would know the other second line drugs and isoniazid within the next 1.5 hours or so. And we have the entire panel at least to initiate the treatment on day 1 for the patient. We always wait back for the culture and we keep a look at the culture in the background, because there will be a lot of times that patients do present with genotypic resistance or genotypic sense, giving not resistant, but they do not respond to therapy. And at that point, our culture does help us really getting back to the phenotypic susceptibility of the test. The lateral flow urine assay, that's the urinary lamb, is something we all talk about, and all of us are still hoping to get this test in India. It's going to be it's a 30-minute assay, no training, no equipment, so it's a rapid urinary flow assay. We don't have this currently available commercially, and I don't think we should be disappointed. We have some other tests as well. So we have the mycobacterial cultures, which can be done on blood and urine. There are special blood culture bottles that are available for blood culture for Mycobacterium tuberculosis. And they have been shown to perform very well on patients with low CD4 count. There have been studies that have been done to compare the sensitivity of urinary lamb with Gene Expert Ultra on urine, and they have been shown to have comparable results. So while we still await TB lamb to come to us, we can use Gene Expert Ultra on the urinary sample in cases where we really suspect tuberculosis and we are not able to get any of the other tests positive. Coming to PCP, the patient will usually present to us with hypoxia with respiratory alkalosis. The gold standard test the gold standard sample remains the bronchoalveolar lavage with staining, that is direct fluorescent antibody staining that is done in some laboratories. The PCR test is what is available most of the times, and it has very high sensitivity. There is the other tests that we look for are the imaging, so X-ray, CT scan. The beta-D glucan in patients with PCP is very high, and it has an excellent negative predictive value. The raised LDH is a wonderful proxy marker for PCP. And like I mentioned, PCR and histopathology, if it is possible for us to actually get a biopsy specimen. If PCR is available, then PCR with beta-D glucan is what we look for. If PCR is unavailable, then we look for microscopy and histopathology. And if both are unavailable, then a lot of times it's mainly clinical diagnosis and radiological. Moving to cryptococcal infections. There are the tests that are available. We have the old time India in preparation, which really is a wonderful test. If we know it's cryptococcal, I mean, if you are suspecting cryptococcal and it comes back to the lab with a CSF sample, it has low sensitivity but excellent specificity. And so the microscopy and culture both have great specificity. Now, what is available to us is the lateral flow assay, which is the cryptococcal antigen test, which has a very, very good sensitivity. Running the cryptococcal antigen test, we have understood that when the cryptococcal antigen test is positive, we are actually detecting way before the patient actually gets the symptoms of meningitis. And it is a very good predictor of patient later on moving probably to cryptococcal meningitis. It is possible to identify early cryptococcal disease and prevent its progression in that case, so we can initiate the required treatment. This is the flowchart that is usually followed, wherein if there's a patient with low CD4 counts and the cryptococcal antigen test is negative, then the ART can be initiated after the other OIs are ruled out. If the test is positive, then we move on to, and if the patient is asymptomatic, then we just treat with fluconazole as the preventive therapy and then initiate ART after 2 weeks. And if the patient tests positive for CRAG, then we would hope that if we can do, we would prefer doing a lumbar puncture and then doing the tests on CSF again. So there is a high, if there are high serum or CSF titers, we know that the outcomes for these patients might be bad. So it is important that we also run the CRAG test along with the titer values, because high, like it's shown here, the high titers leads to higher morbidity and mortality in these patients. Moving to histoplasmosis, the tests that are available for histoplasmosis, most common, what we used to do earlier was culture and histopathology. But blood culture positivity is only about 50%, so it has a low sensitivity, even though the specificity is very high. And the time period required is usually 3 to 6 weeks. Biopsies are preferred over FNAC. There have been times where FNACs have been done and they come out to be negative for histoplasma. And because the patient has not done better with the other treatment, and a biopsy done later on in a point of time has actually shown it to be still histoplasma. So biopsy still remains a better sample than FNAC. The direct visualization of those by the silver staining method. These are all short turnaround time, but they have very low sensitivity. What we now do most of the times is the antigen detection on urine, which is available from a lot of companies now as rapid tests. PCR is a wonderful test, great sensitivity and specificity, but very few laboratories are actually doing tests for histoplasma PCR. Moving to cytomegalovirus, it's the most common presenting feature of CMV would be CMV retinitis, and the patient would come up with a history of blind spots or some difficulty in seeing. And the tests, so the histopathology that we do, it requires confirmation, and we would see the tissue invasion with CMV virus. The CMV antigen test is now largely being replaced by PCR. So PCR are actually the most preferred test. The viral, and whenever we ask for a CMV PCR, we would say that also ask them for a quantitative PCR, because most of the laboratories are actually running a quantitative CMV PCR, even though they might come up with only a qualitative result when we ask for it. Also, when we need to monitor response to therapy, it is preferable to do the CMV PCR in the same laboratory on the same kit, because there have been a lot of differences in the different kits and the standardization of the kits. So it's always better to perform it on the same kit. The serology and viral culture have no significance now. So there is very limited role for serology and viral culture. Coming to toxoplasmosis. Toxoplasmosis is transmitted by the ingestion of oocysts or by the tissue cysts. And most common presenting symptoms is the toxoplasmic encephalitis. There are very, the MRI is has a very classical picture where you would see a multiple ring enhancing lesion. And the toxoplasma IgG would be high, but it also has the toxoplasma antigen antibody here has a very good negative predictive value, because if it's not positive, then we know that we can actually rule out toxoplasma. The CSF PCR has high specificity, but it has a limited sensitivity. So again, we can run it if it's available, but our probability of finding positive would be limited. I just have the last 3-4 slides. Oral esophagitis and candidiasis remains one amongst the common presentations of OI, and it's pretty much clinically that we diagnose these. In some cases where the patient is not responding to antifungals, antifungal culture can be done, and we would be able to give you a susceptibility for those tests. A organism I would like to mention, though we don't see Thalassemiosis that commonly in India, in other regions, it is known to be very common in the Southeast Asia and also the northeast of India, where the patients present with with skin lesions very similar to molluscum contagiosum, and the diagnosis remains on the basis of histopathology and culture. So when a fungal culture comes to us, we see a very typical kind of this Penicillium malafie that grows, and it's easy to grow in the laboratory. My take-home message is advanced HIV disease is still common. We need to screen proactively for patients who have come to us with low CD4 counts. We should keep our eyes and ears open because more often than not, these patients do present with multiple opportunistic infections at the same time. And the right sample for these tests is as important as the right test that we choose. Thank you. That's our team. And thank you so much.
Thank you so much, Dr. Prapti. That was indeed very good to know, and just brought home that despite remarkable scale up in ART, but still the advanced HIV disease. Doctor, please come and take a chair here. Dr. Prapti, may I request you to come on that? So despite that, the advanced HIV disease continues to claim too many lives. And the red flags that Dr. Prapti has pointed out should be our take-home messages. And we must assign the right tests, deploy the right tests to identify these OIs as early as possible to give the patient a better quality of life, a longer life. Thank you, Doctor. And I have the greatest pleasure now to invite Dr. Atul Patel from Ahmedabad. Dr. Atul Patel is going to tell us about beyond viral suppression, when to consider tenofovir sparing ART. This is what we are moving towards now, the new scenario. Thank you, sir. All for you.
Viral suppression, when to consider tenofovir sparing ART, exploring when treatment decisions must go beyond suppression to ensure sustained patient well-being.
Yeah, good morning, and thank you very much for inviting me to speak on my views on like when to use a tenofovir sparing regimen in management of HIV patients. So answer to this question to me is very simple. Like whenever you end up with the tenofovir toxicities, you are going to remove this drug from your ART regimen. And let us understand like what are the toxicities that I am talking about. So I'll take you to the real case vignette. This is case number 1. Like this is a 49 years male, 55 kg weight, and he was diagnosed to have HIV too and taking lopinavir, ritonavir plus tenofovir and lamivudine. He has no comorbidities and he was a tobacco chewer. He complains of progressive worsening bone pains near ankle. After 3 to 4 months, he also get a pain, similar pain into the knee joints. And he received a treatment with hydroxychloroquine and some painkillers without benefit from the treating physicians. So he consulted the orthopedic surgeon, and he has also extensively evaluated with X-rays and the MRIs, and all the investigations were unremarkable except some osteoporosis. And again, he has received some vitamin D supplementation, some change in the NSAIDs, calcium supplementations without benefit. So now the pain progresses and the patient has difficulty in standing and walking and becomes a wheelchair bound. So the treating physician referred this gentleman to the rheumatologist in Mumbai. And rheumatologist sent back these patients to Ahmedabad again to our clinic. So this patient was, so at our clinic, like we started evaluating this patient. Then this patient was taking lopinavir, ritonavir plus tenofovir plus emtricitabine for last 4 years. He do not have any the hepatitis B, C, or the syphilis co-infection. His CD4 count when he came to our clinic was 483, and the HIV2 viral load was undetectable. The patient was unable to stand and walk because of the severe pain, so he came in the wheelchair. The whatever examination that we could do in the wheelchair, like revealed some tenderness over the bony prominence. The systemic examination was unremarkable, and the relevant workup for this patient, the creatinine was 2.1, the random blood sugar was 88, the sodium was 130, potassium was 2.7, calcium was normal, the phosphorus was 1.6, and the urine sugar was 3 plus. Look at this, like random blood sugar was 88, so this patient is having normoglycemic glycosuria plus, proteinuria 2 plus. So again, this patient was, treated with hydration, potassium supplementations, and the phosphorus supplementations. ART was changed to the lopinavir, ritonavir plus dolutegravir because DTG was introduced during that time. And later on, patient was shifted to the abacavir 3TC and the dolutegravir. And this patient had a gradual improvement, creatinine settled to 1.4. The normoglycemic glycosuria improves after 6 weeks. The phosphorus and hypokalemia also normalized during this time. But the clinical improvement, the pain, the discomfort, disability took a longer time, and it took nearly 6 months to recover fully and started walking normally. Let me take you to another case. Again, this is a 55 years male, 62 kg, and this patient was on TLD from ART center for last 2 years. This patient do not have any other comorbidities, just like the case number 1, and this patient do not have any habit also. Again, he presented to our clinic with the pain in both the knees and ankle for last 6 months. The pain is progressive despite the patient is on NSAIDs. Complaints of the pain. Now, when he came to our clinic, he also started getting pain in both the hip for last 2 weeks. And again, he had a similar complaints of difficulty in walking and standing and getting a pain when he stood up. The relevant labs showed albumin 2 plus, urine sugar 2 plus, RBS was 100, phosphorus was very low, potassium was low, calcium, ionized calcium was normal, alkaline phosphatase was 2.5 times upper level of normal, creatinine was 1.34, the CD4 count was 406, and the viral load was 24 copies. So after 2 months of switching this regimen to removing the tenofovir from the regimen, we continued with the dolutegravir and the lamivudine. Patient noticed a 5 kg weight gain, able to walk without discomfort. The phosphorus still low, 2.13 despite supplementations. RBS was 78 and urine sugar was 1 plus. So still he has normoglycemic glycosuria even after the end of the 2 months of the supplementation and removing the toxic drug. But the alkaline phosphatase started declining, and now it is 1.25 times upper level of normal. So why I bring these 2 real cases in my clinical practice, just to understand who are at a risk of getting tenofovir toxicities. And if you look at the literature, you will find that those patients who has a pre-existing renal and the bone disease, they are more likely to get tenofovir related toxicities. The advancing age and the elderly patients, they are also very much susceptible to get tenofovir toxicities. The patient who has a low body weight, less than 50 kg weight, they are also susceptible because there is more tenofovir exposure to the tubular level and produces tenofovir toxicities. The patient who are receiving concomitantly ritonavir, that is the boosted protease inhibitors, because we know that the exposure of the tenofovir at the proximal tubular site will increases when somebody is receiving the CYP3A4 inhibitors like ritonavir or the cobicistate. So the exposure of the tenofovir increases in this group of the patients, and the patient will end up with tenofovir toxicities. Postmenopausal females are also susceptible to get tenofovir toxicities, and the additional risk factors like diabetes, because diabetes is known to produce the renal damage on a longer run time. The prolonged duration of the tenofovir exposures, cardiovascular comorbidities, all these things can contribute to the tenofovir toxicities. The pediatric patients, especially the low body weight patients and receiving boosted PI, they are also susceptible to get tenofovir toxicities. So these are the standard described the host factor where you expect the patients might get tenofovir toxicities. The purpose of presenting 2 cases, they do not have any comorbidities. They are young patients. They are not underweight patients. Despite that, they are getting tenofovir toxicities, except for the first patient where the patient was receiving concomitant ritonavir boosted lopinavir. So that was one risk factor for that patient. So purpose of presenting these two cases is that even though like we can identify a patient who are at a risk of getting tenofovir toxicities, you may get tenofovir toxicities in absence of described risk factors. So this is what is the message to the audience. So both these patients were male, both were young patients. They are not old. They have normal body weight, except one patient who was taking ritonavir boosted protease inhibitors, no additional comorbidities, and the duration of exposure was 2 years for the second patients and 4 years for the first patients. So tenofovir toxicities can occur even in the patient without significant risk factors. Now, in which other conditions that you are going to use a tenofovir sparing regimen? So to answer this, the question like another question that I am going to ask, like why to continue tenofovir when the two drug regimens are equally effective, right? So that is a second thought. So what are the tenofovir sparing ART regimen? Available options are you can go for abacavir plus lamivudine, but you know that like abacavir has been linked very well to the cardiovascular morbidities in HIV infected patients. So because of this increased risk of cardiovascular, we are not going to use abacavir. The older NRTIs like Cytodine, T40, DDI, they are no longer in clinical use because of the severe toxicities. And the another good options would be two drug regimens. So nowadays, like two drug regimens, especially the dolutegravir plus lamivudine is recommended by the guidelines as an initial therapy for the treatment of HIV, provided the viral load is less than 500,000 copies. There is no evidence of hepatitis B infection, and there is no resistance, pre-existing resistance to any of the drug. So if patients satisfy this criteria, you can straight away use tenofovir sparing regimen to treat a treatment-naive HIV infected patients. The other regimens are dolutegravir plus rilpivirine, again recommended by ISUSA guideline for a maintenance therapies, not as a upfront or not as a the primary therapy. So it is recommended for those who are virologically suppressed for at least 6 months. There is no history of previous treatment failure and no evidence of resistance either. And it is not recommended for initial therapy. And there are, we do have several other options for two drug regimens which do not contain tenofovir are darunavir ritonavir plus lamivudine, darunavir ritonavir plus raltegravir, and cabotegravir plus rilpivirine. So this is a very good the summary of the two drug regimens for the in the treatment of HIV in different guidelines. I'm not going to discuss all these things in detail because I mean we do not have that time also. But I mean just to give you an idea that I mean two drug regimens are going to be there in clinical management of HIV infected patients. And these are the clinical data, again, using different regimen, including the DTG or the dolutegravir plus lopinavir plus 3TC or the darunavir plus 3TC and other different regimens. Again, very busy slide. Just to, I mean, highlight the importance of using dolutegravir plus 3TC. And this is a study in the treatment naive patients. Here you can see that in this DOL study, the response rate, this red line is the triple drug therapy and the blue is the double drug therapy. The response rate is almost comparable. So even if you are using 3 drugs versus 2 drugs, and virological non-response rate is also similar in both the groups. So that means that if your patients satisfy the criteria, the 2 drug therapy is adequate for the treatment of naive patients. So what about like patient who has previously failed regimen? We know that like we are treating HIV patients for last more than 30 years. And many of our patients, they have failed first line, either nevirapine or the efavirenz based therapy, or patients have received the atazanavir, ritonavir following the first line failure. So that means very likely that they have accumulated 3TC resistance, that is 184V mutations. So what if your patient has failed previous first line or the second line therapy? And this is again a very important study which says that those patients who has failed first line therapy and patient has accumulated 184P mutations, the response rate is not different compared to the others. So this is the maroon is the 184B mutations in the next generation sequencing in the patient's data. And you can see that the response rate is almost similar, right? So as compared to the patient who do not have any pre-existing 184B or patient with some other mutations. And this is the latest recent publications in clinical infectious disease, looking at 96-week outcome of patient who has 184V mutations. And in this study, like they looked at the proviral DNA just to pick up the patient who has 184V mutations. And you can see that 96-week results is almost same. So message here is that even if your patient has failed your first line therapy, probably you may safely continue with your 2-drug therapy in the treatment of these patients. So 2-drug therapy switch in virological suppressed patient, we have enough data, right? So I'm not going to discuss all this data in detail. So what do I do in my clinical practice? So I generally switch to the 2 drugs to my all high-risk patients who are likely to get tenofovir toxicity. So all the risk factors that we have just discussed. So if any of this is present, I generally switch them to 2-drug regimen. I switch all of my patients who are receiving the first line therapy containing efavirenz plus tenofovir disoproxil fumarate plus amtricitabine to 2-drug regimen proactively before they end up with any toxicities. The patients on 3-drug regimen, which includes either bictegravir or the dolutegravir, I just remove the tenofovir alafenamide or the tenofovir disoproxil fumarate and put them on 2-drug regimen. And even like my patient has failed first line therapy, I switch them to 2-drug regimen. So those patients who are on the second line PI or the second line or the third line BTG based containing therapy, I just switch them and they are maintaining good viral suppressions. So tenofovir sparing regime, like again, when you change to the 2-drug regimen, you have to look for the hepatitis B co-infection. So it is recommended for all the patient who has Hep B co-infection. But when you have a patient who is Hep B co-infected and patient is at a risk of getting tenofovir toxicities or patient has already experienced the tenofovir related side effects, then you can also remove the tenofovir from this prescription and you can add entecavir, right? How to add, what dosage of entecavir to be added? It is again requires a discussion or understanding. It's not that easy. Those patients who has pre-existing lamivudine resistance, you have to increase the dose of entecavir. So these are the some finer aspect, but the HPV co-infected patients, you can also remove tenofovir provided you have an options of adding entecavir. These 2-drug regimens provides an effective viral suppression just similar to the 3-drug combinations therapy. That is what we have started learning and practicing for so many years. So same benefit, same viral suppression that you are going to get with this 2-drug regimen. The reductions in the tenofovir exposure by giving 2-drug regimen significantly reduces the long-term toxicities. This is what is very important to understand, that why to use tenofovir when you are going to get the same results with the 2 drugs. When removing the tenofovir and you are avoiding the toxicities, you are also reducing the cost of therapy, right? And you can recycle or you can use your tenofovir when in future when patient requires it for the treatment of HIV infection. So this is what is very important to understand, that by removing the tenofovir, not only you are removing the one toxic drug, you are also reducing the exposure, you are also reducing the long-term toxicities, you are saving money, and you are keeping your future options open. And the another advantage is that once you remove the tenofovir, there is improvement in the kidney and the bone health, and there is be a higher tolerability. So my perceptions for tenofovir in 2026 is that the morbidities from the tenofovir toxicities is worse. It takes long time to recover. So for 6 months, if your patient is unable to walk, unable to carry out daily activities, it's not good, right? So we need a patient who are healthy, they are working normally. Tenofovir seems to be unnecessary with the current evidence with the 2-drug regimen. So we are not worried about the 184V mutations also, and you are going to preserve the future options for treatment of HIV also. So take home message from this talk: identify your patient at a risk of TDF toxicities, switch them to 2-drug regimen. Switching to the 2-drug is better treatment options as it reduces the exposure, long-term toxicities, saves money, and future options are open. Always screen for Hep B infection. This is very important. I'm again emphasizing the Hep B because I switch 4 patients with Hep B infection, and out of 4, 2 of them have a flare, Hep B flare, with transaminitis and Hep B viral load increases. So I have to again came back to the TDF regimen. The patient at a higher risk of tenofovir toxicities is have been considered entecavir, which is a safer option. And tenofovir regimen ART is for majority of the patients. Thank you very much for the patients listening.
Thank you, Dr. Patel. That was indeed very, very nice. Please take a chair. May I request the organizers to allow a few questions, please? This was so important. While tenofovir is such a stable, highly effective, very accessible and suppressive drug, still we have explored why and when we should try to switch it to the regime of DTG and 3TC and many others which Dr. Saab gave on the screen. So the side effects, important ones, renal toxicity, bone health concerns, bone weight, pregnant women, etc. Please, may we have some questions if organizers permit? Yes, so, sir. Briefly, maybe 2 to 3 questions.
I congratulate Dr. Atul for his excellent presentation. I got only 2 questions. One is, what is the percentage of patients who are receiving tenofovir where he has seen the toxicity? Number 1. Number 2, has he ever seen tenofovir induced SLE? I have seen a patient who has developed SLE. She was 25-year-old girl taking tenofovir and she developed SLE because of tenofovir.
I have never, experienced the tenofovir toxicity presented as a SLE. So, I don't have any experience and I'm not aware about these toxicities. But for first, the question, like how many percentage of the patient receiving tenofovir developing tenofovir toxicities? So percentage could be very less. In my clinical practice, I have yet to analyze. I have not analyzed, but it is not that significant. But the issue is that whenever the patient develops tenofovir toxicities, it carries a very high morbidity and plus mortality also, because some of the patients, they came very late with the end stage renal disease requiring dialysis and other complications related to this. So the message here is that when drug is not required to get a fully suppressed viral load, you have to spare this toxic drug for future use.
And most of the patients who are at that later age, who come with knee joint pain, we attribute it to osteoarthritis. And then we give NSAID, etc.
Same thing happens to these 2 presented.
Exactly.
Any other questions? Yes, ma'am.
I'm Dr. Aishwarma from Andhra Pradesh, Guntur district. Yes, sir, as you said, 2 drug regimen is as effective as 3 drug regimen. Definitely, I also observed many of our patients who are on 2 drug regimen are virally suppressed. But your patients, whether it is on tenofovir alfuramide or tenofovir disopropanol, your patients, whether they are on tenofovir alfuramide also developed toxicity or other drug.
Yeah. So I think both these patients were on disoproxil fumarate. I have a very few patients where the tenofovir alafenamide was initiated to the patients and they have started getting the increase in the creatinine. But again, these patients, they do have additional comorbidities like long-standing diabetes with underlying diabetic nephropathy. So pre-existing condition has led to the increase in the creatinine in alafenamide group, but not per se like these presented cases. So disoproxil fumarate is, I think, more commonly
Actually, that is the drug
observed in my
causes renal toxicity in majority of our cases also. But one patient with tenofovir alfuramide also developed SLE, not developed SLE, I think it is established after starting antiretroviral therapy. And patient developed high serum creatinine, who treated, we avoided tenofovir, but patient not cleared, patient developed knee pains and other things, other related SLE components. So when we tested for SLE was positive, serology was positive. So we avoided. So it can aggravate SLE also, underlying SLE. Asymptomatic SLE also can be aggravated by tenofovir alfuramide.
Yeah, so generally what happens, like those patients who has underlying lupus, because of the immunosuppressions related to the HIV, they may not have the fully manifestations of the SLE. Once you put them on antiretroviral therapy, any regimen, the immune system will come back and patient will start getting manifestation of the SLE. That could be a possibility rather than blaming a drug producing the SLE.
One comment, ma'am.
We'll just take the last comment. I'm sorry, I can see there's a line forming. But just one last comment and then we'll have to move on. Yes, ma'am.
Correct? Okay. Sir, I have seen one patient who gave subsequently, after intolerance to tenofovir, that she already had hypokalemic periodic paralysis some time ago, long back. And she was not tolerating stavudine. And then she was started on TDF. And then she came to our clinic with knee pains and renal dysfunction. So I think renal tubular stenosis is one of the strong contraindications for a patient to start on TDF. Because we as internal medicine, we get to see a lot of these patients and sometimes they need a ART for HIV.
So that was indeed a very interesting topic, and I congratulate the organizers for having selected these 3 subjects to discuss. So we conclude by saying that comprehensive monitoring, vigilant AHT management, and personalized ART selection, if we integrate these 3 into NACO's strong framework, we will be closer to our targets of ending HIV/AIDS. So I thank our visionary organizers, our learned speakers, and our attentive audience for this wonderful session, and I hand over the session to the organizer. Thank you very much, sirs, ma'am.
Thank you very much. We'd like to call upon the chairpersons to felicitate our speakers with mementos.
May I request Dr. Glory and Dr. Gilada to please come up and felicitate our chairpersons, please. Our speakers, I'm sorry.
We would like to announce the tea break now, following which we will reconvene at 11:45.
For those who haven't yet downloaded the web-based app, we'll just put it up on the screen and you can start using that app to interact with the speakers of the dais. And the posters are at the back of the hall, and please find time and have a look at those. Thank you. See you in another 10 minutes.
चालू है।
May I request all the delegates and the faculty to come in the hall so that we can start the post-tea sessions?
Welcome back, delegates and faculty. With this, we will move on to the next session, which is revisiting NNRTIs, and we'll talk about the Doravirin era. I would like to invite Dr. Kumar Sami, who will be moderating this session. Dr. Christina Musini, who is to deliver the keynote, has been unable to travel here, but she will be joining us online from Italy. And the panelists are going to be Dr. Tristan Barber, again, who was unable to join us, but is joining us online, Dr. Atul Patel, Dr. Ishwar Gilada, and Dr. Guha. Over to you, Dr. Kumar.
30 seconds. So welcome back. Good morning, everyone. We are still 4 minutes away from noon. Please get organized quickly because we are a little running short of time. At this time, I'll welcome you all to a special session on the launch of a new molecule in India, Doravirin, which many of you know that, which is a second to third generation NNRTI, which also works against many NNRTI resistant viruses. To discuss more about this molecule, today we have an international speaker from Italy, Christina Misuti. Can you please put her introduction?
Suswagatam, welcome Dr. Christina Massini to ASICON 2026, Mumbai. An internationally respected HIV expert from Italy, she plays a pivotal role in advancing contemporary antiretroviral strategies and integrating newer therapies into clinical practice. Today, she speaks on Doroviral, added value in the current art basket, exploring how this option strengthens and refines modern HIV treatment choices.
So this is a new molecule for India, but it's been approved a couple of years back by the US FDA and been available in the research-rich settings and part of the many developed world guidelines. So today it's time for us to listen to Christina about the new evidence from this molecule. From this, we can discuss on using a wonderful panelists, which you can see them here, for all experienced clinicians from India, to discuss where we can place this molecule, particularly in the setting of lower and middle income countries, especially in India. Christina? Christina couldn't be here, unfortunately, because of these political tensions, but we had a recorded talk from you.
Come due to the also to the international situation. My title is Doravirine Added Value in the Current Art Basket. So these are the last guidelines from European AIDS Society, showing that in addition to the second generation INSTI for starting treatment in naive people with HIV, we also included Doravirine either as a single tablet regimen as tenofovir 3TC and Doravirine, or with TAF, FTC, or tenofovir XTC. You know that I'm the vice chair of the European guidelines section on antiretroviral therapy, and I have to tell you that there was a huge discussion about this because at that time it was not compared with INSTI. Why I'm saying this? Because the trial that has been performed with Doravirine in the registration phase were two, where the drive ahead, where Doravirine 3TC, FTC, 3TC tenofovir was compared to efavirenz FTC tenofovir, and you see that there was non-inferiority. I mean, the two regimens were absolutely comparable with a non-detectable viral load in Doravirine 77.5, in efavirenz 73.6. What emerged immediately was that there were much less CNS side effects in Doravirine than efavirenz, as a better lipid profile with a decrease in non-HDL cholesterol and a decrease in triglyceride. This was continued the observation for 192 weeks, and you see, and the one who were enrolled at the beginning in efavirenz were switched to the open label in open label fashion to Doravirine, and you see that either those who continue Doravirine or those who switch to Doravirine maintain undetectable viral load in a very high percentage of participants, 84.9 and 80.3. The few patients who fail, we are seeing in this slide, a couple of them had resistance at failure. While I said the neuropsychiatric was much better. At the 192 weeks analysis, you see that the effect on the lipids was the same, was really favorable. And especially in those who switch to Doravirine at a certain point, you see while the column became all green but all negative, So there was an important impact on the lipids. We know that efavirenz is not the best on lipids, but so it's not, but it's important to see that there is an important decrease in lipid when switching from efavirenz to doravirine. Also the weight, we had a small increase in weight that was very similar between either the one who started doravirine and efavirenz and the one who switched to doravirine and efavirenz. So after 192 weeks, you see that the weight gain was really a small weight gain, absolutely small weight gain. The other randomized study was the drive forward study, where doravirine was compared to darunavir. And also in this case, we have seen the result at the 92 weeks. We see that there was no difference between the two arms, with 73.1 versus 66 in the darunavir arm. And because there was a high rate of discontinuation, much higher if you see in the darunavir arm compared to the doravirine arm. There was no difference among the different population concerning the possibility to reach an undetectable viral load, while obviously if it was relevant with the efavirenz, it was even more relevant with a boosted PI. We see that the lipid profile was absolutely much better. This is the results in the, as I show you in another, this is the study that was done exactly the same with the drive ahead, so the prolongation F at 192 weeks, and you see that the level of suppression in both arms was very high, was about 81% at 192 weeks. And also the lipid profile was really much better and continued to decrease also along the time, much better obviously in those who switch from the boosted PI. So a good efficacy, virological efficacy, and a very good lipid profile. Also in this, compared to darunavir, we see that there was no difference in weight gain between doravirine and darunavir. You know, from the analysis of the trial conducted by Paul Sachs on the weight gain, that PIs as efavirenz at that time, so NNRTIs were the best in non-weight gain. So I think that it's reassuring that there was no difference among them. There has been also more data obtained in this 192 weeks analysis of those who started and continued doravirine, or those who switch either from efavirenz or from darunavir cobicistat. And what we have seen that there was a decline in eGFR, observing a few weeks from starting doravirine. And this was independent from the use of tenofovir, because you remember that could be either tenofovir or TAF, but because it has been studied, and that it's very similarly to what happened with dolutegravir, we have an inhibition of the organic cation transporter 2, OCT2, so the creatinine stays in the blood, and that's why we have a sort of increase in the eGFR. I said that we didn't have, in the discussion that we had in the antiretroviral panel, was due to the fact that many of my colleagues didn't want to include doravirine because there was not a comparison with the second generation INSTI. So these are the studies that are ongoing now. So there are Opti, Door, and El Dorado. One is from in North America and Europe, and the other one is sponsored by the NRS you see, this one, the first one is conducted in South Africa, sorry, and the second one in France, Brazil, Ivory Coast, Cameroon, Mozambique, Cambodia, and versus dolutegravir, and we will see what they will find. In the meantime, at this CROI, I mean, it has just finished. Jürgen Rockstro showed the data on doravirine, islatravir, that is a new combination that we will have available in I think in 1 year probably, versus BF-TAF, bictegravir, FTC, and TAF. I want to show you the data just to tell you how potent is doravirine, you know, because I don't think that this islatravir is different from tenofovir FTC. Every time that we conduct a study, the results depend also on the population that we have. This is a double blind, so this is very important, study of doravirine islatravir versus BF-TAF. And this is the baseline characteristics. And we see that like 20% in doravirine islatravir versus 14% in BF-TAF had CD4 count below 200, and a viral load that was the median viral load was 53,000. But there was 10% in both arms with more than 500,000 copies. And you see that here the number of suppression, of virologic suppression, were almost 92 with doravirine islatravir, with almost 91 with BF-TAF. I think that this datum is very reassuring for those who didn't believe in a way in this drug, thinking that it was only a switch drug. I can tell you that these data show us that is also a very good option in naive. And this is the paper that has just been published. I said about the naive, we have also data on the switch, and this is the drive shift study. This is the virological outcome at 144. And you see that the level of suppression that has been maintained was very good, very good. So I think that is good not only for naive patients, but also as a switch strategy. And when we look at the weight gain in those who did an immediate switch or delayed switch, was almost, the same. I mean, very, very low impact on weight gain. And I think that this is something that should be kept in mind, while many other drugs like second generation INSTI has been associated with weight gain. So these are the data, but why do we need doravirine in the art bucket? But I think that doravirine, compared to the other NNRTIs, has a much better genotypic barrier to resistance, and this is due also to the level of protein binding that is lower, and this is translating to greater potency against wild type viruses and viruses also with common NNRTI mutation, like the one for efavirenz, for example, the 103, the K103. Not only it is active against resistant virus, but also when you use doravirine, the rate of development of resistance of failure is much lower than for the other NNRTIs. I mean, we know that the genetic barrier of NNRTIs is not the same of boosted PI or of second generation INSTI. But among this class that has a lot of other benefits that I will show you in a moment, we have doravirine is the one with not only active with the in the presence of previous mutation for NNRTIs, for all the generation NNRTIs, but also it develops more slowly the mutation. And what there could be some case in which you could have just one RAM, like Y188L or Y318F, that could be sufficient, that could be enough to determine the resistance to doravirine, but in general, you need at least 5 NNRTI RAMs to reduce susceptibility to doravirine. So very potent and very high resistant barrier. That's why it has been conducted a study on those, and that it was presented at Glasgow, in countries where NNRTIs are probably less used than in your country, so pay attention to this. But they started doravirine without performing the genotype or performing, or having a previous genotype, and you see that there was no difference in having or not a previous genotype in this concerning the maintenance of virologic suppression. But what limits the durability of antiretroviral treatment is the side effects. We have seen that doravirine can have very few side effects. Among these, just a little bit of sleep disturbances or headache that should be asked to the patient if they have it, but nothing about severe like the hepatitis of other NNRTIs or rash. We know that also second generation INSTI have side effects, not only the weight gain that I said, but also, for example, this is a poster that has been presented at CROI 2026, showing that there is an important, a link in a way with the development of the onset of hypertension. And if you look at this, where you see that there is NNRTI MPI in red in this square and second generation INSTI, you see that the incidence of hypertension was much higher in those treated with second generation INSTI. So take into account also the possibility that there is a link with hypertension or that is less known, but it has been linked recently to INSTI. So think about switching the treatment. Tenofovir, we know, doravirine is combined with tenofovir diproxyl fumarate. We know the risk of renal insufficiency or of bone, osteopenia. What we have seen is that when tenofovir diproxyl fumarate is combined with an NNRTI, the level of tenofovir is low. So all these problems with tenofovir were mostly associated to the use of tenofovir in combination with boosted drugs. So this is really important to know, and you see that the level of doravirine, of tenofovir in combination with doravirine compared to the other drugs is low. So, so not surprising, this has been presented last year in the Italian conference, that when we compare doravirine 3TC tenofovir to other association, for example, BF-TAF in this case, the level of I mean, the bone density was very similar between those treated with BF-TAF and those treated with tenofovir 3TC doravirine. You see, there was no difference between the two. So this is very reassuring. And so why? In Italy, this is a study that we have published in the ICONA court. We decide to treat to choose people in art naive to choose doravirine. Usually we start it in a patient who have in people who have a less advanced HIV disease, but maybe sometimes have other fragilities and potential risk factor for comorbidities. So we know that this important, profile, lipid profile, that is much better than with other drugs. It's something that is important with people who are getting old. Also because doravirine do not have any drug-drug interaction, also with statins or whatever, so it is used in also in people with comorbidities. And we have seen that in these patients, for example, in the one published by Leonardo Calza, between those switching to to doravirine or 3TC or BF-TAF, we have seen that there was a better an improvement in insulin resistance in those switch to doravirine. So better lipid profile, the same bone, better insulin resistance, and this is true also in also those who switch, as I said, from from a second generation Rinsti, so from the most recent drug. So as I said, it's very important to profile someone who could have high cardiovascular risk, because doravirine 3TC tenofovir in the study that is the Dorothea study that was presented at Glasgow in 2024 showed that those who switched to doravirine had a decrease in the score 2, that is a systemic coronary risk evaluation. So no surprise that we treat people with who are older than 60, and you see that in switch they maintain absolutely the undetectable viral load. Concerning the weight gain, we know the switching treatment, these are the data of those randomized in the advanced trial, who had this very relevant increase in weight with dolutegravir FTC TAF or dolutegravir tenofovir FTC compared to efavirenz. And when they were switched to dolutegravir 3TC tenofovir, there was a small decrease, but not so relevant. Doravirine has been shown to decrease the adipose tissue, the abdominal adipose tissue, but when it was conducted a randomized study to see if in people who were obese, this is the wrong thing, I think, to randomize people who were obese and not only those who gain weight on INSTI. They were randomized to doravirine TAF FTC or doravirine tenofovir FTC or INSTI, to continue INSTI plus TAF and FTC, and there was no, I mean, all lose some weight, but there was no difference between the arms. I really think that the fact that they were obese really made the difference. So this is something that we have to keep in mind. There should be done some data on people who are just overweight and not obese. I wrote an editorial on doravirine that was published on Lancet HIV on the 192 data, and just explaining why, for me, doravirine could have a place in the sun, in the antiretroviral therapy. And I really think that what I've shown you now shows you that the metabolic profile is much better. It has, the toxicity of tenofovir when it's combined with doravirine is much, much lower. And also we have to consider that the patient have a much lower weight gain. So in conclusion, doravirine is a next generation NNRTI approved for the treatment of HIV. We have seen that it has a unique resistance profile, so it could be used also in patients who have previous resistance to NNRTI. It is dosed once daily, no food requirement, low potential for DDI, favorable PK profile, and I think it's very effective, and especially in a population that is getting old, it should be used more and more frequently due to the good metabolic profile and better, the improvement in insulin resistance. And I thank you for your attention.
Thank you, Christina, wherever you are. Is she online? No. Okay, great. Thank you, Christina. So
thank you to you.
So just to summarize, I know she reviewed. Hi, Christina. So
Hi.
I hope you'll be able to see me. Sorry, you couldn't be with us. We met each other last week. So you said you're very keen to come to Mumbai, but very sorry for all these issues. So Christina, summarize all the old and the new studies on doravirine, which is a second or third generation in an RTI, and clearly walk you through all those indications where it can be, used. Now, currently, it has been recommended for patients who are initiating treatment, and as well as people who are on first-line therapy, which previous no failures were well suppressed, where you can appropriately switch them to these as a regimen, preferably with a tenofovir-based regimen. Right now, tenofovir, lamivudine, and doravirine as a single tablet is being approved by US FDA and been available even in Western countries. And if you look into this data, what she showed, it has got a lot of favorable response to use doravirine, particularly in the context of comorbidities like cardiac disease, hypertension, renal disease, because it can also be used in mild to moderate renal disease based on the data shown, and also favorable lipid profile, and as well as a weight gain as compared to darunavir and efavirenz. Now, you may ask a question, we are all seeing with the integrase inhibitors about the weight gain. Now, what about with this doravirine? Right now they have been, involved in the studies. We need to wait for more data on this. But on the other hand, in a country like India, where we have got so much of non-communicable comorbid conditions in the general community, where in the context of HIV and with the integrase, we are now seeing increasing prevalence of new NCDs in our patient population. In that context, based on the data which is reviewed by Christina, now doravirine might be a preferred choice in our setting. Coming to these second-line therapy, someone who had failed, at this time we don't have any data, so hence not been much discussed on this, but we need to wait for more and more data on this. With this, I'm going to put up some questions on our panelists. So we have got three panelists in person, and we have got one person on all the way from UK. Unfortunately, Tristan Barber, you couldn't be here with us. We apologize that all those. Anyway, it is not in our control. It's beyond our scope. So I'm going to put up some questions, to this panelist, especially in the context of India, where now this molecule doravirine is getting launched, how you'll be using them. I'll start with Atul Patel. Dr. Patel, you gave a wonderful talk about your own views on two-drug therapy and dolutegravir and lamivudine. And here, can you tell about your views on doravirine, especially in your practice, where you use it?
So like looking at the profile of doravirine and the availability of dolutegravir, which is very cheap and highly effective, like even in a patient who has previously failed the first line and second line regimen, the DTG is very active. So, I mean, I don't see that, doravirine can be a major drugs for the clinicians in the India, but for a few patients, and these patients are really very few. So one of my patients like recently diagnosed last week, and the weight was 110 kg. So I just discussed with the pros and cons of available antiretroviral and the newly launched doravirine. And that patient, like educated guy, so he opted for the doravirine. So this is only one situation where I have initiated doravirine therapy where the baseline weight was 110 kg. So I just explained that there is a chance that you may have additional weight gain when I put you on the INSTI inhibitors.
So at this time, you're saying that people who have got a risk factors to develop, you may consider doravirine, at this stage. Now moving to Christian, Dr. Barber, you use this a lot, in UK and as well as part of your guidelines. Can you tell us to our Indian physicians how you are using this drug, in your settings?
Thank you for the question. I mean, I think we are mainly using doravirine in people who do not tolerate integrase inhibitors, so people with neuropsychiatric side effects, for example. I'm a little bit cautious about the weight story. Because of the Do It trial. I appreciate Professor Massini's points about the fact that they only included people who are living with obesity. But I think there's something about weight we still don't fully understand. And my suspicion is that there is a toxicity of TDF that limits normal weight gain. And so I still worry that when we talk about weight and we think about introducing regimens that might counteract the weight gain that some people experience, particularly on the combination of tenofovir alafenamide with the second generation INSTI, are we reintroducing a toxicity that as yet we don't understand? Of course, patients like it if they don't gain weight, but I think there's something there about that story that we still need to be a little bit cautious about. I think the other thing I'm cautious about, there is mounting data from real world evidence that of course we can use doravirine in people with non-nucleoside resistance. And we have studies also looking at switches from etravirine where people have been given a non-nucleoside with resistance mutations. But I think it's very important to remember there is not really very good, well-powered, of course it's difficult to find people with resistance to go into well-powered clinical trials to look at the efficacy of this agent in people with NNRTI mutations. But nonetheless, I think we need to remember that this is all very much cohort evidence, cohort data. We don't have very good randomized clinical trial evidence that this can be used safely in people with certainly with extensive NNRTI mutations. So I think a little bit of caution around the resistance story, but we are seeing, as we just heard, very good outcomes of using this agent with, for instance, dolutegravir in people who previously might have had complicated regimens or experienced virologic failure. So I think it's an interesting one. It's got a role. I still very firmly believe in people who tolerate them, that integrase inhibitors should be core of most people's regimens, but we know that some people don't tolerate INSTIs, and I think doravirine does offer us an option for those individuals.
Thank you, Dr. Barber. At this time, I'll turn to Dr. Guha, who is chair of our TRG for NACO and helped to set up our national guidelines. Can you tell us, if at all doravirine is going to be available in your program? I'm sure it will be available one day soon. Where you will consider?
At the moment, Kanga Khepkar shared the programmatic data this morning. Around 98% people who are on DTG-based regimen, they are virally suppressed. So I don't think probably this is the time we can go for shifting all DTG-based patients to doravirine. But then again, personally, what I feel...
But they also should be healthy on a long run, right? Without any cardiovascular morbidities and so on and so forth.
Absolutely. All those things need to be taken into consideration. And what I feel that for naive patients, definitely doravirine can be another option. But we need to wait for that clinical trials that's trying between DTG versus doravirine in two settings, low-income group countries as well as in industrialist countries.
So you will consider at this time on certain populations,
yes,
on who have got toxicities,
definitely.
And also you'll wait for the dolutegravir hits-on data for introducing in the big programs. So moving to Dr. Gilada, you see variety of patients, right? Your own fancy patients, celebrity patients, patients moving from with no money from the government ERT center to see a clinician like you. You drive them with variety of medications. So where do you place in your practice?
See, if you look at the theme of the conference, adding life 2 years. So you first decide goal and first decide set of people. The goal is initially it was increasing CD4 count, decreasing viral load, keeping it virally suppressed. But when the people are surviving for 20 years, 30 years, and then getting diabetes, I personally consider diabetes and HIV. If God comes to you that I'm happy with you, in one hand I have diabetes, in other hand you have HIV, take one. I'll take HIV, not diabetes. Number two, there are two sets of people who are working in the field of HIV. Those who have been there for 20, 30 years, they have come, patients have come, they were dying, give us 5 years. Then they said, I want to see my child getting married. Now they come and they want to see their grandchild getting married. As a doctor, my duty is to see that you can see the grandchild's marriage also. And that is possible. So basically, in the program is totally in such a way that mechanical, that even a counselor can give medicine, anybody can give medicine. If 10 to 20% people are getting diabetes, I think there's a wide scope where this can be used. And coming to DDD, earlier D40 was there, DDI was there, one knocked down. Then 2DD came, DTG and DRV, very good drug. The third D is also going to be very good. So you have to keep an open eye, and then we see that where it can be fit in. But at least we have started some people yet to know the results, but yeah, they are currently safe.
Yeah, I think this is a message from the real life physician who works with our people. Our patients HIV live with us, because they never die, but on the other hand, comorbid conditions, make them, to be morbid, where it is up to us. I will make sure that they are not being bound to one of those comorbidities. I think there's a way doravirine can rescue them, based on the data which is presented by Christina. Christina, before we close this panel, do you have any last minute comments, what you missed in your presentation or based on whatever, we spoke here, you want to make to the crowd?
Yeah, I just want to say that we have, since it was the launch, I stayed on the data, and especially because at CROI there has been the comparison with the second generation INSTI, and I think that this was very important because the rate of suppression of the two registrational trial were not impressive, while the result of this last trial were very, very impressive. But I have to say that we have a lot of experience with doravirine. We have accumulated a lot of experience with doravirine in all these years that we have it available. And among the different patients, I think that it's very important to include doravirine also in the treatment of experienced patients who have experienced people with HIV who have resistance, because it could be combined with dolutegravir. We have some experience with a combination named DODO, that it means dolutegravir, doravirine, on the basis always of the genotype. So don't stay directly on the, on naive and just a switch, simple switch, but it's a very flexible, it's a very flexible drug, and it could be used either in a very experienced patient, very resistant patient, but also as in naive. So I think that you will see that it's not, as everybody said, a second generation INSTI, so the numbers will be different, but you will find a lot of people where it can be used.
Thank you, Christina. I think we heard from the experts who have done the trials. We heard from guideline makers for the Europe and as well as for UK, and as well as from the key clinicians from a personal experience of handling patients for 20 odd years, what could be the best drug on a long run, and as well as from the guidelines maker for NACO, where they can place it in future and also benefits of the current therapy. With this, I'll make 2 or 3 concluding remarks. I think this drug, doravirine, which is a powerful NNRTI as compared to the earlier one on nevirapine and efavirenz, works against the resistant viruses based on the data we saw. It can be a perfect choice for initiating treatment, even particularly in a country like India, where we have got a lot of comorbid conditions. But on the other hand, it is not recommended along with the TB medications. We don't have data at this time on rifampicin and doravirine. Based on preclinical data, I think it cannot be combined because of the drug interactions. And as well as we do not have good data on the safety in pregnancy at this time. There are studies underway, especially registration trials and registry studies, where we may get some, data at this time. But on the other hand, there are patients who now don't have TB, who are not intending to become pregnant, who have got a lot of comorbid conditions, like a lot of weight gain, even before initiating on treatment, who have got previous cardiovascular disease and diabetes, as said by Dr. Gilada, and who has got also have a high altered lipid profile initiating treatment, where this drug can be considered. We don't need to say that TLD is an, superstar. It's always a superstar. Sometimes superstar can also slip down somewhere, where we are seeing now increasing data on comorbid conditions on a long run. So at this time, we need to, discuss more and more on how we are going to place. Based on the available data, it can be a good option, especially particularly country like India, even to initiate treatment, but not in TB patients, as well as in, in pregnancy. With this, I'll thank my panel members for giving your wonderful, views, and as well as our speakers, Dr. Christina and Dr. Barbara, from all the way, speaking from your situations, and unfortunately couldn't be here. Thank you so much. At this time, I'd like to invite the manufacturers of this Doraver in India, that is MCure Pharmaceuticals. They have been launching this drug as a name called Hofix, as 100 milligrams, which has been recommended by the US FDA. At this time, to come a few words before we wind this session.
Thanks, Dr. Kumarasamy, sir. I'm Dr. Sachin Suryanshi, and I'm heading the medical affairs at MCure Pharmaceuticals. Thank you, organizers, for this association. We are really privileged and proud to be part of this great conference, ASICON. We at MCure are committed to continuously bring in newer molecules, innovative molecules for the better outcomes for the people with HIV in India. Doraver, which is the next generation NNRPI, is a part of such an endeavor. We also continuously, as you are aware, we are continuously working with the global innovators to bring in newer and innovative molecules to India as a monotherapy or in combination. I thank Dr. Kumarasamy, sir, also for guiding us. He has been the guiding light for us, for selecting the molecules also, and having the representation to the authorities, so that the right molecules are selected for the people with HIV in the country. Thank you so much. Over to Dr. Kumarasamy, sir, unless Mr. Balaji has to say something.
Yeah, this is Balaji from MCure Pharmaceuticals. Thank you, ASICON, for giving us this platform. It so happens that whenever MCure comes up with a new product, there is an ASICON conference around the corner. And we have used this platform to bring this product or introduce this product to our dear doctors. Now, that was a very interesting discussions about what Doraverin can do in your armamentarium. But going back to giving you some snapshots on where this all started, we have some deep, MCure as a company has deep inroads into the HIV hotbed, that is the African countries. And when we were interacting with the AIDS control program on these African countries, we were confronted with a request of what next. I mean, they have been using the conventional standard of care medicines, but there was an unmet need to address issues like comorbidities and metabolic challenges. So that was the time when we started scanning what are the products in the pipeline. And it so happened that both the DHHS guidelines and the European AIDS Clinical Societies were talking about this product called Doraverin. And then when we approached the innovators, they were very happy to give us the license because of our long-standing relationship with MSD. They not only gave us the license, they also gave us
the technology transfer to manufacture this product right from the basic stage, that is the raw materials, and going forward, developing the tablets. Now, having received all these things, when our scientists actually started working, there were certain challenges in developing this product. This product required additional investments in terms of what you call a flame-proof area, reactors, top sprays, and a few other things. Looking into the product profile, we decided that we will go ahead with this for the simple reason that this product offered itself to certain unique combinations, including tenofovir sparing combinations and possibly certain other two-drug combinations which could come out in the future. So this has been the developmental story of doravirine at MCure. And as far as what it does to the patient, I think you have listened to the experts, and the test of the pudding is in the eating. Thank you once again, Dr. Gilada and ASICON, for giving us this platform. And you can count upon MCure to be in the forefront to launch more interesting combinations and new generation molecules. Thank you, sir.
Thank you, Mr. Balaji and Dr. Sachin. As we heard that there are several in pipeline, I think thank you very much for bringing such molecules. And because of that confidence only, we are able to organize such rich conference to update and upgrade our clinicians' knowledge. With this, thank you so much for your participation. We didn't take any questions. Maybe we can have some interaction during the break. And someone asked me, through WhatsApp, what's the cost? At this time, I do not know. So you can speak with the company representatives in their booth, so they'll be happy to assist with this. Thank you so much, and thanks all the panelists.
Can we just take a group picture with Christina and Tristan?
Sure. Hold on, Dr. Babar and Dr. Christina. We're taking a picture.
Thank you, Christina and Tristan, for joining us.
Ah,
We hope to see you next year.
Thank you so much. I hope so as well.
Kisses.
Bye.
With
Ciao,
that, we move
bye-bye.
on to the inaugural ceremony, and just give us 2 minutes while we set the dais, and we'll move on to the inaugural ceremony in a few minutes.
Good afternoon, ladies and gentlemen, and all the delegates. It is my absolute honor and privilege to welcome you all to the 17th National AIDS Conference, ASICON 2026, organized by the AIDS Society of India. Today, we gather not only to celebrate progress in the field of HIV/AIDS, but also to reaffirm our commitment to ending this epidemic through science, collaboration, and unwavering dedication. HIV has been a disease where an infectious disease where we have come a long way from being a death sentence many decades ago to a chronically manageable disease, from the drugs which had so much toxicities that both the patients and the doctors would have nightmares, to a bouquet and a basket of drugs that we have been discussing today, multiple options, single tablet, uh, and we have come a long way. And we have to thank all the giants in the field of HIV who have been working from the beginning, who had challenged the status quo, the challenged the stigma, and a patient have now become from stigma and living a life with dignity. So we have come a long way in HIV. So for this inauguration ceremony, we have an esteemed panel of dignitaries with us today, and it is my great pleasure to invite them all into the dais. May I request the dignitaries to join the dais as I call the name. The following distinguished guests to please take their seats on the dais. First, Dr. Glory Alexander, President of ASI. Dr. Ishwar Gilada, President Emeritus of ASI and ASICON. Our guest of honor, our chief guest, Dr. Mr. Bhushan Gagrani, Mumbai Municipal Commissioner. He is not here, but he will join us at 8 p.m. due to ongoing assembly sessions. May I request our chief guest, our guest of honor, Padma Shri, Dr. Raman Gangakhedkar sir, distinguished professor, Symbiosis International Institute, Pune. May I also request our guest of honor, Dr. Vinay Garg sir, Deputy Commissioner for Central TB Division, Government of India. Dr. Vinay Garg. May I request Dr. Naval Chandra, Secretary General of ASI, to come on the dais. May I request Dr. N. Kumarasamy, Vice President of ASI. Ladies and gentlemen, let's welcome them with a grand round of applause for all of these dignitaries and esteemed. To set the stage for today's proceedings, it is my honor to invite Dr. Glory Alexander, President of ASI, to deliver the welcome note. Over to you, ma'am.
Dr. Vinay Garg, Deputy Commissioner of Central TB Division, Government of India. Dr. Raman Gangakhedkar, Padma Shri, and a well-known person at our AIDS Society of India. Dr. Gilada, President Emeritus of ASI. Dr. Kumaraswamy, Vice President of ASI. Dr. Naval Chandra, Secretary General of ASI. Delegates, participants of this conference, as well as other distinguished members who are in the audience. Good afternoon and welcome to this 17th ASICON being held at Mumbai. The AIDS Society of India, as you all know, is the country's largest professional body, professional not-for-profit membership association of doctors and researchers who are focused on HIV/AIDS care. And we focus, the three main areas of our focus is clinical management, education, and advocacy. We conduct a lot of events through the year. We try to do as many seminars, webinars, CMEs as possible, but this is our flagship event where we conduct the annual AIDS conference every year in different parts of the country. This year, we also published a newsletter, and we hope that we'll be able to do that every 6 months. It gives me great pleasure to welcome all of you to this conference, and we've already passed half the day has gone, and I'm sure you enjoyed all the topics that we had scheduled, and that there was a lot of interaction, a lot of interest, and a lot of new material to be learned. So we welcome all of you again, and I hope you enjoy the rest of this conference. Thank you.
Thank you, ma'am, for the welcome address. Now we move to the felicitations. We are in Mumbai, Maharashtra, land of great saints, and I would begin with a line from a abhang of Sant Jnaneshwar that "Ivlese rope lavle dari त्याचा वेलू गेला गगनावरी." So we for felicitating, instead of conventional method, conventional mementos, what we are giving is something that grows, a rope that is a sampling that will grow higher. So we expect in clinical also that our knowledge will nurture and it grows. So may I request Dr. Glory Alexander may I request Dr. Naval Chandra to felicitate Dr. Raman Gangakirkar. May I request Dr. Kumar Swami to felicitate Dr. Vinay Garg. As we embark on this meaningful event, let us illuminate our path with wisdom and knowledge. I request our dignitaries on the dais to join in the lighting the ceremonial lamp. Buddha once said, thousands of candles can be lighted from a single candle, and the life of the candle will not be shortened. Knowledge never decreases by being shared. May this light symbolize our collective mission in fight against AIDS, HIV/AIDS. May I request all the dignitaries to move for lighting of the lamp. Thank you, all the dignitaries. May I request Dr. Ishwar Gilada, sir, President Emeritus of ASI, to address on public-private partnership and role of ASI. Over to you, sir.
Thank you very much. The sapling which you see for ASI, it was grown or it was sampled in 2000, and we have crossed the silver jubilee of ASI. We started first conference in 2005, that was in Delhi, and thereafter we moved south-north. But when we realized that whenever we go to north for the conference, our conference is not well attended, because the HIV work in the private sector, which we want to connect, it is in the in 4 or 5 states in the south: Maharashtra, Karnataka, Andhra Pradesh, Telangana, now divided, Tamil Nadu. So therefore, more conferences are here, but still we go to north. We had been to Delhi just 2 years before. Now coming to public-private partnership, we all know that there is no bigger charity than government. No one can compete with government. Only we can complement government. I worked in state government of Maharashtra for 10 years. Thereafter, I was advising central government with the government of India as a health department between 86 to 88 as a joint secretary of National Health Committee and couple of states. So I understand the strength and weakness of both these sides. And therefore, since beginning, when we started organizing ASI conferences, it was never ever only for the members of ASI or those who are in the private practice. From the first day till today, we have been partnering with NACO. We are partnering with the Central TB Division. We are partnering with UNAIDS and WHO. This time WHO could not make it. We know all over the world that there's one factor which is dismantling lot of work, and therefore WHO or UNAIDS may not be seen after a year or so. So they are all under problem. When I was growing up, I always used to pray God and say, God, give me crisis. Because man come up in crisis. God give me crisis and staying to come up with the crisis. But God listened to many of my prayers and gave a lot of crises at a time. What are the crises at a time now? There's a war going on in the Middle East. A lot of people could not come. Even Christina went back from Amsterdam. Barber could not come because he was getting a flight to come to India, but not from India to back. So I think there were a lot of crises. Today, there is an assembly session and budget session in assembly. Chief Minister was to come, he could not make it. Deputy Chief Minister will come tomorrow. There's a parliament session going on in Delhi from 9. And there has been some issues where Speaker of the Parliament who accepted could not come. Municipal Commissioner is so nice. Yesterday morning, 4:40, he sent a message that either I can come early morning or late evening because there is a session in the assembly. So I said, come in the late evening. He's coming today evening. So with this, we put together MDAX, MSAX. I would like to tell NACO people or TB HIV department that we learn a lot of things from TB. And a lot of things when we learn from TB, for example, the 3-in-1 combination, 4-in-1 combination medicine, this all we learn from TB and practice in HIV. So similarly, public-private partnership has to be learned from TB department. I'll tell you a simple example. The most expensive drugs like bedaquiline, delaminate, which are costing in private market like 1.5 lakh a month, we can get free of charge. And they have done a public-private partnership where they don't want anything. Okay, you are in private sector, you have a collaboration with us, we'll provide you everything, we'll provide you in the kind of a test for monitoring, do it. And this is going on for 5-6 years. With HIV, we wanted to have similar system. For 5-6 years, we are discussing. We are willing to walk a couple of miles extra, couple of steps extra. Even we walk 10 steps, you walk 1 step, fine. But there must be public-private partnership in real sense. And this PPP is not only PPP, it is PPP. Practitioners are there, pharma companies are there, patients are there, all they are 3P. So unless until we collaborate with all Ps, we cannot succeed in this. So wherever you see 80% of the last mile connectivity for first 95, that is because we are not connecting the dots. And unless until your 80 goes to 95, your other 95 will be weaker because the 95 are of 95% of 80. So that further steps will be weaker. So with this, I would like to once again request all the agencies, whether in government or private, pharmaceutical or patients or anybody, we must collaborate. And war is not going to end. That war may end, but this war is not going to end. This war has a up, down. Again, for last 8-10 years, we started seeing new HIV cases coming up. Incidence is increasing. New STIs are coming up. STIs are going up. And this generation Y and generation Z, they have not seen the high-profile campaign which used to be there 10-15 years before. They were growing up at that time. And now they are landing up with the problem. So unless until we have a good PPP, we cannot progress and we cannot have that goal of 95, 95, 95 or 95, 95, 99, which we discussed. Thank you very much.
Thank you, Gilada sir, for highlighting the very importance of private-public partnership where together we can make a difference. Moving on, may I request Dr. Raman Gangakhedkar sir to guide us and give us some pearls of wisdom.
Good afternoon, everybody. I know you're waiting for lunch. I think I have become a complete accidental man all over. No? I began my career in HIV with first of the case that I saw in Valsad, Mota Vakchipa, when I went for a sickle cell disease survey. No, sir, more than survey, it was an intervention. Community-based cohort was there, which I had established. I saw the first case. Then I met, that was an accidental thing. I had almost forgotten after some time. Then I met, my boss had asked me to establish HIV in IIH then, Institute of Immunohematology. Then I met Gilada on Churchgate Station, where he was with full throttle. No, he was trying to educate people. And then he said, why don't you join our group? No? Later, accidentally, I was transferred to Nari. So at that time, when I was transferred, I had the largest cohort of most well-studied HIV-infected individuals in Bombay those days. Probably it was close to 100 odd people by then. Every investigation was done because my lab was also very strong. I ended up being transferred to National AIDS Research Institute, another accident. I never wanted to, Gilada is witness to that. I never wanted to go to Pune because I thought it's a Maharashtrian culture, very conservative. Nothing will come out of staying there. Then I ended up with ICMR headquarters, which I had never thought, no, because I was only a HIV guy. I ended up handling all infectious diseases there at that time. When it came to Padma Shri was also an accident because my patients, the sex workers, the Hijra population, MSM, their associations, they said, we want to apply. And my principle was I will never apply to any award any time in my life, and I don't. I got Padma Shri, I first laughed at them. I said, this cannot happen because I don't have any pulls. I don't interact with people in that manner. Why are you doing this? They said, you have gifted us life in HIV in India. Today morning, I started with this thing that yesterday, this is cricket time, that today I ended up giving a keynote address just because somebody did not come. No, that was also an accident. But this is perhaps the first time you will see that Duckworth-Lewis rule, those who know cricket, I started with, I had a tiff with Dr. Gilada, whether it is T15 or T20, 20 minutes talk or 15 minutes talk. I thought it was 15 minutes and was very happy to say yes. But it was my mistake. But I have never seen Duckworth-Lewis actually adding hours to staying on the stage for nothing, no? Just an accident. What do I feel? I have been associated with ASICON since inception. We have the best of the opportunity. If you actually see, we represent the core of those who provide HIV-related care to people in India. Somebody was saying all these guys are older because we are faithful to our own work. Though our hair have become gray, we continue to work in the field of HIV. Those birds who flock are perhaps still flying. We have to attract them. To me, this is one opportunity for we to learn, gain knowledge, understand policies, move around, because basically, as Dr. Gilada said, government in health is going to be strong and stronger, whether it comes to quality or low quality, whatever people might say. Eventually, we are moving towards insurance-based model. If you actually look at how the recent policies are, whereby perhaps things will happen in a different manner than we are imagining as of now. This is our opportunity to show leadership, ensure that those who could be interested in the field, you mentor them so that you will ensure that the right kind of care is given till death to HIV infected individuals who are going to live as long as all of us. What is most important, which perhaps I thought is something which I will speak and leave at that, we have to think about ASICON becoming the infectious disease kind of a conference. The sole reason is we have worked very closely, not only in private sector, but with also the public sector. Now, given that this is something which is unusual, no, we have huge experiences as to what works and what doesn't work in the field. We are perhaps going to be torchbearers who will eliminate this particular disease by 2030, a disease which doesn't have a vaccine, doesn't have a cure, but still we will be able to do it. You are going to be the most fortunate viral disease specialists who will be able to do it, see it, and experience the same. We have to ask one question to ourselves. Can we not move strongly, take these experiences ahead? You have an open canvas because the spectrum of diseases that you cover under HIV are too huge. Perhaps it is opportunity that you lead even other national programs as strongly as we are doing together for NACO. NACO has been very receptive. We have made the difference. Earlier predictions have all proved wrong when it comes to India because of good governance, the flexibility shown, and the evidence-based strategies that NACO followed. I think it is time we should reflect strongly and move. Perhaps we may add other diseases to the mandate, and together let us try and make a difference and ensure that the true transitional health model, we will go towards non-communicable diseases, which would become more common in India rather than infectious diseases. Thank you for the opportunity.
Thank you, Ganga Kedkar sir, for this excellent address about all the past as well as guiding us into the future. And as sir said, it is not just the HIV, but the other infections, and we cannot work in silo. So may I request Dr. Vinay Garg, who is Deputy Commissioner of our Central TB Division, Government of India, to address us.
Thank you. Thank you so much. I thank Dr. Gilada and his team for inviting me here. This is my first exposure, honestly, to the ASICON and the activities here. And this has been till now a very enriching experience. I get to know what are the nitty-gritties or what are the challenges faced by the treating physicians. Probably also how we can also learn from those experiences. As a government functionary, I, through this forum, want to assure that government is not competing, government is not regulating. We are here to learn from you, to share experiences, and how best those solutions which you practically see in the field can be imbibed in the government. Our role is to make policy which is patient-centric. Of the all three P's which Gilada sir mentioned, I believe the most important P is the patient. And we are all working towards that.
integration part with the private practitioners, coordinations, policy frameworks, bi-directional screening, etc. These things are in place. But we must understand, as in clinical practice, you keep evolving, we are also evolving. We learn from you, we try to imbibe the things which we are doing, say outdated or incorrect, we try to correct them, we make it a policy, and then try to do best what we can do in the limited resources. So forums like these are very, very important, are a learning experience for this side also. So my heartiest congratulations, sir, and best wishes. I'll continue to be part of this say knowledge extravaganza, and I learn, and I assure that the learnings which I take here will definitely be reflected somewhere during the government deliberations, and we'll try to make best of it. Thank you so much.
Thank you very much, sir. And it was great learning from all these dignitaries who are stalwarts in their field. All good things must come to an end, but not without gratitude. So I invite Dr. Trupti Gilada, local chair and scientific co-chair for ASICON 2026, to deliver the vote of thanks. Over to you, Trupti.
Respected dignitaries on the dais, our distinguished guests, colleagues, and dear friends, on behalf of the Organizing Committee and AIDS Society of India, it is my absolute privilege to deliver the vote of thanks for this inaugural ceremony. We are deeply grateful to our guests of honors, Dr. Ganga Khedkar and Dr. Vinay Garg. And we are really grateful for having this lovely audience right before lunch. All your leadership and commitment towards strengthening the collective fight is really appreciated. We sincerely thank Dr. Ishwar Gilada, Dr. Glory Alexander, Dr. Naval Chandra, and Dr. Kumar Sami for the visionary leadership, and both for the organization and really setting the tone for this conference. I wish to acknowledge the faculty and delegates who've traveled from far, those who also couldn't make it. And we really hope this is a conference that you really enjoy. The formal vote of thanks for the rest of the conference will happen tomorrow. So please join us for lunch. And thank you so much for being here. We plan to meet back by 1:50. Yeah. Can we just all stand for the national anthem?
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
जय The lunch for the faculty is in the Romanos, which is on the right side. The lunch for everyone is at the patio attached outside. And just quick 2-3 things, housekeeping. If you haven't started using the web-based app yet, please do start using it in the lunch break. The posters are out there. The restrooms are on the right. And for those delegates who haven't picked up their conference kit, please pick it up. It's a lovely bag that we really hope to take out to the community with a very strong message of U is equal to you. Thank you. See you soon. 150.
For the speakers for the post lunch session, we request you to kindly upload your presentations with the team, as so that we do not spend any time once we start at after lunch.
Good afternoon, everyone. Welcome back from lunch. We'll be starting with our next session titled TB HIV Closing the Gaps in Care. We'd like to welcome our chairpersons on stage, Dr. Girish Rajadhaksh from Mumbai and Dr. Uday Kumar Jadhav from Aurangabad. We will hand over the proceedings to the chairpersons.
So, very good afternoon, everybody. Today in this afternoon session, it's my pleasure to welcome you to the important session of TB and HIV, closing the gaps in care. The interaction between tuberculosis and HIV, it represents one of the most challenging syndemics in modern medicine. TB continues to be the leading cause of death among people living with HIV worldwide, reminding us that despite of the major advances in diagnostics, therapy, and public health programs, significant gaps in care still remain. In countries like India, where both infections intersect with social determinants, health systems, and access to care, the need for integrated TB-HIV strategies becomes even more critical. As clinicians, program managers, and researchers, our responsibility is not only to treat, but also to bridge these gaps between policy, practice, and patient outcomes. In today's session, we bring together distinguished experts who will guide us to different aspects of this complex interface. I would like to welcome Dr. Vinay Garg from Central TB Division for policy to practice operationalizing integrated HIV and TB care. Dr. Vinay Garg.
Suswagatam, welcome Dr. Vinay Garg from the Central TB Division to ASICON 2026, Mumbai. A key contributor to India's national tuberculosis response, he plays an important role in strengthening TB-HIV collaborative strategies and translating public health policy into effective program implementation. His work focuses on integrating HIV and TB services to improve patient care and strengthen national health outcomes. Today, he speaks on From Policy to Practice, operationalizing integrated HIV-TB care.
Thank you so much. So, post-lunch drowsiness, try to be as brief and as interesting as possible. So, as I was talking in my previous little interaction with you, we as government functionaries have always tried to interact and coordinate and work with the people who are working in the periphery. It's a learning experience for all of us. We learn from you how to formulate policies better, and maybe probably the guidelines which we form through the collective wisdom with the private practitioners or the experts in various medical faculties, be it diagnostics, treatment, surveillance, etc. We try to bring on board the people who are working in periphery for a common goal. So the talk today, which I've been assigned, is policy to practice, operationalizing integrated TB care. So, like Sir said, that it is the dual epidemic or the syndemic we are living in. And needless to say that TB is one of the biggest cause of mortality among PLHIVs. And it was for me enlightening to hear in the previous sessions that now NCDs is competing with tuberculosis, and it is also causing a significant damage to the people living with HIV. Now probably we'll have to make a three-pronged strategy wherein NCDs, which we are independently also working with, and HIV and TB working together for the common good or the better care of the PLHIVs living in our country. So these are the numbers I believe you would be quite aware of, that we have incidents or the cases which we found have increased in number, but HIV-TB incidence has reduced to some extent. And the mortality similarly has, although the cases have increased on tuberculosis side, the TB-HIV mortality has reduced quite a bit. So as our all discussions previously have been going on, comorbidities like HIV or diabetes or any other renal function immunocompromise, they weaken the immune system, and tuberculosis being an opportunist bacteria, whenever our immune system falls, so they progress to a disease. So the disease, occurrence of disease in an HIV positive person or a comorbid person or any person having any other immunity limiting disease is significantly higher to develop active tuberculosis compared to a normal population. So these things are obviously likely to lead a poor treatment outcome even if we catch them early. So their response to treatment, monitoring, etc., they remain impaired. So the program side, I would say that we have evolved from being only being a data collector to a few more things wherein we promote, and to some extent in the government system, we have established a bidirectional screening. In the later part of my talk, I would come upon how we can expand this to other sectors, other players in the care system, and what is it meant for us and for them. Diagnostic, as Dr. Gilada was also saying, that in tuberculosis now we have a very significant presence across the country wherein we are bringing in molecular tests free of cost to the government of India. They are available till periphery and upfront. We are doing it. We have done away with completely. We are not saying now microscopy. We are restricting only for follow-up cases, because viable bacteria only will present if in microscopy during the course of treatment. Then we can monitor it better. So diagnostics, integrated treatment protocols, TPT, TB preventive therapy, not only for PLHIVs, but all. My talk would be slightly bent towards tuberculosis, I'm being a TB guy. So TPT is one of the core areas which we are, say, promoting usage in all susceptible, vulnerable populations. HIV is being significant proportion of those, and monitoring systems, needless to say. So during our formal policy development things, we have 3 I's we have been focusing on: the intensified case finding activities, initiation of TB preventive therapy, and control of TB infection in healthcare settings. So wherever private practitioners or the private hospitals or the government, wherever, be it PLHIV, be it not PLHIVs, we promote that airborne infection control practices are put in place. Similar would be my request towards our colleagues who are treating HIV patients. As such, they have weakened immune systems. We shall be doing them good if we have such practices. So these have been incorporated in our policy. So certain aspects of maybe that can be taken towards the other sector also. So my focus or my point of joining here or coming here was to unlock the potential of these activities through private practitioners. I believe a significant proportion of attendees today are working in private sector. So at each step of whatever they are doing, I would just enumerate a few things. I am not as knowledgeable as you in treating patients, but I know how systems can integrate and which can function and help both the government, private sector, and in that interaction, help the patient. So our practicing colleagues hold the key to our success. 70% of individuals seek care in private sector. All it is known to us, be it TB, be it sore throat, be anything. So their involvement is critical in achieving NTB targets. Now that we have aligned with SDG goals, whatever number, whatever year, whatever target we set ourselves for, we cannot reach there till we have our privately practicing colleagues on board. So we, through the program, call for action through whatever activities you are doing in your day-to-day practice, monitoring, clinical, etc., etc. So first is early detection through routine screening. So all of those who are closely, say, monitoring what TB department or what we are issuing the guidelines or requesting people to do is, now we have expanded from 4S to 10S symptoms. So by that, we are trying to catch extrapulmonary cases which do not have a classical presentation of sputum, cough, chest pain, hemoptysis. And the occurrence of EPTB is much more in real HIV. So we have expanded from 4S to 10S to include any, say, ascites, any back pain indicative of spinal TB, or a lymph node, or pleural effusion, or any other such condition which might not be classically looking as tuberculosis in pulmonary terms. But my request would be, whenever you are seeing a patient, whatsoever frequency you are following them up with, just keep an eye on 10 symptoms, which I'll come on later on, whether any of these symptoms are there. Just keep an eye, try to interact with us. If possible, we'll offer all support regarding diagnostics and treatment. So referral, if you send us a sample, we are happy to take that. If you send us a patient, we're happy to take a sample and examine that. So it is up to you. How do you want to interact with us? Private practitioners, retain your patient, because patient has first of all come to you with some faith, and that faith matters most. So the way of interaction may be chosen by the private practitioners, how they want to interact with us. Our private service provider agreement, there are certain interfaces for tuberculosis program which we have created. So by which our field functionaries, they are interacting with private practitioners for TB cases. But while they are interacting with private practitioners for TB cases, specifically people who are treating HIV, they can also take their support for getting diagnostic services from the system free of cost. So now this is Bombay numbers I try to extract. So we have so many machines, TrueNat, CBNat, district centers. So even now, handheld X-rays we are deploying in the field for asymptomatics. Your patient pool who is asymptomatic, at least get an annual X-ray done. So I understand that whatever condition pulmonary they might be coming with, you would be taking an X-ray. In case you are not taking and the patient is not able to afford much, you can refer that patient to us. We'll get an X-ray. If you want us to get a sample done, we'll get a sample done, provided there is a suspicion of having a tuberculosis, or even not, the annual X-ray, at least one, we should. So after you have diagnosed, this program offers free of cost treatment. We will not ask your patient to come to us. We can give the entire medicines, entire fixed drug combinations, etc., to your clinic, and you can yourself administer those drugs, monitor the side effects, monitor the efficacy, monitor the adherence. If at all you need our help, we are more than happy. So, but the government cannot function in isolation. To make policies, to facilitate procurements, to create systems for better implementation, we need data. So we have a system called Nikshay. So those practitioners who come forth and are receptive of interaction with us for TB cases, we give them a login ID and password, and they can by themselves enroll their patients in us and in our system, which has a small monetary incentive also. Like for notification, we give 500 rupees. For completion of treatment, will be another 500 rupees, which I understand is not much, but that money can be used to facilitate a person who is working under you. So you might not yourself be doing it, but you can little outsource it and facilitate that part of getting an enrollment. Nowadays, this is a regulatory requirement. This will serve both ways. You will not be having a non-compliance. Second, good to patient. Third, a little monitoring. And fifth, and the foremost, the most important thing is having a dialogue wherein different stakeholders. I believe there would be certain NGO representatives, some partner agencies, private practitioners are also obviously there. Government side, I can see a few people. So we keep on interacting, giving our feedback, taking feedbacks, how we can improve. We are more than receptive. Tell us that this thing works, it is logical, we'll try to incorporate it. These four are, they are our eyes and ears. So how can we make our policies better? So, but the first thing is there should be a willingness to come on board. So this is a summary of whatever I said. Diagnostics we can offer free, drugs we can offer free. And the third thing which I would like to offer is, being a private practitioner, you might not be able to put in that many resources if your patient defaults. The schedule to come after 3 weeks does not come. How would you monitor? Maybe you have some mechanism, but we have a full system down there, which we call as public health action, by which we can, if you notify us, you inform us, we can make a home visit and try to bring back the patient to care. Screen, enroll, Usenet, treat, take drugs from us, initiate on TPT who are not showing any active TB disease, bring to the notification of the system. Yesterday, I was visiting a few areas of Mumbai and I found a very good private-public partnership examples here. There are doctors who are running MDR clinics here, outsourced. There are agencies which are collecting sputum. There are agencies which are doing follow-ups. So these agencies are really an example of a good interface between the system and the practice. That's all. Thank you.
Thank you, Dr. Garg, for this insightful highlighting all the policies to translate into some practice workup. Thank you, sir.
Thank you. Any questions if I can take? Yeah.
Questions will be asked after.
Thank you.
So please join. As clinicians, one of the biggest practical challenges we face is managing drug-resistant tuberculosis in patients living with HIV. To address this critical issue, I would invite Dr. Trupti Gilada from Mumbai, who will speak on navigating MDR-TB in HIV.
Suswagatam, welcome Dr. Trupti Gilada to ASICON 2026, Mumbai. A leading clinician from Mumbai, she plays a pivotal role in managing complex HIV-TB co-infections, particularly multi-drug resistant TB in people living with HIV. Today, she speaks on new TB drugs, old problems, navigating MDR-TB in HIV.
Thank you for that. I probably looked that way probably 15, 20 years ago. So thanks to AI also. So thank you so much, Dr. Vinay Garg, for setting the stage and discussing managing two troubles together. That's MDR, TB, and HIV. A lot of what I'm going to speak, of course, comes from a lot of data, but also things that we've seen in our clinic, where we are one of the clinics for MDR, TB under the public-private partnership. So this is the outline. We'll see how big the problem is. Some new definitions and classifications that have evolved over the last 5 to 6 years. Challenges in diagnosis, management, and some important concerns. So we've seen these numbers time again, where we know that MDR TB is twice as common in a person who's living with HIV. And the mortality, even with effective ART, is twice as high. Now, a lot of this mortality is actually attributed to undiagnosed TB, which really is the highlight, is that we really need to be quick in diagnosing TB in these individuals. And if you see, of course, we are number one across, whether it's TB, MDR TB, or TB HIV. And as we speak, we sit in the hotbed of MDR TB, which is Maharashtra and Mumbai. Unfortunately, even in the MDR TB, our numbers or percentage of pre-XDR is over 50 to 60%. So when did these definitions really change? And 6-7 years ago, the entire classification of ATT changed. And if you see, WHO placed, of course, based on a lot of data, and the most effective drugs for MDR TB were classified as Group A, which is bedaquiline, linezolid, and fluoroquinolone. Group B was cycloserine and clofazimine, and everything else that we had learned or we give is in Group C, which means when we are designing a regimen, we need to include as many drugs as we can from Group A and Group B. And pretty much that helps us in really understanding what pre-XDR or XDR TB is. So, first we were only talking about TB, and now we talk about monoresistant TB, rifampicin-resistant TB. MDR TB, like I said, once we have fluoroquinolone resistance added to that MDR, it becomes pre-XDR TB, and we are seeing more and more cases of pre-XDR TB amongst that. And unfortunately, we've also started seeing XDR TB just because linezolid is used so rampantly at family physician level over the counter. And that's the reason why we're also starting to see XDR TB as well. Now, in an HIV infected individual, we would, where is the MDR TB coming from? Is it primary drug resistance? Is it being acquired as MDR TB? Or is there secondary drug resistance? Which means the person has acquired a sensitive TB, and over a period of some process, it is becoming MDR. So primary drug resistance is, of course, we are in Mumbai. It doesn't take too much to acquire an MDR TB here. And the secondary drug resistance has been attributed to rifampicin levels being low because of ART, or just so many pills and therefore a poor adherence or malabsorption. Several studies over decades have shown that even though we know that these are the two ways of acquiring drug resistance, the prime way of drug resistance or MDR TB in HIV individuals continues to be primary drug resistance. So the odds ratio is almost 2.8 compared to secondary MDR, where it's just about 1.08, which means that our patients are actually starting with an MDR TB, and therefore it becomes all the more important to really diagnose whether it's MDR TB right at diagnosis, rather than even wait to see if, what it evolves to be. So we'll see what are the concerns. There are diagnostic challenges. And then once we start ART and what treatment we will start. But before that, we'll just see what evolved in the treatment of TB as well. So we've seen this before, that just because of being HIV, there is atypical presentation both clinically and on radiology, and that adds to the complexity. Also, extrapulmonary disease is much more common, which means sometimes getting a sample, especially in a public health system, can become very challenging. And while we might use surrogate markers and sometimes we are forced to give empiric therapy, we need to keep in the back of the mind that if we are giving empiric ATT, even if we are certain this is TB, this might be MDR TB. We've seen this time and again of the different things that we have, but what I wanted to point out to you here is that in this setting, rapid testing becomes very crucial. And what do we have for rapid testing? It's mainly the molecular assays, whether it's CBNAT, line probe assay. We are now moving closer to targeted sequencing and home genome sequencing, where at one go, we will know the entire genome and which drugs are going to be susceptible and which are going to be resistant. TB-LAM, we are hoping it should be available to us this year. At least it will tell us in individuals which are with low CD4 count, whether we are dealing with disseminated TB and do we really need to go and keep hunting and find some way that we can get a sample. But what I also wanted to point out is that artificial intelligence in radiology is really helping. We've started using a program with very high sensitivity and specificity where we've been able to pick up at least 25% additional cases of TB that would have otherwise been missed because they were just not symptomatic. And when we talk about genotype phenotypic correlation, it's very reassuring that at least for rifampicin and isoniazid, the correlation is high, which means if we've seen on genotypic testing that it's resistant, we know it's resistant, while that might not be so good for the other drugs. And for bedaquiline, delamanid, and clofazimine, we are still learning because we haven't seen that many samples to even make a correlation between what we are seeing genotypically and phenotypically. There are different reasons, even in clinical practice, of why we might see a discrepancy in the genotypic and phenotypic reports. You know, sometimes the phenotypic DST is missing resistance just because the MGIT critical concentrations might miss low-level resistance. So the key takeaway point is while the genotypic predicts resistance earlier, we really need to validate it with a phenotype as and when it becomes available, and also the clinical improvement that we see in the individuals. So coming quickly now to our challenge. We have BPAL-M, which is great because it's a 6-month regimen, 3 or 4 drugs, very high cure rates. It's been with us for internationally for quite some time in the guidelines. It's a molecule that started its journey way back in 2012. But now in 2024, the end of 2024, India has finally introduced BPAL-M for the eligible MDR, DRTB patients. So these were based on 2 large studies that were in one issue of NEJM 2022, blockbuster issue, where TB Practical and the Zenex study, I'll show you what this showed was. What was good was that even in this study, which included MDR TB patients, 30% of these patients were with HIV. And what they saw was the unfavorable outcome in the BPAL-M was 11% as compared to almost 50% in the standard of care. And even when you look at the safety, it was a very safe regimen. And all this was regardless of CD4 count, even when they did a subgroup analysis, which means now in our population with HIV and MDR-TB, we really can rely on these reports. What Zenex trial did was really help us with bringing down the toxicity of linezolid, because they tested linezolid at different doses and they found that even with decreasing doses, the efficacy remained the same, but the toxicity really came down. And again, this study had 20% HIV infected individuals. So this also applies to our population. And we have data from India as well, where they studied it across 3 arms, where they gave 600 milligrams across the 6 months, 600 milligrams for 9 weeks, and then switched to half a dose. And that's 600 milligrams for 13 weeks and then switch to half a dose. And if you see the efficacy across all groups is the same, but of course the peripheral neuropathy really came down by half. So that is what went into our guideline, which went out in November 2024, where we are giving 9 weeks of 600 milligrams of linezolid and then going down to half a dose of linezolid for the rest of the 6 months. So this is something that we've all seen. What I only wanted to point out is that once we see the rifampicin resistance is not detected, we must keep in mind that there could be isoniazid monoresistance. So we still look out for the first line LPA or the XDR panel, which is now available. And if it is a rifampicin resistant TB, then of course we have different options of either going on to a longer duration bedaquiline based therapy versus a BPAL-M, which is 6 months. I'm not going into the details of this because this itself is a very lengthy process. But for the isoniazid monoresistance, if you remember the first table that we saw, we would move on to the next best drug. So the next best drug is a fluoroquinolone. If we don't have fluoroquinolone, then we move on to linezolid. And if not linezolid, then of course we will have to go to the other drugs. The reason why we will not include bedaquiline when it's isoniazid monoresistance is because we really want to retain the rifampicin. And bedaquiline and rifampicin cannot be used together. It really brings down the levels of bedaquiline. So if it's an isoniazid monoresistant TB, we will be using still a rifampicin-based therapy, but replacing the other drugs. When we talk about drug-drug interaction in terms of ART, thankfully, with the most commonly used regimen, which is TLD, the BPAL, BPAL-M, or the longer bedaquiline-based regimens work just fine. The problem with bedaquiline is with efavirenz. So we've anyway moved away from efavirenz, we moved to dolutegravir, so that isn't a problem. Other than that one bedaquiline efavirenz side effect or interaction, there isn't anything major to really worry about. Of course, we need to keep in mind that linezolid, we've seen QT prolongation with bedaquiline delamanid, but it's never been a major problem. It's observed, but it's manageable. We've very rarely have to really withdraw drugs for that side effect. But one thing that we really need to monitor is the linezolid myelosuppression and peripheral neuropathy. Very, very important is while we are managing the TB to ensure that the viral load is suppressed, because there is enough evidence that a viral load which is either detectable or was never suppressed. So someone who was suppressed and rebound, or someone who was never suppressed, there is a higher mortality risk. There is a higher risk of failure for MDR-TB. And of course, if someone is not suppressed, which means someone is not taking the treatment properly, also means that there is a higher risk of loss to follow-up. So it's extremely important to keep both those diseases under check while they are in our care. When is the right time to initiate ART? And this applies not just to MDR-TB, but TB in general. And 3 major studies really guided our understanding of when is the right time: the SAPIT, Camellia, and the STRIDE. What I will try to point out is that in the SAPIT study, which all these 3 studies were done in CD4 less than 200, they were all randomized to receiving ART earlier, which is within 2 to 12 weeks, rather than deferred. What's in the SAPIT study, there was a 56% risk reduction when ART was started earlier. But interestingly, in those with MDR, TB, and HIV, the reduction in mortality was even more. And of course, the Camellia and the STRIDE study showed just the same. This went into the guidelines, and now all guidelines, including the WHO guidelines, talk about early ART initiation. And that's true for across TB. In someone with CD4 of less than 50, we want to do it even earlier. So we really want to be able to start within 2 weeks. In someone above 50, sometimes we really wait for another few weeks, but in CNS TB, definitely for 8 weeks. When we are talking about starting ART, and especially at low CD4s, we need to keep in mind that the risk of iris is going to be even higher. And whether it's paradoxical iris or it's unmasking TB iris, the challenge is just the same. You know, it'll be seen pretty much in the first 2 to 3 months, much more common in someone who started on ART or TB with a low CD4 baseline, a low hemoglobin or low weight, and especially if it's disseminated TB or extrapulmonary TB. The treatment is prednisolone. There was a PredMed trial which showed that starting low-dose prednisolone for the first 4 weeks really brought down the mortality. But if we are giving empiric AKT and we have suspicion in the background that this might be MDR-TB, that's the time when we should definitely not use steroids until we are certain that we are not dealing with MDR-TB. Very quickly in LTBI, not forgetting that TB prophylaxis is important in those with in our setting especially. WHO has said that in resource-limited settings and high TB burden countries, everyone receives isoniazid prophylaxis therapy irrespective of their CD4 count. What's interesting is that there is growing evidence that even in MDR-TB or preventing MDR-TB, IPT has found to be significantly help in reduction in the incidence, even in MDR-TB. So that's very reassuring. These are the drugs that we use for TB prophylaxis in MDR-TB, where someone with MDR-TB with FQ susceptibility in a contact, we will go for levofloxacin. So my last few slides, in fact, that's my last slide. So to conclude, early diagnosis is key, especially in this population because the mortality is so high and we really need to depend on our genotypic assays. We have the bedaquiline-based regimen with us, so that's really changed the whole management of MDR-TB. Please keep the household contacts on prophylaxis and make sure that we screen them because it's not uncommon for us to pick up a TB in the household contacts in a year or two. HIV-TB, avoid efavirenz with bedaquiline. Please counsel against drug adherence, and we have to continue our collective efforts to prevent MDR-TB. And most importantly, it's a double hit to our patient. A lot of stigma begins from the caregivers, but if we do our job well, I think it goes a long way for our patients. So thank you so much.
Thank you, Dr. Gilada, for your wonderful session. Drug resistance certainly adds another layer of complexity in managing co-infected patients. But while treatment challenges still remain significant, the future of TB control lies increasing prevention innovation. Right now, we are going to explore the exciting developments by Dr. Koikilam Naidu from South Africa. She will speak on dawn of a new era in TB prevention, innovative therapy and vaccines. This will be an online session.
Suswagatam, welcome Dr. Kogi Naidu to ASICON 2026, Mumbai. An internationally renowned expert from South Africa, she plays a pivotal role in advancing TB prevention research, innovative therapies, and vaccine strategies. Today, she speaks on dawn of a new era in TB prevention, innovative therapy and vaccines.
A very good afternoon. To the organizers and distinguished guests and the chairs of the session. I am going to walk you through for the next 20 minutes on the new era in tuberculosis prevention, specifically the innovative TB preventive therapies and vaccines that are available. My talk will cover a few points. I will start off by giving you an outline about why we need TB prevention. We'll then look at what we have in our existing tools with regards to TB prevention strategies and the preventative therapy that's available for drug-sensitive and drug-resistant TB. We'll then go on to explore the emerging approaches to TB prevention, including the TB vaccine landscape, and I'll end with a few concluding points. Tuberculosis remains the top infectious killer worldwide. It was usurped for a year or two by COVID-19, but it very quickly resumed its place as the leading cause of death from an infectious agent. Every year, more than 10 million people fall sick and become ill with tuberculosis, and that numbers remain constant, over 10 million since 2021. Over the last 15 years, we've seen a 12% reduction in new TB cases being notified. Each year, approximately 1.2 million deaths occur from tuberculosis. Again, the numbers dying from TB have been well over 1 million, despite effective prevention, treatment, and even cure that's available. We have seen approximately 29% reduction in TB deaths over the last 10 years. Drug-resistant TB is an additional public health crisis, with only 2 out of every 5 individuals diagnosed with drug-resistant TB accessing treatment. Globally, 8 countries account for about 2/3 of the TB burden. India has the unfortunate privilege of being number 1 in the global burden of TB in the world, harboring 1 in 4 newly diagnosed TB patients in the year 2024. And that status existed even in the years before 2024. So these data I present to you come from the Global TB Report published in 2025. You can see the co-occurring burden of both HIV and TB. So this conference has a strong focus on HIV, but we can't do anything about HIV if we don't also focus our attention on tuberculosis. Indonesia and China follow India also with high numbers of people with tuberculosis and also high rates of HIV co-infection. So are we on track to ending the global TB epidemic by 2035? The NTB strategy targets and the SDGs, the Sustainable Development Goals, have asked us to reduce TB incidence to more than 95%, to more than 90%, and to reduce TB mortality by about 95%, with zero catastrophic costs by families affected by TB. If you follow the red line, that's the current trend of new TB case reports based on the existing tools that we have deployed. That's about 1.5% reduction per year. And that's about 1,000-fold greater than the desired elimination threshold. If you follow the solid blue line on my graph, you could see what happens when we have more effective tools available to combat TB. So if we do better at preventing therapy using the available treatment strategies for managing TB infection, we think we can achieve a reduction of about 10% per annum by the year 2025. However, if we introduce innovative new tools like point-of-care tests for TB, vaccines to prevent TB disease, new drugs and treatment regimen for both treatment and prevention of TB, we will probably get to the desired reduction of about 17% lower TB incidence per annum. So there's a lot of room for improvement and a lot of room for the addition of novel, innovative diagnostics and therapeutic strategies. Currently, the WHO recommends a TPT regimen for drug-resistant and drug-susceptible TB. There's various strategies that you could see listed in my table, from 6 months of INH, isoniazid, 3 months of isoniazid and rifapentine, 3 months of isoniazid and rifampicin, 4 months of rifampicin, 1 month of isoniazid and rifapentine, a co-formulated drug that has isoniazid, cotrimoxazole, and pyridoxine, which is vitamin B6, and 6 months of levofloxacin, specifically for the prevention of household contacts from acquiring drug-resistant TB. Child-friendly rifapentine options are not universally available. So many of these options that I put forward to you is not really available for specific age groups. Among people living with HIV, there are several options that are currently available on this table, and the choice will depend on the ART regimen that the patient is taking, as well as the drug interactions between the rifapentine or the rifampicin with the ART. As you know, rifapentine is a potent inducer of cytochrome P450 in the liver and will wipe out your integrase strand transfer inhibitors by more than 60% of plasma concentration. So we need to look out for the PK studies that will be emerging that tells us that it is safe to co-administer rifapentine with your integrase strand transfer inhibitors, or what the appropriate dosing strategy would be. But of course, among HIV uninfected individuals, there are various options available that both include as well as don't include rifapentine. So what are the novel approaches for TB prevention? I'm presenting this paper because I don't think that we pay enough attention to the outcomes of this clinical trial and how it guides us in terms of programmatic use of TB preventive therapy. So this WHIP-3 TB randomized controlled trial assessed weekly high-dose isoniazid and rifapentine that's given just weekly, once off over 3 months for 1 year in one group, or given annually over 2 years for the second group, compared to daily isoniazid given for 6 months among over 4,000 people living with HIV that came from 3 separate sites in sub-Saharan Africa. The endpoints that the authors were looking for is incidence of active TB over 24 months and the completion rates of tuberculosis preventive therapy. I share 2 graphs that's in front of you. Graph A shows the effects of a single round once off of rifapentine and isoniazid versus a repeat done annually over 2 years. And you can see the incidence of TB was exactly the same. So there was no impact of the repeat in year 2 of isoniazid and rifapentine. Graph B shows you mortality of a single versus a repeat round of 3 months of isoniazid and rifapentine. Again, no difference in mortality between the 2 groups. So what this basically tells us that repeat annual administration over a 24-month period is not required because the 3 months therapy confers adequate protection to participants. It conferred adequate protection to participants in the trial that lasted over 24 months. The one other finding from the study was that the rates of TB preventative therapy differed amongst those that took isoniazid and rifapentine, where it exceeded 90%, compared to 50% amongst those that took isoniazid therapy only for 6 months. So not only was it safe in protecting against TB incidence, it also had very high treatment completion rates. So the uptake was good programmatically. Of course, many settings have already incorporated the findings of this trial, the brief TB trial, into their program and their guidelines, but I thought it's such an important trial that it's worth mentioning. The brief TB study was conducted by the Division of AIDS, a phase 3 randomized controlled trial that compared the efficacy and safety of 1 month only of isoniazid and rifapentine. And this was compared to 9 months of isoniazid only in 3,000 people living with HIV that were followed up for more than 3 years. The endpoint was death or active TB diagnosis. And when you look at the 3 graphs that's presented in front of you, you can see that the 1 month versus the 3 months, so one's a dotted red line and one's a solid blue line. The 9 months is the dotted red line. That the incidence of death or active TB was exactly the same. So patients in the 1 month group did as well as those in the 9 month group. And when you looked at active TB or death in those with CD4 less than 50 in the graph in the middle, or in those with CD4 counts above 50, the graph at the end, you see no difference in the rates of outcome. So what this is telling us that there were similar rates in the 1 HP, patients were no worse off than taking 9 months of prevention, that the adverse event rates were similar across the group, and of course the completion rates for the 3 HP was 97% in this trial compared to those that took INH, where the completion rates were at 90%. I'm now moving on to the strategy trials, the emerging evidence on preventing drug-resistant TB among high-risk household contacts. And so there's 2 trials that I'm going to walk us through. The first is the VQuin trial conducted in Vietnam, a double-blind randomized control trial that utilized in the intervention arm weight-based levofloxacin. Almost 4,000 patients of all age groups that were high-risk household contacts of individuals, index patients with bacteriologically confirmed RIF-resistant TB, were randomized to receive 6 months of daily levofloxacin. And the endpoint was measured over 30 months, looking for bacteriologically confirmed TB amongst those that participated in the trial. What they found is that there was the rates of TB incidence was 0.6 in the levo group versus 1.1 in the placebo, with a risk reduction of about 45% that was not statistically significant, that those in the levofloxacin group had higher rates of adverse events, notably musculoskeletal events, and there were no acquired fluoroquinolone resistance. And they concluded that levofloxacin may lower TB incidence without any major safety concern, warranting a pooled analysis with other trials. The next trial was one that was done in South Africa, specifically among children under 5 years, irrespective of HIV status, and a few children above the age of 5, specifically those living with HIV. This also was a double-blind cluster randomized trial assessing safety and efficacy of levofloxacin in about 1,000 children, where levo was given for 24 weeks. So it was slightly shorter in duration. And the endpoint of incident TB, including death from TB, was measured by week 48. So it was a shorter time to an endpoint. It was week 30 in the VQuin trial. And here they found that 1.1% versus 2.6% developed TB. Again, not statistically significant. Higher rates of grade 3 or more AEs in the levofloxacin group. The conclusion from this paper is that levofloxacin reduced MDR TB incidence in household contexts. The children exposed to an index patient was well tolerated. Subsequently, a meta-analysis, which was a planned meta-analysis done in consultation with the VQuin and TB Champ science, the leaders of both clinical trials, looking at pooled analyses of both patient populations, looking at a confirmed outcome by 54 weeks, so it's a shorter endpoint, and looking at 2 different statistical methods to pool the data and conduct the analysis on impact on levofloxacin on reducing TB incidence. So they use Cox regression and a Bayesian analysis to make their conclusions. So here about 3,000 household contexts participated in this meta-analysis. Again, levo versus placebo, and they looked at efficacy as well as safety. And what they found was that 6 months of levo reduced TB risk by 60% over a 1-year period, and that it was statistically significant, that there were an increase in adverse events, but not significant. It was mainly musculoskeletal events, and the protection conferred by levofloxacin was restricted only to the 6 months treatment period and didn't really extend in the subsequent 6 months after the treatment period. So that was interesting, unlike the findings we've seen with the brief TB trial. But this data was sufficient for WHO to change guidelines, where now the recommendation from the WHO that came through last year was that levofloxacin is now recommended as a TB prevention therapy for MDR TB contexts, especially children and people living with HIV. And this is a strong recommendation with a moderate certainty of evidence. So many countries have taken up these evidence into their guidelines, and it's now becoming standard of care in various settings. In addition, the additional points that have been made is that preventive therapy is the regimen now can be tailored to the drug resistance profile of the source case. For example, if the index patient has fluoroquinolone resistance, then you would not use fluoroquinolone preventive therapy. And the emphasis is now on getting early susceptibility testing of the index case to guide the management of their contacts. No story of TB prevention is complete without a mention of the Bhagrawat trial, which for me gives us what we've all believed in intuitively, that TB is a disease of poverty, and if we do enough to feed populations, then it will help reduce the burden of TB. So this cluster randomized trial in more than 10,000 household contacts of about 2,800 microbiologically confirmed TB patients was conducted in India, where the intervention group received food rations and micronutrients for 6 months for drug-sensitive TB and for 12 months for drug-resistant TB, with extension under special circumstances. So it was about just over 5,000 in the intervention group and just under 5,000 in the control group, where the primary outcome was new episodes of TB, so all forms of incident TB in the household context over the 2 years of follow-up. And they showed a dramatic 40% reduction in all forms of TB in the intervention group. And when they looked specifically at the reduction amongst microbiologically confirmed TB, there was a 48% reduction. And so what it's telling us is that nutritional support for household contacts of index patients significantly reduce TB incidence. That when an index patient has TB, it's telling you about household vulnerability, and we need to do more for the households that the patient that is exposed to the patient for us to make a significant dent on new TB case notification. The other strategy that also showed enormous potential is this community-wide screening for TB. Again, the study was conducted in Vietnam as a cluster trial between 2014 and 2018, where sub-communes, so a commune is 1,000 residents of more than 15 years, were the individual cluster units. And here they had 120 sub-communes that were assigned to either intervention or control. The intervention consisted of annual sputum screening using a nucleic acid amplification test every year over 3 years, regardless of the presence of symptoms. And the outcome was the prevalence of microbiologically confirmed TB measured in year 4. And this study showed a 44% reduction in TB prevalence. So they went in every year and measured that community for TB. And in the 4th year, they looked at the prevalence of TB. So in year 4, they found a 44% reduction. and showing that the annual community-wide screening in a TB endemic area was just more effective than passive case detection alone. So, telling us that we need to put in a lot of effort in order to reduce TB incidence and take strategies into the community if we want to make a difference. I'm now going to talk to you about the few TB vaccine candidates that are showing a promise for the prevention of TB disease. There are approximately 8 candidate vaccines that are rapidly progressing in phase 2B and phase 3 clinical trials. The orange studies, the studies in the orange boxes under phase 3 consist of live attenuated mycobacterial whole antigen or MTB, just MTB antigens. The red is the inactivated TB vaccines, and the blue are your protein adjuvanted vaccines, right? So they are the 3 main classes of vaccines that are now progressing into phase 2 and phase 3 clinical trials. 2025 gave us data on 2 landmark studies that paved the way for the future. The first is that the use of BCG revaccination for the prevention of TB infection showed no protective effect. So in a study of 1,800 adolescents that received BCG revaccination to prevent sustained QFT conversion, which is a marker of new TB or sustained TB infection, there was no effect, basically telling us that BCG revaccination is not, it no longer has a place on any future TB vaccine strategy. The second trial is a trial of the safety and immunogenicity of the M72AS01E adjuvanted vaccine in people living with HIV specifically. So there were 2 trials published in 2019 that showed the effect in HIV negative patients where it conferred a 50% efficacy in prevention of progression to TB disease in South Africa and Mozambique. So this trial was very specific around safety and immunogenicity in people living with HIV. And you can see there was about 46%, 46.8 versus 43.5% in terms of adverse events, which means equivalent safety. And if you look at day 57 and day 390, M72 specific CD4 responses, you can see sustained high responses telling us that there was significant immunogenicity. So it's an acceptable and safe strategy for well-controlled HIV for patients to receive this M72AS01E vaccine. So, of course, there's a very large 20,000 patient trial that's in year 3 of implementation in 5 countries where this M72AS01E is being evaluated. The trial is powered to show efficacy in HIV negative, IGRA positive participants. However, it has included HIV positive and IGRA negative cohorts to show safety and immunogenicity. So if this trial, I think the data is expected in Q3 of 2027, this may be a complete game changer for the prevention of TB disease, irrespective of HIV status or IGRA status. MTB-VAC is live attenuated mycobacterial tuberculosis. Remember, BCG is Mycobacterium bovis, but this is actually Mycobacterium tuberculosis. Trials were done to establish the dose that is safe in adults and the dose that is safe in neonates and infants. And so dose selection has helped pave the way for larger clinical trials in both adolescents and newborns that will assess safety and immunogenicity. And some trials are also assessing efficacy. So these studies will also produce their results in 2027 around the prevention of TB disease, both in HIV infected as well as HIV uninfected populations. I will now end with a few concluding points. We've seen from the epidemiologic data that despite all the progress that we've made, TB incidence and mortality is unacceptably high, with the pace of decline insufficient to meet our SDG or end TB strategy targets by 2035. That there are newer, shorter, and more effective prevention regimen for TB for both drug-susceptible and drug-resistant TB. That innovative strategies, including nutritional interventions and regular community screening, have been effective in reducing TB incidence. That there is a diverse and a broad pipeline of the next generation of TB vaccine candidates, and that they will include patients irrespective of their HIV status or their IGRA status. And that a combination of all of these interventions is necessary to be done at scale for us to be able to meet the end TB goals of a TB-free world. Thank you very much for your attention. Thanks.
Thank you, Dr. Naidu. If you have any questions, then we can have 1 or 2 questions due to shortage of time. So if there are no questions, I conclude this session.
Thank you very much. I would like to call upon the chairpersons to facilitate the speakers with the memento. May I call upon Dr. Prakash Bora to please facilitate our chairpersons? We will now start with our next session titled Redefining HIV Prevention in India, chaired by Dr. George Oman from Mumbai and Dr. Manoj Shivkani from Ahmedabad. We will now hand over the proceedings to the chairpersons.
Just to remind you, we are 25 minutes behind schedule. Our next session is on HIV prevention in India. And to begin with is Dr. Vinay Kulkarni, pre-exposure prophylaxis in India, evidence, reality, and the road ahead.
Suswagatam, welcome Dr. Vinay Kulkarni to ASICON 2026, Mumbai. A leading HIV prevention expert from Pune, he plays a pivotal role in advancing and implementing PrEP strategies in India. Today, he speaks on PrEP in India, evidence, reality, and the road ahead, examining how science, policy, and real-world challenges shape the future of HIV prevention in the country.
Good afternoon. I think it's virtual reality, not true reality. So I am supposed to talk on this PrEP in India, evidence, reality, and the road ahead. And just it could be just one slide lecture, because when I was looking for this lecture, where are we and why do we want it? How do we forward it? So pre-exposure prophylaxis. So then why are we still discussing this? Because this was the presentation I did in ASICON 2013. So we are 13 years down the line and we are still discussing where should be PrEP in India. So that's the progress we have made probably. So, but why we are still discussing this? Because 2026, 2031 strategy towards ending AIDS by UNAIDS is still discussing that. And why we are discussing is basically because we all know that the world is faced with multiple issues, conflicts, crisis, and geopolitical uncertainty. And yet AIDS is not over. We wanted to do that. Ending AIDS is still possible, but only if we do not give up. And I think we are gathered here not to give up, whatever, whether there are changes in regimes, changes in conflicts, there are wars, etc., etc. But we have to still fight and get over the line as regards HIV. UN mandates to lead, guide, and coordinate the global HIV response. This is not a UNAIDS strategy. It's a strategy for the world. Not just because someone is dictating us, but because we want to do it. And someone was saying that we are a fortunate aging generation, many of us sitting in this room, because it rarely happens in the life of a physician that a new thing comes up. When we are doing our post-graduation, Ishwar might be remembering, there was no AIDS, 81, 82. We were just started listening about AIDS. It came, and by the time now 70, 72 years old, 75 maybe, we are thinking of end of AIDS. So it's just the career of a physician starting the new practice to retiring from the practice. You are seeing a whole spectrum of the disease. But we have to have this prevention grounded in dignity, equity, human rights, science, and community leadership. We are at the historic crossroads. The science, tools, community strength exist to end AIDS as a public health threat. And we have seen this during the COVID crisis. The program almost was to collapse, but who came up and did everything was the community networks. And we know that the community leadership has helped a lot. Political will and financing are fragile, we know. Some of the titles in the corner may not be there next year. The strategies to call to decisive action, choosing action does not mean choosing courage over fatigue and hope over resignation. So we are not going to resign. We are there to fight for the cause. So end of AIDS is elimination of HIV epidemic, but it is not possible without prevention. So it's not just going to be the treat all going to end the epidemic. And prevention strategies built on two closely interlinked things: prevention of transmission of the virus from a person who is infected, and prevention of the acquisition of HIV by someone who is not yet infected. So treatment and prevention should go hand in hand, and the foundation is like that. So we have 40 million people on HIV treatment and with viral suppression, and 20 million people accessing antiretroviral medicine based on HIV prevention options. Both these things happen, then only by 2030 we are going to end AIDS. Reaching the 2030 targets, will it save lives? Yes, we'll look at the top corner, how many of the infections would be prevented, and the lower chart shows how many deaths could be prevented if we have prevention. I'm not going to go into the details of prevention because we know that it is not just one prevention strategy and we'll be over the line. We have to have a combination of preventive approaches, which includes everything: behavioral change, treatment, highly active HIV prevention, biomedical strategies, and also social justice and human rights. Now, yes, what is the evidence? That was the title given to me. The evidence regarding pre-exposure prophylaxis is there. It has evolved from a conceptual idea in 1980s till what we have now, not only daily regimens, but long-term, long-acting injectable regimens. It reduces the risk of contracting HIV by almost 99% in some of the cases. The history of PrEP is marked by landmark clinical trials, the approval of daily oral pill, and the recent introduction of long-acting injectables. So this is just a history. Conceptually, as long back as in 1980s to 2000, we had this using drugs to prevent transmission, like using medicines, using zidovudine for prevention of mother-to-child transmission, etc. And from there, we have come to new oral options in 2019, and now also the injectable ones. These are various trials which have shown that. This is summary of the clinical trials, several studies on oral PrEP. We have also these new studies where there was some of the trials showed success, some of the failure. For example, Maravirok was a failure, but we have this other studies of long-acting cabotegravir, etc., which are showing a great promise and have been approved now. So what are the PrEP options that are available? Daily oral PrEP, daily pill, highly effective standard reducing sexual risk by more than 99%, event-driven PrEP for MSM with infrequent sexual activity 211, long-acting injectable PrEP, cabotegravir, twice yearly injectable lenacapavir. Then we also have this dapavir in vaginal rings, and there could be future options like long-acting implants such as islatravir or broadly neutralizing antibodies, which may have even less kind of a frequency. And so these are the options that are available for the PrEP. So what we know is that apart from these drug trials and what works, we have the evidence of the programs also. And we know that when given, prevention works and prevention is needed. So dedicated efforts to promote and support combination HIV prevention are producing clear and impressive results. So wherever these programs have been implemented, they have shown success. And the failures is going to be in programs. Just last week, I had a person come back from US and asking for PrEP. And he said that, but when told that it is not available in the program, you will have to purchase it. He said, okay, fine, but I was getting it free in US. So I asked him, are you going back to US so that you can get it free? He said, no, I don't know, because they might start charging there now, because the free PrEP is being taken off from the program in the US also. So we don't know what kind of strategies would be coming in many places. HIV programs must include a combination of all. You cannot rely on one prevention strategy. And PrEP plays a key role in India's HIV prevention amid a maturing epidemic where declines have slowed down. So ours is a mature epidemic. However, what we know is that the epidemic, whatever plateaus we have seen, have stabilized. We are not seeing further declines in this. So what is the PrEP evidence available to the program? In 2022, NACO's guidelines endorsed TDF FTC for high risk via typical kind of a risk scoring, whom to give, etc. Pilots in FSW's MSM demonstrated safety, feasibility, acceptability, and possibility of integration into community-based prevention. There was good initial acceptability, but adherence challenges in some of the very high-risk groups like Hijras. Qualitative studies among MSM indicated high interest in PrEP once explained what it is, viewing it as a condom backup, though concerns include side effects and risk compensation. So we don't know exactly. People are all the time those who are opposing PrEP are saying that other STIs are going to increase. But at least from India, we don't have enough data to show that it is happening because of the knowledge or usage of PrEP. So What is the reality? India's adult HIV prevalence is low, very low, 0.2 to 0.22, and it is concentrated in some groups. New infections have dropped 48% from 2010 to 24, AIDS death by 81%, and mother-to-child transmission by 74%. Are these figures good enough? I don't think these are good enough. It should be much, much lower than that. NACP phase 5 targets 80% reduction in new infections and deaths by 2025-26 from baseline, but we have not achieved that. The progress accelerated under NACP phases has had gains but have plateaued over time. New adult infections have fallen down. New incidence is 0.05 in uninfected adults, but the number of new infections hover around 65 to 75,000 or 68 to 107,000 new cases every year. And there is no complacency because 90% decline is needed by 2030 before we end the epidemic. Current tools are condoms, opioid substitution, testing, etc. They have saturated the high-risk groups, but gaps persist in hard-to-reach or at-risk populations. What is happening is that there are cohorts of targeted interventions, and the same people are being looked after year after year. There needs to be a much better outreach. Additional biomedical options like PrEP are vital for 95% at risk using comprehensive prevention, and the low incidence favors targeted PrEP. So it need not be universal, but we have to target the populations because we still know that there are so many people who don't even know that they are at a risk of HIV, and this can be evidenced from the kind of boom we are seeing in syphilis cases, which means that there are more people involved in high-risk activities. They are not aware of the risk of not only syphilis but of HIV, and we are likely to see not only plateauing but now a rise in new cases of HIV, at least in some small kind of clusters. The current PrEP reality, it has been approved in 2016, yet uptake is very low for a country like India. Saying that somewhere around not more than 7,000 patients are on PrEP is really minuscule. And whosoever is taking is through private providers, NGOs, and pilots targeting key populations. The availability is limited, often expensive. Now, I don't know why the availability is limited, because the drugs are available. So we are using it for so many other things. ARVs are available. And the awareness poor among the people, especially lower socioeconomic groups. NACP phase 5 has supported HIV prevention through PrEP, but emphasizes only targeted intervention. What are the concerns people cite when they don't want to have PrEP? It is that there are going to be resistant mutations if we use it over a long period, and it would harm our ARV program. And as I said, there is a risk compensation, and we might see increase in other STIs. But as I said, we don't know whether it is happening because of the changes in behaviors, the sexual networks, sexual patterns, or because of PrEP. So what would be the road ahead? We should have better implementation models. We should ensure that people who are on PrEP adhere to treatment, because the basic line in all PrEP lectures would be PrEP works if it is taken. PrEP does not work if it is not taken properly. So the adherence is very important. We have to target appropriate populations. We should increase awareness, not only people who are on PrEP, but about the availability of PrEP. People, especially MSM, coming to the clinic for the treatment of syphilis, not more than 20% of them are knowing about availability of PrEP. When we start asking them, are you on PrEP? Do you know about PrEP? 80% of them say, we don't know about that. Explain to us. So we have to increase the awareness. We have to look at the cost. There could be cost sharing. There could be PPP models. But again, as I agree completely with Ishwar that private-public partnership has to be a partnership. It cannot be one-way thing that you do it and we will follow you. Or, for example, as you were saying in all PPP thing, the only thing that is being discussed in all the kind of meetings is we want data from you. And we ask, what are you going to give us back? They say, we are not going to give you anything back. And I tell them that, but what about the data which I am providing to you for last 3 years? Are you getting it? They said, no, we don't know. But then say, at least an acknowledgement that you have given me the data every month, saying that received is good enough from the other side. And so even in prep, we are ready to provide that or give it with the program. But I think there should be a good partnership in that. We can share the costs of that also. And of course, we have to reduce the stigma, because why we don't want prep in the public programs, one of the reasons given is prep would be for people who are not HIV infected. And for them to go to ART centers, which are centers for people where HIV infected people go for treatment, there could be stigmatization because they could be stamped as having HIV. So there we have to have different kind of models. So what could be the way forward? We need greater public investment, that is from the program. We should have awareness campaigns, and awareness campaigns not only for PrEP. We really now need awareness campaigns rejuvenated after 20 years about HIV awareness. Because the youth, as you said, Gen Z, doesn't know about prevention and seriousness of HIV, because the awareness campaigns have gone down. Implementation research to boost access, retention, and cost effectiveness. For example, subsidized or free PrEP via government channels, whatever. Exploring long-acting injectables also, because we should not be giving this kind of a lecture after 5 years. Injectable PrEP, where are we now? As the evidence keeps on coming, we should be moving forward along with that, because it could really change the scenario. Use of digital platforms to educate and virtual networks, ensuring equitable access to marginalized high-risk populations, and of course, community engagement. So when we talk of these kind of interventions, they are very difficult in program. The road is very difficult to climb. But just like if someone goes to this trek to Falut and Sandakphu, you have a lot of effort to go to the top, but you can always see a beautiful scenery like this if you reach on the top. Thank you.
Thank you, sir, for a very informative session. I think we'll have question and answers later at the end. So now let me welcome none other than Dr. Ishwar Gilada, sir, and he will guide us on symptoms, surprises, and syndromes in STI. Welcome, sir.
Suswagatam. Welcome Dr. Ishwar Gilada to ASICON 2026, Mumbai. A senior clinician from Mumbai, he plays a pivotal role in advancing comprehensive STI and HIV care with deep expertise in diagnosis and management strategies. Today, he speaks on symptoms, syndromes, and surprises, rethinking STI diagnosis and management.
So we start from the glaciers, which Vinay has shown you, and going to iceberg. And in my outline, I'm going to show about changing trend in sexuality, obtaining sexual history, which we have been taught and sometimes we wrongly pursue. Changing trend in STIs, symptoms, syndromes, and surprises, and take home points. So when we talk about changing trend in sexuality, it is just like a phenomena. About 10-15 years before, we thought it is a small iceberg and below there will be something. But now we realize that icebergs are also big and below also they're big. And more we go in, more we unearth, more we are finding. So after even 44, 45 years in the field of STIs, we are still learning. A lot of phrases we learn, a lot of things we learn, a lot of new type of sexual act we learn, which we never thought of earlier. So when we look at that, what are the factors? There are several factors which are affecting sexuality. They can be biological factor, environmental factor, psychological factor, and recreational factors. And in that, there's something like chemsex. When I heard first time the chem sex, I realized it is some Gujarati word, chem sex. And this is a chemical and sex. We are standing at a place, and from here, hardly 200-meter or 300-meter place from here, there's a hotel, which is LGBTQ friendly hotel. And every Saturday, today Saturday? Yeah. So every Saturday, today is Friday, then tomorrow night, you don't go there. Every Saturday evening, there is a party for MSM people, and more than 1,000 people go there. 1,000 rupees is the cover, and a lot of activities goes on there. So inside, outside, later on. But if we don't intervene there, then the things will carry on. As we said about general Y and generation Z, that will continue to happen. So earlier, we were taught that we used to say, "Kahan gaye the?" Which market you go for sex. Now, no, which app you are using. So there are so many apps, and there are millions of visitors. If I have an app, I hardly get 50, 20 visitors. I always say that when me and Vinay speak, maybe 20, 30, 40 people will come. But if we have some kind of Bhagwan Kapad and say, Baba, Vinay Baba's a pravachan, then thousands of people will come. So similarly, if we look at apps, how much following they have, and look at the data, look at the business. I think if we think that government of India will really work and HIV will be nowhere, then I think we should also get into this kind of business where it is shooting business. So there is a match, chat, date, and your way. And with match, there is also catch. Catch is HIV, STIs, etc. And when you look at the matrimonial business, it has hardly gone up. But if you look at the business of app, it has gone up 1,000% in just 4 to 5 years. And these are the best cities in India to be single. So those who want to be single, yes, these are the cities. And this is not only city. Earlier we used to think that is happening because we always say Munni Badnaam hai. So Mumbai and Munni Badnaam hai. But Badnaam is everywhere. So all these smaller places also, wherever every year on year, you don't see any market which is appreciating by 25% per year. This is the market. And these are the 10 best apps which can be visited. And then the dating numbers, share, increase, share, everything, you know, and they're in vernacular language. So earlier used to think that only English speaking person will have an app. Every language has an app. So going from there, we being in the field of HIV care, STIs, we need to be LGBTQ friendly people. If we stigmatize people right from the day one, you don't sit here, you don't come here. And I remember my days in JJ, my dissertation topic was pattern of STIs in Hijra cult. So when Hijras used to come in the clinic, people used to laugh, make a joke of them. And my subject used to say, no, sir, hum nahi aayenge. Hamare ko log haste hai. So I started a special OPD in the afternoon. Now there's also Hijra ward in GT hospital, which is now independent, but it was part of JJ hospital. So special OPD, they come, get a cup of tea. In government hospital, can you imagine that patient is given a cup of tea? We started treating that way. And therefore we became Hijra friendly, MSM friendly, STI friendly since beginning. And therefore now it is the center of excellence in the country. It doesn't happen overnight. So we have to look at every angle, how we can map different STIs. So this is just a small example where one boy wanted to become girl. And she is not supported by anybody in the family, but sister, mother, grandmother. They all came together and now she is girl. So now society has also started accepting. After section 377 is repealed, there's a lot of acceptance in society. If we say lot, it's not 100%, but at least people come, they accompany, they accept what it is. And then there are also positive marriages happening. There are negative marriages happening. Male marriages are happening. Male positive negative marriages are happening. So that is also, we have gone beyond that. And now their issues are to be discussed there. Obtaining sexual history, it is a endless job. We asking, hugging, kissing, because some, like I'll show you some of the pictures of secondary syphilis. You shake hand, you get syphilis. Shake hand and get syphilis. That is so simple. So hugging, kissing, smooching, masturbation, vibrators, e-sex, non-penetrative sex. One fellow called me on a mobile. He said, sir, I had a memory sex. I said, he's memorizing sex. I never knew what is memory sex. So he had a sex in between the mammary glands, and it's called memory sex. So all these terminologies, phraseology is coming in. Live-in, bisexuality, overt and quote. There's so many living couple comes. You cannot imagine. At least I never could imagine earlier. Orogenital sex, 69 position. Sex with unknown partners by design and by dating apps. Dating apps are raat gayi, baat gayi. You don't know the name, you don't know the mobile number, phone number, nothing. So you met and you talk about kind of stress or do kind of contact tracing. Impossible in this era. And chemsex, I already said. So when we obtain the history, now we need to ask lot of questions which we are not asking. We used to say bahar gaya tha kya? So we have to ask, घर में किसको लाया था क्या? And then how many partners, whether there has been sex abuse, there has been coercion, whether there has been marriage was your first experience of sex, was it under peer pressure, under influence of alcohol or drug? Number of exposure, single, multiple, tens, hundreds and thousands. I have at least some patients where how many partners you had? 1,000 in low, sir. And the number of sexual partners in a day also, they 10 to 12 partners they had. Date of last exposure. So when we ask last exposure of the wife with the other partner and casual sex. So you need to know all that so that we can figure out what disease we have to look at. Sex of partner and history of MSM with a top, bottom, versatile. Again, that can be a separate lecture. After me, I think Dr. Jay is going to speak and he will talk about that. Type of intercourse, oral, vaginal, anal, protected, unprotected, non-penetrative sex, body to body, etc. And ever tried sex with non-humans. And I have at least 5 to 6 patients who had sex with non-humans. And then what is the changing trend in STIs, symptoms, syndromes, etc. Is a why and how. Is intense HIV awareness with aggressive condom promotion resulted in STIs going down by 1990s. Most dermatovenerologists became cosmetologists. So hardly we see 4 or 5 dermatologists sitting in the hall. Earlier it was 50-50. They come because no, because they are going down. Maybe, but that time they had a lot of the after test and treat strategy and ART, HIV awareness got neglected. Targeted intervention became low key. Hardly any organizations are funded for that. PrEP and PP further fueled STIs. So when they talk PrEP and PP, there are 2 sets of people working in HIV. Those who do not understand STIs at all, they say PrEP low, PP low, prevent HIV. Yes, prevent HIV, get syphilis, bring gonorrhea. And that's what is happening. U is equal to U, again, same thing. You don't get infected, you don't infect somebody once you are undetectable. And policy paralysis towards controlling STIs. There is no sincere policy of controlling STIs. And this is a major neglect. So when we look at what are the chances of getting any STI in one single sex, there are trichomoniasis, syphilis, etc. They come very fast. HPV very fast. Herpes simplex very fast. HIV is at the lowest bottom. And what are the infections we see which are increasing? Syphilis, HSV 1 and 2, omnipresent. HPV, also oropharyngeal cancer due to HPV, gonorrhea, chlamydia, adenomyosis. And the genital ulcer disease or genital discharge disease, both are increasing in that syndromic Then upward trend of the syphilis in non-pregnant adult, and that is a marker of how syphilis is increasing. And that syphilis, you can see, like the TB lesions you see everywhere in the body. You can see genital, perianal, oral, skin, palm, soles, eyes, ears, brain, anywhere and everywhere. And here is a case of alopecia universalis. And as a skin specialist, we think, okay, we'll treat. But the person is HIV positive, tested VDRL and TPHA in high titer, and treated, recovered, got bullous pemphigoid. So iris phenomena is not only in HIV. In HIV, a lot of terms we started using, but we have been treating iris earlier. So bullous pemphigoid treated, and he finally got the hairs. And as I told you, secondary syphilis, teeming with syphilitic organisms, and highly contagious, both the face or anywhere. And such kind of, as soon as we see syphilitic palmar or plantar syphilite, we treat, and again within 2 to 3 weeks they become all right. Different lesions. So it can be in symptomatology, they can be tertiary and secondary syphilis. You can see papules, nodules, plaques, ulcers, and cellulitis. And on the right side, it shows syphilitic gamma. And my teacher in pathology in Aurangabad Medical College, and he was a poetic teacher. He used to say, "Gam bhulane jate hain, gamma leke aate hain." So We cannot forget gamma in entire life. We have been taught by Dr. Bhautankar that. Surprises in syphilis, as I told you, somebody comes blind, only one eye blind, and check syphilis highly positive. After treatment, he got back his vision. We have seen at least 3 total deafness because of syphilis. After just 2-3 weeks treatment, they become all right. So what are the problems in syphilis? Persistence of antibody positivity. So that doesn't mean that person is a, I think yesterday Dr. Koenig spoke about that. Difficulty diagnosing reinfections, titers important, not positivity. TPH and VDRL or RPR titer, they should be correlated. And 4-fold up or 4-fold down, that is either person is responded or going up or new infection. Best treatment is penicillin, but there's a shortage of penicillin. John Wyatt company market for 20 rupees. But to get that 20 rupees, you need to spend at least 1,000 rupees to go to 100 shop, then you get a penny drug. Alternative is doxycycline, as you mentioned, very weak, doesn't work properly. Reluctance by practitioners. Out of 100, hardly one or private practitioner is willing to give penicillin. And in last 3-4 years, we never got a single reaction to any patient. Doxyprep and in habitual risk taker. So we don't even advise doxycycline 2 capsule, just like in lepto where we give prevention. Here you give post exposure, just 2 capsule, single dose, 50 to 70% reduction in syphilis, chlamydia and gonorrhea. HSV, labialis, which looks like a cancrum oris, and that person was treated with ghee, butter. Just apply butter, slough comes out, and then it will respond to treatment. You give any kind of antiviral, it is not responding. And we can see that multinucleated giant cells in herpes. Herpes digitans, which is a precancerous condition. And then you can see, I think this slide has come double, but this was what is available for HSV kind of diagnostic. So a lot of people come, one of my patients came from Miami, took a flight, came, sir, you treat my herpes, where is a IgG positive? What do you do for IgG positive? So we need to propagate that kind of message that IgG is nothing, IgM is nothing. There has to be either cytology or now there are PCRs available. So HSV challenges are HSV2 serologic test have a high false rate when used for screening and asymptomatic individuals. Confirmatory testing not widely available. HSV1 serology can't differentiate oral from genital. Anxiety and cracks in person relationship that can be associated with positive test result overweight or overweigh the potential benefits of screening. Lack of specific treatment intervention for asymptomatic people. And what are the drugs available? 40 years before we had acyclovir. 30 years before we had a famciclovir. 20 years before we got valacyclovir. In last 20 years, there's not a single new drug. And those people who have been taught 40 years before, they still treat acyclovir. Acyclovir has to be taken 5 times a day. Nobody takes 5 times a day, and that person becomes registered. So you can see squamous cell carcinoma, perianal carcinoma, vaginal carcinoma because of HSV, because of HPV. HPV, this was a very classical HPV, but I said, well, how can it come in mouth? Orogenital sex, and we cauterize this part. And you can see aggressive genital HPV 16 and 18, we took a tissue and did the PCR. And there are studies to show that even in Tata Cancer Hospital, there are at least 40% of the oropharyngeal cancers are because of HPV. And in our small sample size of 200, we have 62% of MSM population. We are the probably in the city only center where we do HPV by scooping from anal canal. And we've got HPV by that positivity. 30% of them have either 16, 18 or 45. So HPV treatment challenges, no perfect treatment except electrocochlear or cryosurgery. Local applications like tincture podophyllum or TCA, precision of application, otherwise it damages the adjoining skin. Large and multiple warts require surgery plus cautery both. Cautery and tincture podophyllum contraindicated in pregnancy, and we do see pregnant women coming with HPV. Warts, lack of high resolution anoscopy. I don't see anybody is doing in India. We tried to learn from our international colleagues, and they said somebody should be trained from us, and they are willing to provide training. Looking at gonorrhea, chlamydia, yellow, white, or greenish frank urethral discharge, burning urination, increased frequency of urination. Incubation period is just 1 to 3 days. On yesterday, today comes with burning urination. One of my patient, call from Delhi, and on a video consultation, he showed me a discharge. I said, you need to do the test. He calls a couple of places. Nobody was doing the test. He said, no, don't worry. He sent his assistant with urine and with a return ticket. The assistant sat in the clinic. We did a NAT test on CT and NG. Found positive. I called him. Call your doctor. Take ceftriaxone. Next day morning, he said, salute. Sir, kya kiya aapne? Kamal kiya. So it is so simple, but we don't want to learn and look at it. And then we, if we don't treat, get Bartholin abscess, we get gonococcal and other kind of lesions, and you get chlamydia, usually mild. Urine examination doesn't show high level of pus cells. Sometimes earlier we also used to do that. Do urine examination. If urine examination doesn't show much pus cell, don't do any CTNG, PCR. So here we are misguided. Discharge often sticky or colorless. Patient tend to ignore. Ping pong infection. They come, treat one, the other partner is infected, again pick up from there. The partner is never in treatment. And if diagnosis and treatment delayed, they get epididymo arcutis, they get sterility. And treatment is ceftriaxone, treatment of choice. But if you are suspecting both of them, then give azithromycin 1 gram single dose. But azithromycin come 3 tablets. Sir, एक गोली का क्या करूं? मतलब कल खा लो, आज 2 खाओ, कल 1 खाओ. That helps. Doxycycline, cotrimazole. Before ceftriaxone came in, I used to give them 10 cotrimazole as a single dose. And they used to say, sir, 10 गोली खाओ, कुछ नहीं होता है. 2 गोली खाओ, 1 केला खाओ, 2 गोली खाओ, 1 केला खाओ, 4 केले में 10 गोली खत्म. Next day, gonorrhea is treated. And then we see multiple, like we call museum of STIs in one patient. You treat one infection, then it another. So gonorrhea, then we had herpes, HIV is already there. And then this boy comes and he says that I was sitting on a early promenade. Somebody came, you are a handsome man, did you have sex anytime? And he was indulged. And he, in just 3 weeks, 4 weeks time, he got so many infections. And then because of warts and because of candida together, phimosis, paraphimosis, here he got a wart which was cutaneous horn. We had to cauterize, and then he was a drummer. You could not drum properly. And then donovanosis. So donovanosis is only in the coastal belt of India, either Kumar's place or our place. And nowhere in the mainland country. I don't know why. Either they are doing a different type of sex here in the coastal region, I don't know. But here, pre and post treatment, within 3 weeks, 4 weeks, they get proper treatment. Otherwise, if you don't treat them properly, it will never heal. It will become a non-healing ulcer. And here is a pre-treatment, and right side is a post-treatment. And here is a weekly, I have taken pictures to show that in 3 weeks, 4 weeks, how does it heal? Azithromycin. And chancroid, multiple painful ulcers with dirty granulation tissue. And patient is in utter pain. And you treat and they become all right. Single dose of azithromycin. Mpox, one of my first patients of India, he had 10 partners in one night. And this was a deductive logic. I could diagnose that because I was not wise enough why he got it. I don't want to go on Mpox. I think only few seconds remaining. He's a perianal and he's always a homosexual person only for bottom sex. And he got a lesion on penis. So I said, how can he get it? And then I realized that it is Mpox. And India is a land of innovation. One of my patients came, I said, show me the lesion. He had hidden the lesion with some dabba and just and I could see the lesion because it was painful. He couldn't wear underpant. And just 4 days before one patient came, he mapped all his warts. And sir, यहाँ wart hai. आप बराबर देख के जला देना, मेरे को second time नहीं आना है. So there are a lot of innovations and confusion, and why I think Mpox I want to skip. Okay, what are the challenges? Often syndromic management, poor access to testing, CT/NG PCR is hardly done and they are very expensive, still very expensive. Difficulties of pap smear, anal sampling, high-grade anoscopy, and shortage of injection penicillin. And our center is such that in 2 to 3 hours, everything can be done under one roof, including counseling and treatment and whatever is required. So take home points: U is equal to U, dating apps, policy paralysis, poor awareness lead to rise in STIs. And also that kind of campaign must take other STIs into account if you are doing this campaign. Sexuality and pattern of STIs have changed and they will keep evolving. IDEA and STI experts and OBGY have to re-engage. Now all of us sitting here, if we think that HIV is totally wiped out, Learn STI. STI will be never wiped out. STI will never go away from Earth because sex is not going to go away from Earth. And think of multiple STIs at a time. So keep a vigil with different incubation periods. Expect long-term survivors, people living with HIV, even under good care, they come up with STIs. So you cannot say that you don't have sex. And choices are between no sex, safe sex, PrEP, PrEP plus condom, PP, doxyPrep, doxyPrep, and vaccine for preventable STIs, hepatitis B. Unfortunate part in this country, hepatitis B, I first time went to the parliamentary committee in 1989. It took 30 years. In 2011, it became compulsory immunization program. And thereafter till today, all of us do this triple S test everywhere. STI clinic, pregnancy clinic, in hospital, but we don't advise that you are hepatitis B negative. Please take vaccine. It's costing peanut. 100 rupees, you can get 3 doses. In bulk, you get 10, 20 rupees dose. Don't do that. HPV, again, policy paralysis. We call it Cervavac, cervical prevention vaccine. But if I advise Cervavac to a male, sir, oh, I don't have cervix, why should I take that? So don't call such wrong names. And it should be for both male and female. So thank you, the organizing committee, for giving me this forum, and my team in my clinic, which are really on tender hooks because I need diagnosis quickly. And last but not the least, we should have some understanding and laughter. And I would like to play this video.
Noticed his grandpa, who looked rather tensed. So to break the ice, he asked his grandpa one question while on the way back from school. What is the difference between wife and girlfriend? Grandpa thought for a minute and simplified the explanation like this. Listen, son, wife is like a TV and girlfriend is like a mobile. At home, you watch TV, but when you go out, you take your mobile. Sometimes you enjoy TV, but most of the time you play with your mobile. TV is as good as free for life, but for the mobile, if you don't pay, the services will be terminated. TV is big, bulky, and most of the time old. But the mobile is cute, slim, curvy, replaceable, and portable. Operational costs for TV is often acceptable, but for the mobile, it is often high and demanding. TV has a remote, but mobile doesn't. Most importantly, mobile is a two-way communication. You talk and listen. But with the TV, you must only listen, whether you want to or not. Last but not least, yet TVs are superior because TVs don't have viruses, but mobiles often do, and mobiles can be easily hacked or stolen. Take care, stick to TV only.
Thank you.
Thanks, Dr. Gilada. Our next speaker is Dr. Jayakant Singh. He's a PhD in public health and he represents Humsafar as a director. He's going to talk on digital sexual networks.
Dr. Jayakant Singh to ASICON 2026, Mumbai. Representing Humsafar in Mumbai, he plays a pivotal role in community-led HIV prevention and in understanding how digital sexual networks influence evolving risk patterns. Today, he speaks on digital sexual networks and HIV risks, what every clinician should know.
Very good afternoon to all of you. Evening, in fact, perhaps. I'm standing between the tea break and you guys. I'll be brief. But thanks to Dr. Gilada for the context setting, because what I'm going to talk mostly will revolve around the initial, precursor that Dr. Gilada has given so far. I'm essentially going to talk about one of the online HIV intervention programs called NetReach. It is supported by the Global Fund, and we are doing this program since 2021 in collaborations with NACO and the SACs. Essentially, to reach the first 95 targets, a lot of speakers have already highlighted about the importance of first 95 targets. We all know the targeted intervention programs of NACO since so many years have been instrumental in, to a great extent, managing the epidemic. In fact, the first 95 targets, if I say, we're reaching about 85% right now, which means about 15% we still have not reached. So what happens 15% when I say we are estimating the number of HIV epidemic to be 2.5 million, which is like 25 lakhs as of now. If I say 15%, then about 3 lakhs plus people have not been reached so far. I mean, they have not been diagnosed. So through this program, what we have been trying to do is we are on online platforms, on dating apps, on social media platforms. And, when you're saying online, it means you're not meeting anybody in person, but we are trying to link them to HIV related services through this program. So far, we have been able to reach to about 50 million online profiles. We reached the profiles and have conducted about 27,000 plus tests with a positivity of about 9%, which is way higher than the national average and the numbers that you see in the NACO regular reports. Okay, so just to give a very brief context about how this has been envisaged. I'm from the Hamsafar Trust. It's a community-based organization established in 1994, LGBTQ community-led organization. And over the years, we have been innovating ourselves to reach to the LGBTQ population who are considered to be at risk of HIV in most literature that you read. And of all these, in 99, we started a clinic, linked ART center. And by 2013, we realized that a lot of people are shifting from physical space to online space to, to meet partners, to date, to socialize and all that. So since then, we recruited one online outreach worker. We call them like internet outreach worker, and started chasing some of the profiles, people who are on dating apps like Grindr, the gay dating apps, very popular gay dating app. Then, the generic dating apps like Tinder, Bumble, all that, followed gradually. So this program was, gradually understood that it's going to be the game changer at the next level, because a lot of people do not want to meet in physical space to cruise, at least to fix your partner, but you can definitely do that on a phone call. So that's how we have started this intervention since 2021. The main objective is to create demand. As a lot of speakers have already spoken, how before, say, about 15 years ago or 2 decades ago, there were a lot of programs, interventions about using condom. The Gen Z populations right now do not understand what is condom. Perhaps a lot of gay people think, the young gay people, that condom is to prevent pregnancy, not to prevent an infection. So that's how the narratives have come up right now. Easily you can hook, easily you can take somebody, raat gay, baat gay, as Dr. Gilada was saying. So that kind of culture is gaining a lot of momentum right now, and people are into these kind of applications. So how we are doing this intervention, just to give you an idea, we are on gay dating apps. The frontline health workers, mostly we call the outreach workers in the PI interventions, are in our intervention, we call them CVN, Counselor Come Virtual Navigator. They are virtually navigating people, so we call them virtual navigator, but they are also our counselors who interact, engage with the clients on the dating apps. So we have created profiles. That is one aspect of it, wherein we do one-to-one outreach. Also, we do a lot of digital media campaigns. Some of the posters you will see later on, wherein we try to create demand from the populations that we are here on a platform to provide you information and also connect you to HIV and related services. So that's how we design digital media campaign. We target, we buy media, and we bombard a lot of content in the digital platform. That is one aspect. So we create demand, then we engage with the populations who may be interested to initiate a conversation with you, or you find somebody who is at the online space, may be at risk of HIV or anything else that you think they may need help from you. A lot of time we also get calls for crisis. Dating apps are also a place where a lot of crises take place. People blackmail you. A lot of other things come that way also. So after we engage with the clients, in the third step, we have a web portal called netreach.co.in, wherein you can go put your mobile number and you can book an appointment for yourselves for selected services that we have so far identified. 90% of services that we have been doing so far is with the government health setting, about 10% with the private healthcare providers with whom we have some affiliations or understanding so far, and we of course look forward to definitely expand this landscape. So After the appointment is booked online, the client and the virtual navigators have conversations and they are try to identify whether the client has access services. They have tested for HIV, STR, or they have initiated PrEP or any other mental health counseling support that you're looking for. And then we close the loop by understanding that the client has taken services when the client provides some information that they have access services. Yeah. As I said, we are omnipresent. We are trying to use any platforms that could possibly, be used by online users. We mostly target LGBTQ plus, and to some extent, we have also, navigated some of the networks where female sex workers operate, but not necessarily to the general population as such. So it's like for the key populations that we have been targeting so far, and we have been there in all the online spaces that we can afford. So we are using AI to people those who don't want to interact with the virtual navigators, counselor come virtual navigators. We have AI chatbot. You can ask your questions and you get answer there. In terms of languages also, we are in all the prominent Indian languages, so we can choose the language you want to interact with using the chatbot. Some of the features that we generally see nowadays when you use such kind of platforms, what is needed. So we have like voice search, we have GPS enabled website wherein I can understand where the client is coming from, and as I said, we are in many different languages in the website. Yeah. So coming to the main part of this discussion, I'm not a clinician by practice, so I'll talk from the public health point of view in terms of how it is very important to build trust in the online spaces when you're conducting an intervention of this kind. Because nowadays you see a lot of people in online spaces do not trust you. You send some link, they will say that you are here to take my money perhaps. So how you establish trust is very important. So one of the ways that we have adopted of the many is to engage with the community influencers. If you see the pictures out here, there is a singer from the Northeast towards my left, and there is a very Insta famous doctor, and I forgot her name. She's a sexologist, and promotes a lot of interesting stuff on Instagram. We also used animations. We used people from the LGBTQ community themselves, with whom the community can connect easily. So they promote our Instagram handle or the NetReach web portal that I'm talking about, or push some of the content in terms of the digital media campaign that we have been pushing. This is just a snapshot of how we have established trust over last 5 to 6 years of our intervention, and how people easily talk to us right now. Earlier we used to have conversations around I have a small penis, or I have premature ejaculation, questions like that. But right now we bang on get questions about I want to get tested for HIV, or I had a unsafe sex, or what can I do next. So that kind of questions are coming right now, because we have been able to understand the landscape and understand the pulse of people those are using these platforms over the last 5 years. And the population come across India, not necessarily limited to Mumbai or Maharashtra, but we get throughout. In fact, the left corner of the message that I'm talking about is from the Arunachal Pradesh. Then you see from Jharkhand, and you see from UP, Punjab, so all across we get conversations like that, and we link them to HIV and related services. Yeah, coming to why it is important to right now talk about behavior change communications to the population using online platforms. So we are talking about sex toys here. Nowadays in Zepto you can quickly order sex toys. You just get in 15 minutes. How to safely use sex toys is something perhaps you have to talk to the clients right now. And people will come and just show you that this is the infection that I have got. They may not even want to answer you that whether they had anal sex, or they had orovaginal sex. What kind of sex they had, they may not want to tell you. They just want to be treated. But how you navigate this space. And Dr. Gilada also was talking about how interestingly you can design some of your questions to assess risk. We have also in the web portal risk assessment module. It is self-administered. Anybody who wants to understand their HIV risk can go to our web portal and navigate through about 17 questions. And they get to know whether they are at risk of HIV, medium risk, high risk, low risk. So that kind of setup that we have created using AI and other combinations. You may all log into netreach.co.in, netresch.co.in. Then you will get to understand that. So far, we have been able to this is from 2022 to February 2026. We have reached impressions of about 100 million, reach about 50 million, and about 8 lakh people have reached to NetReach web portal. Yeah, so I'll just give you a brief overview about some of the risk profiles that we have identified through the platform. I'm talking data from last 1.5 years only, not the previous data that I have. Looking at this graph, you can see that majority of the population, those who come to the online platform, are from the young age group. They are below 29 years of age. And if you also see in the bar graph, you can see there is also line graph that shows the HIV prevalence rate among them. And mind you, I'm just only talking about population, those who have come to our NetReach web portal and they have self-assessed their risk, or they may not have assessed. So when I'm saying ND, they have not assessed, they have not answered this question. Only those answered I'm putting in the percentage point. So about 11% of HIV positivity we found in the age group of 18 to 29. And when I'm coming to gender, so most of the population that we are catering to are perhaps from the MSM and TG population group. So you see male, and the HIV prevalence is about 11% among them. And some of the risk questions that we also include is, I'm not giving all the percentage and number of all the risk profile questions that we have been administering, but just briefly about some of the questions that we thought may be of interest to you. We check about migrant worker status, whether you are a migrant or not migrant. And when you see somebody is reporting as migrant, their HIV prevalence also is quite high. Then we also ask about whom are you sexually attracted to, whether you're attracted to male, female, both. So that way also try to assess risk. So that is one of the areas that you can explore perhaps. And interestingly, if you see one question on when did you first have sex, age at initiation of sex. The later you initiated sex, the more likely perhaps that you might acquire HIV, is what our data is saying. So this is something one needs to explore. And all the more this is programmatic data, nothing to do with research data, so it's difficult to validate. And if you see, the use of condoms is very, very low among these populations. So consistent condom use was about only 17%, so which is like way lesser than the national average that we see nowadays. And Dr. Gilada also was talking about chemsex. So this is something about whether you use drug before sex. The prevalence is quite high. About 11%, including both sometimes and using all the time. About 11% reported that they have been using drugs before sex. Also injecting drug, is something that you get to see. So I just wanted to give an overview about how one can design online HIV intervention program in the changing context now, considering the fact that a lot of things are shifting to online spaces. The targeted intervention program that we have been considering to be one of the most successful public health interventions in India is getting redundant day by day because you're reaching to same populations again and again. So the 3 lakhs population that I mentioned in terms of the people those who have not been reached so far, how different mediums can be used to reach to them is a very interesting exploration that we have started. And I had given a topic about what clinicians should learn. I don't know what you should learn. I'm sure you're learned enough and you know the context much better than I do because you practice more often. As I said, understanding the dynamics about LGBTQ community is very important. From what kind of context they're coming. People who identify themselves to be from the LGBTQ community are stigmatized more often than those who do not identify. There are a lot of layers of discriminations that they go through, starting from family, from school, workplace, and all other places. And a sensitive question like, did you have anal sex might offend them. They may not want to be, coming to a clinic again, perhaps. So how you administer questions, it is important to administer and understand the risk profile, but how you can be sensitive and at the same time, understand the context is very important as, practitioners is what I feel. And building trust is important. Once you start building trust, people start to open up themselves. You may not want to ask them further questions. They will tell themselves, what they have been doing and how or why they may be at risk of, some of the infections that we are talking about. And it's time, we normalize about conversations around sex. If I wish to have anal sex, if I wish to, explore with toys, it's my choice. We are no one to judge. So the moment we say, "Ki, why do you have sex, using toys? Why don't you masturbate? It's safer." So let's not ask such kind of questions. People have choices. Even if you say or don't say, they will eventually do it what they like to do it. So how we can, be sensitive and not judge is very important in this context. Of course, we are supposed to provide information about safe sex practices and also promote and link them to nearby NGO, CBO, or anybody who is working on this space so that they can be better sensitized. At the end, change is constant. Everything is going to change. The way we have been, doing media campaign is also changing because we heavily relied on Meta. Meta means when I'm saying Instagram and Facebook, the Meta policies have been evolving and changing. When you say about sex in Meta advertisement, they tend to, block your, advertisement. When you talk about condom, they block your advertisement. So the kind of policies are evolving. One has to be very creative to, work in this environment. Also in dating apps, people are on dating apps for a reason. If I go and talk to them about HIV intervention program, they may throw you, they may slap you, they may just block you. So how you initiate conversations on a dating app where people are there to find a partner and have sex, and I'm talking about HIV, is also important to navigate. And you have to reinvent every time, what works, what doesn't work, and how you can do it better. And also, working with a lot of stakeholders, including private healthcare providers, government agencies, because nobody can replace government programs. So ultimately, we all are required to link, a lot of our clients to the government healthcare programs because many times, they are free of cost and people can afford it. At the Hamsafar, we have been doing, some effort in terms of providing community-sensitive healthcare. This is just a picture of, our Bombay clinic that got award from, MDAX about how we have been, sensitively providing healthcare services. I think that's what I wanted to say. And any questions, if you have, happy to answer. Thank you.
Thanks, Dr. Singh. Do we have any questions now? Yeah, Dr. Glory.
My question is to you, Dr. Jaikant. Very interesting presentation. Thank you. I just wanted to know whether the virtual navigators also belong to the LGBT community.
Yes.
And what percentage of those that you refer to the government services, what percentage of them actually go to the government? Do you have a...
Yeah, we do have numbers. Of the population, those who book appointment using our online platform, about 60% go to the healthcare settings for getting services.
And are those people the government set up trained, or is there stigma?
To some extent, we have been doing a lot of advocacy with the involvement of these state AIDS control societies. I can give you one example. For instance, when we started this intervention in Uttar Pradesh as well, the Uttar Pradesh SACS, sent a notification to all the ICTC counselors saying, we have started one virtual intervention program called NetReach. Anybody who comes with a referral slip, we call them as e-referral slip. You provide them, community sensitive healthcare services. They have already undergone risk assessment and other stuff. So lot many times the clients who have been referred through our platform may not have to stand in the queue. They can just quickly go. Also, our counselors who the CVN counselor come virtual navigator who is engaging with the client, they also set up a call with the ICTC counselor directly. So saying that my client is coming, can you please look into the client? So that kind of engagement is required to actually get some sensitive help.
And do you encourage self-testing and prep?
See, we are part of the national program, and according to the guidelines that we have been, Hamsafar also did one pilot study about self-testing with PATH, but through this program, we are not doing any self-testing promotion.
Or prep?
Sorry?
Prep.
Yeah, prep, we refer for prep.
Okay. Refer to private practitioners.
Of course, I mean, there is no government healthcare providers for that.
Thank you. Thank you.
If there are no more questions, may I call the session closed?
Thank you for your attention.
Thank you very much. We'd like to call upon the chairpersons to felicitate our speakers with mementos. Starting with Dr. Vinay Kulkarni. Dr. Ishwar Gilada. And Dr. Jaykant Singh. We'd like to call upon Dr. Glory Alexander to please felicitate our chairpersons for this proceeding. We'll be taking a brief tea break and we'll reconvene in the next 10 minutes. Attendees are requested to please bring in the tea and coffee back because we'll be having a very interesting debate right after this. Those presenting posters are requested to stay by their posters for judging during this tea break. Participants are requested to return within 10 minutes, please. Welcome back from the tea break, everyone. We'll be starting with today's debate on the topic of all stable patients can be safely shifted from TLD to two-drug maintenance. For this debate, I'd like to call our moderators up on the stage, Dr. R. Sajit Kumar from Kottayam and Dr. Anita Matthew from Mumbai. Thank you.
Suswagatam. Welcome Dr. Satish Rao from Mangalore, Dr. Haripriya Chala from Hyderabad, Dr. Raman Gaikwad from Pune, and Dr. Vikrant Shah from Mumbai to ASICON 2026, Mumbai. Today's debate explores the topic. All stable patients can be safely shifted from TLD to two-drug maintenance. Dr. Satish Rao and Dr. Haripriya Chala will present the arguments in favor of the motion, while Dr. Raman Gaikwad and Dr. Vikrant Shah will present the case against the motion.
Invite the panelists, please. Good evening and welcome to the debate of the day. At the outset, on behalf of the chairperson, my co-chairperson, and the panelists, let me thank the organizers of ASICON for selecting this topic and for permitting us to conduct this session. This will be a debate based on a current scenario, which most of us are familiar and about which we had some discussion in the morning also. The discussion will take this pattern. We have a total duration of 30 minutes, 4 minutes for each speaker. That means 4 persons speaking for, and 2 persons speaking for, and 2 persons speaking against the proposal, and 2 minutes for rebuttal for each speaker after that. And then there will be an open discussion for 5 minutes. Now, most of us have experience about large number of patients who are doing extremely well on triple drug therapy, particularly after dolutegravir has been introduced, and now TLD has become a standard, something like an OTC drug, which most of the people are willing to take for long years. And many a time, I have even a patient who has been taking antiretroviral drug for 32 years now. And he has been asking, is there any other alternative that is available? So triple drug therapy is the one which is going to stay, or do we have to switch them over to something safer, something easier, and something cheaper perhaps? And we have this question about large number of patients who are on TLD, whether we can switch them over to two-drug therapy. Morning, and Dr. Adul has discussed most of these points. But before we actually go into the debate, can we have a small poll with a show of hands? How many of you would like to switch your patients to two-drug therapy who has been doing extremely well, but who are maintained well on TLD? How many of you would like to switch them over to two-drug therapy? Please have a show of hands. No. Anybody who is not willing to join this group? Anybody who still says that we have to continue with the three-drug therapy for maybe a time? Definitely. No, but at least we have two persons who thinks otherwise in the whole group. So let's go into the debate. We'll have the person to speak for switching over first, and then we'll come back to the other person.
Yeah, good afternoon. I think you had a very refreshing tea or coffee. I think we are ready for some fun. So when the poll was taken, it's like overwhelmingly in favor of us. I don't think I need to do much of firefighting, but anyway, for the sake of academics, we need to have some discussion. We need to have pros and cons so that you get to know both sides of the story. So I'll start the presentation. So actually, I'm standing in for Dr. Neha Mishra, who is not here. And when I was told to cover this topic, I was wondering why at all we are doing it in the first place. Since this has already come into the guidelines, what is there to discuss? But anyway, we'll see what about the dual therapy. Okay. So I will try to cover it under simple headings. My presentation will not be very complicated, very simple. Most of it has already been covered by Dr. Atul Patel, so it becomes very simple for me to do it. So what is the purpose of this? And is there evidence to support this concept? Now, this concept of dual therapy was designed or conceived based on certain clinical needs. It aimed at fulfilling or bridging that gap in the clinical areas, and it was meant to simplify the ART regime. It was meant to preserve the future options. It was meant to enhance tolerability, decrease drug interactions, and decrease toxicity. And the intention was to eliminate the adjustments that we need to make with the food and other restrictions. And also there was an element of cost involved in this. So the purpose of this is fairly well designed and well defined. But then we are not the people who will come and say here that it has to be given for everybody. No, there are some areas where you cannot use this. And what are those areas? Hepatitis B, for example, we say it should not be used. When there is TB co-infection, again, it cannot be used. Pregnancy, we cannot use it. And if there is some history of drug resistance in the past, then again, it becomes a little tricky to use this. So you're not saying that it should be used in all. It's not a blanket recommendation. There are some patients where this cannot be used. So originally it was conceived as a switch option, especially in those where the patients were virologically suppressed, primarily for a switch. Now, do we have enough evidence? And what are the main concerns? Why people still criticize it? If you look at this came in Lancet in HIV. There are a lot of studies on this. I'm not going to go into any of this. I'm just putting this to show that there are enough and more number of studies which have looked into this concept or which have looked into this evidence. And in this, I've listed some of them. Here, all these studies were either non-inferiority design or there was some kind of superiority. So that's why I have listed only these things. Now, because of the evidence generated by these studies, this made into the various guidelines, which has been shown to you by Dr. Atul in the morning. But these are the concerns. Still, there were concerns whether it could be used in patients with very high viral load to begin with, or whether it could be, what about the long-term efficacy and safety of this? These two things also have been addressed in some of these recent studies. For example, in the Wolver study, the 96 weeks data has come, and according to this, despite M184B mutation, it continues to remain efficacious and safety is also proven. And this came just last month. According to this, even when it is used in advanced HIV patients, in treatment naive patients, it has shown good results. So I think we have everything in place now. The concept is good. We have the evidence. The concerns are also have been addressed to a large extent, and we know in whom this has not to be used. So I feel it's an open and shut case. There is an indication for dual therapy.
Dr. Rao and Dr. Vikrant speak against dual drug therapy.
Good evening, everyone. So I could see only 30% of the hands up for dual drug therapy. And when we ask about triple drug therapy, there were few hands. Rest of the people for what? Right. So we just heard about dual drug regimen, but is it for all? Why it seems to be not working? Thank you. So, colleagues, HIV is not a disease wherein we experiment with margins of safety. We talk about lives, we speak about resistant patterns, and we are here still for awareness. We heard previous lectures about HIV awareness program. Where were we and where are we right now? We speaking about U is equal to U, wherein we cannot compromise regimen. We need to have the strongest evidence. We need to have the highest barrier to resistance, and we have the longest track record of success. And that record is with triple drug ART. Definitely not with the two drug ART. So we have the START trial, hit hard, hit early. We have reduction into the serious non-AIDS events and death by 57% by using triple drug regimen. We don't have such solid evidence with the two drug ART. We have consistent benefit noticed across globe and across CD4 strata. We have established durable suppression and immune recovery noticed with triple drug regimen. We've heard about, we saw the busy slide talking about different trials. We have the famous Gemini 1 and 2, dual versus triple. You have non-inferiority trial, 91 versus 93%. But I would still go with 93%. Why compromise 2%? We have non-inferiority shown, but that is again with a carefully selected patient. We are talking about the entire spectrum of patient. So we need to think about it. How many times as a government program we test everybody for hepatitis B co-infection? We've had, all of us have had patients coming to us with hepatitis B very high viral load. We also thought about resistance. Fewer drugs is equal to fewer barriers to escape. Resistant compromises future regimen option. And practicing in resource limited setting, we have compromise options for second line. Here, when we talk about the direct genetic barrier resistance, you have high genetic barrier resistance to triple drug as against two drugs. We have 25 years of global data. We have limited data available with dual therapy. We have all patient categories with triple drug therapy, and you have only stable patients and selected patients with dual drug therapy. Any viral load strongly supported with triple drug ART, but with very high viral load, there's a caution which is there with two drug ART. Public health impact, prevents population resistance and risk if it is misused. So we have something like a population level responsibility. So U is equal to U, we cannot achieve with that. So innovation is important, but not at the cost of resilience. Short-term non-inferiority does not equal to long-term superiority. Dual therapy works in ideal patient, triple therapy works in real-world patients. In global HIV care, we do not treat ideal scenarios, we treat reality. If it was your patient, would you choose a regimen backed with 25 years of global success, a higher genetic barrier resistance, a strategy aligned with public health security, or would you choose a drug and reduce the safety margin? That's all I wanted to say. So triple drug ART is still not outdated. It is time tested. It is resilient. It is globally validated. And when facing a virus defined by mutation and resistance, we must respond with strength and not with minimalism. For durability, for safety, and for public health, I still feel triple therapy remains the gold standard, and that's what will give us U is equal to U. Thank you very much for your kind patience.
Thank you. So you're not fascinated by sword, artistry, tango, etc. You're not fascinated by the trials. Let's hear once again, why they are trying to propagate this.
I'll start where Dr. Vikrant left. If it was your patient, would you choose? Yes, I would start with that. If it was my patient, I would carefully choose and shift the stable patients onto dual therapy. This is because it is a leaner, cleaner, and it's future for HIV. 25 years data on global success is there, but I want my patient to live forward 75 years. On Dr. Gilad also mentioned, people want now not just to be alive, they want to see their kids' marriages, they want to see their grandkids' marriages. So are we gonna burden our patients? Are we gonna burden our patients with the extra drugs? So 3-drug regimen, yes, it was time tested, but it was designed for an era of weak drugs. And now we have our drugs which are high barrier resistant. If you say lives, we are treating lives, we are treating resistant patterns, was the statement made by Dr. Vikrant. Yes, we are treating lives. We also want add life to the longevity. We are not just increasing, but we also want quality. We don't want weak patients, bones damaged, kidneys damaged. So this is brief cases I will go through. 32-year male who was screened for his deviated nasal septum, found to be HIV-1 positive, no symptoms clinically, 720 CD4, viral load of 69,000 copies. He was started on TAF, FTC, and DTG. 1 year later, he shifts city because of his job, and then presented to our center, reports a weight gain of 8 kg, HbA1c of 8.7, whereas baseline was 5.8. The second case of 54-year male who missed diagnosis of HIV when he had abdominal TB, expert proven 4 months ago, now presents with breathlessness, diagnosed as PCP, and then he was HIV was found, viral CD4 of only 100, and then with a viral load of 6 lakh copies, started TLD from the government program. 8 months down the line, he presents for a routine checkup and creat of 2.1, baseline creat of 0.9. Don't we see all these patients also on a regular basis? So this is a third patient who 59 years old female, ART from 13 years, previously on TLD regime, then changed from past 6 years as the government changed to TLD. And then she presents with body pains, generalized unwellness, no specific symptoms, but she's not been able to carry out her regular work. More pains of lower limbs. She got imaged, this osteopenic bones, and then we see the DEXA scan. If you can make out the Z score is minus 1.4, anything minus less than -2, it is that your bones are failing and your pathological fractures are, you're very, very high risk. Do you want to do this for a 59-year-old female who is already stable? I don't think so. So there's a lot of evidence. It's not just of anything one or two. Where I think we have heard enough from these in the morning. So tangos, switch therapies, and salsa therapies, and then we have, I'll just, for the sake, it is nothing like genetic barrier. It is a myth that MA184V. So we have this trial, Volvo trial, which saw that the patients, even when there is present this mutation is present, they can still be safely treated with a two-drug regime, and it was 96 weeks data. It is not still 3 years data, that is. So I rest here and we'll take care of the rebuttals. Dr. Raman.
Front and back. So I think we need to look at this subject through a lens of pessimism and skepticism. Right? I consider that point that these two-drug regimens have been evaluated to work, they work well, and many people can, they have less weight gain, and they don't result in emergent resistance. But what we now need to understand is whether we can take that data from clinical trials and apply it to the real world. Now, dexamethasone does work in COVID. You apply it to the society, you get mucormycosis. Okay. So now you need to be careful before we say that this works well. All patients, all stable patients can be switched, right? And this real world has suboptimal adherence. It is an irregular follow-up. People don't turn up for in their clinics for years, and they are on non-supervised ART. They are treatment experienced. They have some archived mutations. And these clinical trials, they are conducted with a subset of patients where these conditions are underrepresented, right? So now, when we switch to such regimens, there are some implicit requirements. One, that there should be regular follow-up, there should be a good adherence, and there should be regular HIV monitoring. The question is, how many of our patients really satisfy these conditions? Look at this patient, a 50-year-old one. She was doing well, so I switched her to two-drug regimen, and then suddenly she stops coming to the clinic. Next time I check, the viral load is 2400. What do I do then? Do another viral load, or do a drug resistance assay at this point, or switch by her back to a 3-drug regimen? It leaves me with unnecessary choices, really. Or this patient, we recently found his provider switched him to a 2-drug regimen, and in 6 months he presents with a reactivation of hepatitis B, and this requires now hospitalization, some plasma exchanges, and all that stuff. We checked why was his hepatitis B overlooked. The problem is no one has been checking his hepatitis B. It's been checked 15 years back, and there's no document lying around where you can really check this hepatitis B. Now I am just afraid how many of my patients I have switched overlooking this thing. So when in practice, what I will do is I will switch patients to a 2-drug regimen when their full ART history is known and documented. They have demonstrated adherence and follow-up. They are likely to follow up regularly and are able to do viral load monitoring. So these are my prerequisites where before switching a patient to from a 3-drug regimen to a 2-drug regimen. And then there are other factors. A TDF1 is likely to do better on a 2-drug regimen, but on TAF, the scale is even really. Unfortunately, these conditions we want cannot be met in many patients. And that's why I consider them ineligible for this 2-drug regimen, 3TC plus DTG. Right? So I believe that the 2-drug regimen is a future. And it's also a very current option for most of my patients. But what I think is that both the drugs should be active. They should have low or negligible prevalence in the population, which this regimen I don't think has. It leaves with me some concerns. And any regimen should not come with caveats. Viral load less than 5 lakh, should not have hepatitis B. I mean, this makes it too complex, right? I can fire a 3-drug regimen and leave it there, and I don't have to think about it. I am always right? So the current regimen is a significant advance, but it does not satisfy our requirements yet. And it is unwise to underestimate the pressure of evolution. and tendency of pathogens to develop drug resistance. They have time on their side, right? And our treatment regimen should have a wide safety margin built in. Thank you.
Thank you. Now the major campaign is over. Now we are going for the rebuttal.
Yes. I do not have any additional points to make, but I would like to only emphasize certain things. One is dual drug therapy is not just DTG and 3TC or FTC. There are a lot of other dual therapies that have been considered and have been tried, and that is again a mistaken belief that it means only dolutegravir with lamivudine. There are other two drug regimes also. And when we say non-inferior designs, meaning like more or less the outcome is equal in both the groups. So that's why repeatedly raising concerns that triple drug therapy is superior, this is not so superior, just because there is one additional drug, I think that we need to reconsider, because that additional drug can also lead to toxicity and drug interactions and so many other problems. So if you can do away with that additional drug, it's always a good idea. And I just showed one study, Volver study, where 96-week data is available. That's the longest available as of now. And in that, despite 184V mutation, the efficacy didn't come down, and there were no safety red flags raised. So I think, although I agree that the evidence is not enough for long-term efficacy and safety, it is developing. It seems to be in the positive direction. And other points that were raised, these are happening in all the patients. It can happen even in patients who are on triple drug therapy, like somebody lost for follow-up, somebody developed reactivation of hepatitis. That can happen in any way. That we need to be vigilant. That's why we are saying this is not for all. You need to choose your patients correctly, and only in those patients you need to consider dual therapy as an option. So that's where that's my rebuttal.
So I completely agree with sir with a caveat again. So he just said that it is not for all. We are here to actually talk about therapy for all. So this forum is basically for people, public forum. We talking about so many ART centers across India. Are we really going to implement this in ART program? It is still not into guidelines. I completely agree as a private practitioner with the best optimal setting wherein patient is going to follow up with me. I'm happy to do that. She mentioned about complications of TDF. Now we have TAF. If we are doing regular follow-ups, I might as well do the bone densitometry. I can do UACR. I can follow up private patients on a regular basis. But when we talk about ART center, wherein there are 200 to 300 patients in one single OPD, can we, replicate the similar design? That is my question to all. So people who are doing well without any side effect, are we justified in, as a mass population, are we justified enough to switch them to two drug ART? 96 weeks, 144 weeks, is that account for 25 years of experience? I don't think so. But as we had that 25 years of experience, over 25 years, I'm sure we're going to have the experience with more and more trials to come and more years to come with two drug regimen. And I'm sure maybe next time we'll have something else to say. But the fight between two drugs versus three drugs, completely scientifically agreed, most optimal patients, I would do that in a private setting. But for a government setup, for a program, I would still be questionable. Thank you.
Thank you. Yes, we are waiting.
Can I have my PPT?
Another PPT?
No, the same one. I just want some conclusion points for the audience not to be confused. Two drug, three drug anyway. So basically, nothing is for all. for what Dr. Vikrant question is nothing is for all. Even for the 3-drug regimens which government is providing is also not for all. I would also want to make a comment of for what Dr. Raman said. I can just fire 3-drug and I think you are frying kidneys instead when you are firing. I think and we can't be lazy. I forgot to check hepatitis B. I'll just give. I don't think we should be doing just in case, forgetting, and I don't think these are excuses. I think we should carefully, at least in private practice.
That's real life. That's real practice, right?
at least when we are. Okay, if that is real life, but I don't think it's an excuse to just give extra drugs. Any drug extra is an extra poison and extra side effects. So I think we should be careful. And for the sake of hepatitis B, I just want to say hepatitis B, you have not just HBsAg just alone might not be for those practitioners who on private. Just hepatitis B, HBsAg is not enough. Maybe you have to check for a core and they have to be sure that there is no reactivation that is gone there when you're pulling off tenofovir for any renal or bone related side effects. That is one issue that we have to keep in mind. And also vaccinate if they are both HBsAg all 3 negative, just try and vaccinate them for hepatitis B. With this, I would want to conclude saying choose your patients better than choosing 2-drug. I think the debate should be, it is not choosing 2-drug or 3-drug. I think choosing right patients for right drug. Thank you.
My last point would be that give me a 2-drug regimen without caveats and I will be very happy to use it.
Anyone from the audience who would like to ask some question or have some discussion on this particular topic?
So here we see 2 people from my generation, 2 people from the other generation. And at least there are 30, 40 people sitting here who have been practicing HIV for many years. When the first drug came, they started 1 drug. Second drug came, they started 2 drugs. Thereafter, when the third drug came, we all say using 2 drugs is criminal. And that message went all over the world. Now, when you have option, when you have evidence, and when suppose you get HIV and you have been treated, and then you are getting fracture neck femur, or your vitamin D3 is low, all people in lockdown, they have not gone out, vitamin D3 are low, almost 60-70% population. We want to burden that person with the third drug for no reason. So evidence, today there is a metro in Mumbai and there's a lot of traffic. You will ask me, there is no evidence of metro working for more than 25 years. Metro was not there for 25 years. So you have to see what is evidence available, and thereafter you go that do you want to burden. And last but not the least, government program at whose cost? We are paying the taxes. You want to withdraw one drug cost will go down. It's not free. Nothing comes for free. You people think that you are getting free. We are paying taxes. It's a people's program paid by people. So you need to be very, very conservative. And if you say that ART center cannot manage 3-drug, 2-drug, how you have to train them, teach them. That's the reason we are having ASICON. Otherwise, there's no need of ASICON.
Yeah, please.
So I just had a comment. If we are really talking about, eventually we will all be thinking about 2-drug. But when we're talking about a public program, I think we don't even have hepatitis B vaccination. If we really need to go to 2-drug, we have to vaccinate our people in preparation. And I think that is one such a big missing link in our entire program, where we are giving ART, which is much more expensive, but hepatitis B vaccination that is less than 200 rupees for 3 doses, we haven't included. I think as a preparation for all of this, I think we should include hepatitis B vaccination so that at some point we can get to 2-drug.
He's also talking about doing core antigen and envelope antigen.
That's not a recommendation in HIV.
That's what we're going to do it in government setup, and sir, at our cost, with our taxes.
We also have one poster displayed there, about a patient who developed a hepatitis B infection while on treatment for ART.
Yeah.
There's a poster which is being displayed there. Yeah, Dr. Kumar.
It's a nice both ways you argued. When we started with the AZT containing regimen, at that time no tenofovir was there, right? We also had hepatitis B patients who infected. We all managed that. Now, why we are looking at this is, how we can make sure the patients live longer without having toxicities. This argument came up in the WHO Guidelines Committee, which I serve. You know that I strongly recommended this two-drug therapy for the whole world conditions. At that time, the program managers from many countries, they said that they cannot do it because it will be very expensive. You have to do a hepatitis B testing and vaccination, so on and so forth. So we modeled with a group from Harvard, stating that if someone develop a renal toxicity to kidneys, they want to have a dialysis. If you put that cost into the model, and as well as someone who has got a fracture, hip, to do a hip replacement because of tenofovir, put it in the model, the cost will be extremely high because it's all going to happen. Now we know that accumulated, by when I published the first paper on tenofovir toxicity, people, laughed at me, why is he talking about kidney toxicity many years back. Then after that, they started introducing creatinine monitoring, and so on and so forth. I think with all those, we had to look at it as a whole, everything. Now, when you, again, the cost, don't look at that. But there may not be a big cost difference between making, if you ask the manufacturers, between 3TC DTG and TDF 3TC DTG. It might be very marginal. There's no cost difference. But on the other hand, cost to manage the toxicities for tenofovir related will be much more higher. So I think this is something what we are looking at. There are a lot of other new drug in pipeline coming to the CAB rilpivirine. We're going to get CAB len, CAB in len and bictegravir. There are a lot of things are there. So this is something a stepping stone into that. This is not the end of the story. The minute when we are going to talk about bictegravir and len, when it is going to be approved in another 2 years' time, we'll have a huge outcry will happen here. Because
the last CROI,
right?
Last CROI.
Yes. This is the very latest one. So this two-drug therapy is something like, what we on. I think you argued very well in terms of it cannot be possible, but that's not the way. But on the other hand, a lot of other points you brought in, especially it's been doing well. Why do you want to disturb? But on the other hand, doing well can also harm. How we can prevent disaster to happen. I think that's the way we look at the monitor. Thanks.
George.
Yeah, Dr. Vikrant has been a friend of mine for many years. Now, I don't know whether NACO has got any data regarding 3TC mutations. You're on the NACO board, huh?
There is one Indian data, Indian study.
Indian data.
It's not on. It's
So
not.
we don't have any data regarding mutations of NRTI. So in short, we are giving patients monotherapy. It's almost like the OK trial that came long back. That the only Caletra study, that was where only lopinavir was used. So in short, this two-drug therapy patients are receiving monotherapy.
It is not really equivalent to monotherapy. So this is the argument, but with the mutation, there is a fitness issue of the virus also. So it inherently it becomes weak, and the strength of DTG is good to handle. We actually have some trials like early simplified, which actually are changing patients and seeing monotherapy. Those patients who are primarily who started ART at the primary viral infection, this early simplified study also came, which actually shifted patients once they are stable to only DTG. They are also, it is data of 48 weeks and 96 weeks. But they are also doing well. I don't think with the mutation and the exposure to DTG therapy, dual therapy is equivalent to monotherapy. It's still the 3TC part has an effect because of the viral fitness issue. That is how we are looking at it, and that is what the so far data has come shown.
Any further comments? Vijay?
I think, ultimately data is data. So I think you should be guided by data. What I'd like to see is more Indian data on resistance prevalence, which we will have in the next few years, because
I think we have one small study with few patients, roughly about 120.
No, but a few patients is not the
That
answer.
is the only Indian data we have so far, sir.
I understand, but
From
we need
Pune.
more data. So I think with the next few years, both NIMHANS and AIMS are going to have a credible, robust HIV resistance testing, both on the NGS platforms, which will give us much more data. I think the key issue that one should think about is
whether there is an accumulation of archival mutations that will eventually impact what happens in the future. That, I think, is an answer that we need. We need data to answer that question. As always, we should individualize. I mean, I think that it's ridiculous to take a doctrinaire stand when you're dealing with a patient who has a problem. The patient's problem needs to be addressed. And like Kumar Swami said, there's so many options that we have.
Let's probably wait for beta driver based regimens also to come up in the near future. Okay, can we have a poll again? Anybody who is against this proposal?
I want to tell one of my experience. 76 years old man is on tenofovir and lamivudine regimen since long, but he is okay till no bone fractures, nothing. So it is not 2-drug regimen or 3-drug regimen that causes bone disappear. In my 25 years practice, only 2-3 people got this vascular necrosis of femur. So it's our monitoring only.
Thank you, ma'am.
Our monitoring only.
Thank you. Any need for a poll? Anybody who is against switching to 2-drug therapy? Okay. Yeah. So all is converted. Good for the 4 people. Thank you. Thank you again, once again, for the organizers.
We would like to call upon the chairpersons to felicitate the debaters. Starting with Dr. Neha Mishra, Dr. Satish Rao, Dr. Haripriya Challa, Dr. Vikrant Shah. We would like to call upon Dr. S.K. Guha to please felicitate the chairpersons. We would like to start with our next session titled Micro Enemies in HIV When Infections Don't Read the Textbook. Our chairpersons for this session are Dr. Harsh Toshniwal from Ahmedabad and Dr. Falguni Parik from Mumbai. We hand over the proceedings to our chairpersons.
Good afternoon, everybody. Now we come to a very interesting session, just like how with effective antiretroviral therapy, patients are living longer, but they are getting non-communicable diseases. There are certain infections who are very smart and they still happen in patients with HIV. So let us hear from the experts. I call upon Dr. Aisha Sunawala.
Suswagatam, welcome Dr. Aisha Sunawala to ASICON 2026, Mumbai. A leading clinician from Mumbai, she plays a pivotal role in managing complex HIV cases, especially in evaluating febrile illness in patients on ART. Today, she speaks on the febrile patient on ART, thinking beyond the usual suspects.
Okay, so good evening, everyone, and thank you to Dr. Trupti and the organizers for having me here. So I'm going to talk about the febrile patient on ART and thinking beyond the usual suspects. Now, we're all, as HIV practitioners practicing today, we're all breathing easier in the comfort of this catchphrase. And like the U equals U catchphrase, there are many more easily manageable chronic viral partnership, very impressive lifestyle disease, age-related complications, outpatient management, life compatible, from death sentence to daily pills. So quite dramatic. But is there really a predator lurking within, waiting for an opportunity to grab more than the unsuspecting patient, even the unsuspecting clinician? So is this all wishful thinking? And does undetectable actually equal uncomplicated? Well, let's find out. So if we were to sort of look at the algorithmic approach to fever in the HIV patients, in the context of ART, we could broadly divide them into patients who are ART naive, failure, recently started on ART, and those who are virologically suppressed. Now, these three groups could ideally be grouped together because the etiologies would be somewhat similar, with the base of a pyramid of etiology clearly being opportunistic infections, followed by other infections, malignancies, autoinflammatory, etc. On the other hand, in the virologically suppressed patient, this pyramid would really sort of, flip on its head, such that opportunistic pathogens are at the very bottom, if at all, with more infections being community in healthcare, drug toxicity, malignancy. Of course, both the latter groups, the recently started on ART as well as the virologically suppressed, high-risk must be an important consideration in them. And there's a little overlap over there, which we will discuss in detail. So if I was to expand the lens on PLHIV and fevers, we could look at 7 I's, broadly categorize it as 7 I's. What are these? Infections, intercurrent infections of aging and geography, and we'll go into details on that, but most importantly, pneumonia, pyelonephritis, tropical fevers, TB, of course. Incomplete immune recovery, especially in patients with a low CD4 nadir, patients who have discordant response, and patients who are recently started. Iatrogenic causes, and we know there's a host of those. High risks, of course, extending beyond the causes just described here. Immune dysregulation, autoimmune conditions, ITP, sarcoid, SLE, and inflammatory conditions like HLH, which are triggered, secondary HLH, triggered by some of the opportunistic infections. So, and then there are infiltrative conditions like CAPO-C, NHL, non-AIDS. I forgot about that. Yes, so 7 I's over there. Now let's go a little more into detail into these. So let's start with intercurrent infections of aging, geography, and these related to incomplete immune recovery. I'm going to put a question out to you. Which of the following pathogens do you feel is the most virulent? Cryptococcus neoformans, Pneumocystis jirovecii, strep pneumonia, or cytomegalovirus? Any takers there? Anybody? Okay, so someone, why do we say it's strep pneumonia? Why not the others? They're so uniformly fatal and, morbid. But strep pneumonia is acute in onset, a sort of dramatic progression, causes invasive disease with high mortality, even in the immunocompetent population. Whereas the others, Cryptococcus, PJP, CMV, are also fatal, but they're opportunistic pathogens with a more indolent course. So clearly, in terms of virulence, they scores above the others. The point I'm trying to drive home over here is that in patients living with HIV on ART, they still remain susceptible and perhaps more so to these virulent pathogens which affect the general population. And one of the most studied of these pathogens is strep pneumonia. So this is a Danish study which was done on over 3 lakh patients, sort of HIV patients and controls at different time points. And what they did find here in this sort of simply shown bar graph is that definitely the incidence rate ratio of pneumococcal pneumonia reduces as the CD4 increases. But even at a CD4 value of more than 500, the risk remains higher than the control population. All right. And in fact, it remains 7-fold increased risk of invasive pneumococcal disease as compared to the general population. Multiple references starting from 2008 going down to 2025. The IPD risk remains elevated even with virological suppression and CD4 more than 500, like I showed you. Mortality rates reach as high as 25% for PLWH, even in the modern CAR-T era. And these patients exhibit diminished serological responses and rapid antibody decline following pneumococcal vaccination, which is probably one of the contributing factors here. They also remain at higher risk of other infections like sinusitis, otitis media, MTB, NTM, some of the herpes viruses, UTIs, pyelonephritis, skin and soft tissue, vulvovaginal candidiasis, chronic dermatophyte infections. And I think all of you will bear me out with your patients. Even our chronically well-suppressed patients doing well on HIV have these intercurrent problems from time to time. And we see them getting admitted and coming to our OPDs with this. And this appears to be sort of, related to this legacy of prior immune collapse that they have had, which leads to this incomplete restoration of the CD4 memory T cells, B cell function and antibody responses to encapsulated bacteria, particularly T cell exhaustion and dysregulation, which are again facilitated by some viruses like the herpes and CMV viruses, altered mucosal barriers in the lung, gut, genital tract, smoldering reservoirs of low-level viral replication, which are present in these patients, and reduced vaccine responses. And it's not just pneumococcal vaccine. We've also seen reduced responses to influenza vaccine, to hepatitis B vaccine. And it's thought that, the germinal centers within the lymph nodes are actually critical sites for antibody development and immune memory. And these are irreversibly sort of damaged with HIV, even some of them having fibrosis. And therefore, the reduced vaccine responses are explained. Now let's move on to the iatrogenic causes of fever in these patients. So when I started out, this is from way back in 2012 when I was training at Hinduja under Dr. Soman, and we had a patient with nevirapine-induced SJS. And as we went on, we thought, we were done with those toxic drugs and we wouldn't see reactions like this. But we've seen drug reactions from time to time. This lady actually had a mild reaction to TMP-SMX and was switched to dapsone. And she developed fever, she developed lymphadenopathy, a mild macular rash initially, hepatitis. Her peripheral smear actually showed atypical lymphocytes, and the CMV viral load was over 2,000. So she was initially thought to have a CMV syndrome. And it was only, as things evolved that we realized that this is part of a dapsone syndrome that she has. And she had this kind of exfoliative dermatitis. And then we have this patient who presented with DRESS on dolutegravir. And this has been reported very rarely, but we stopped the drug and he actually reversed. Moving on to iris versus inflammatory and immune dysfunction in HIV. So I'm going to start with a case. And this case really takes us through so much and taught me so much. This was a 34-year-old male, single homosexual, diagnosed with disseminated COX, spondylodiscitis, effusions, generalized lymphadenopathy. He was found to be HIV positive at the time with a baseline CD4 of 61, viral load of over 10 lakhs. He was started on TMP-SMX and weight-based first-line AKT. He had some initial improvement with defervescence and weight gain. BDRL was positive on the baseline testing. He was treated for this. And 4 weeks later, he was started on antiretrovirals. About day 9 into his antiretrovirals, he develops high-grade fever and chills, dry cough, pancytopenia, which is coming on, raised ESR, CRP, blood and urine cultures are sterile. He had sort of been worked up extensively, nothing really coming up. We just had a procalcitonin, which was 22. And we had a CMV viral load, which was 32,000 copies. All right. This gentleman had no response to empiric antibiotics or IV ganciclovir. So we considered paradoxical TB iris. Now there are certain clues and caveats that we've always gone by before we make this diagnosis of TB iris. Patient has to be on appropriate AKT based on either a genotype or phenotype susceptibility, weight-based AKT with appropriate dosing, adherence, interactions, drug levels if needed to be checked. Initial improvement followed by worsening, of course, is the dictum. Abrupt withdrawal of steroid or immunosuppressant is a very strong positive influence. Atypical exaggerated presentation with marked inflammation or suppuration is something that you see in these patients. And there's often concurrent resolution of some lesions with development of new foci somewhere else. There could be neutrophilic inflammation, AFP may be seen, may not be seen on smear, and generally cultures are known to be negative, but in early iris, this may not be so. So we considered this. This patient had a PET done right at the beginning, and it was about 2 months into that. So we repeated a PET, and you can see from November to January that there's a marked difference. So the lymphadenopathy has practically resolved. The spondylodiscitis is no longer lighting up here. And you can see the lymph nodes, cervical lymph nodes also. Significant resolution. So clearly this doesn't fit into iris. So this is an advanced HIV recently started on ART, disseminated TB with clinical radiological response. Latent syphilis, which has been treated. Post-ART develops fever, progressive pancytopenia, which is now transfusion dependent, hepatosplenomegaly, and CMV viremia. So a whole lot going on over here. And during the workup, this is what we found, had a high ferritin level, the SCD25 high, and the bone marrow showing us HLH. Mind you, I've tried to compress this. This all happened over several weeks, and the initial bone marrow was negative. So we really struggled with this patient. He met 6 out of 8 criteria for HLH. He had a dramatic initial response to steroids. The procalcitonin actually reduced on steroids from 22 to 1.36, showing us that in these kind of high pro-inflammatory conditions, with a lot of cytokine production, it's very difficult to use procalcitonin to differentiate bacterial from secondary HLH, and we found this reference. So HLH and HIV develops more frequently with chronic uncontrolled HIV infection. There's an overlapping sort of pathogenesis and signature pattern. It's fever, hepatosplenomegaly, lymphadenopathy, cytopenias that are seen in various disseminated opportunistic infections as well as in iris. And 1/3 of patients with severe TB iris also met the criteria for diagnosis of HLH as per this reference here. These patients were found to have a more prolonged and refractory clinical course. If we were to continue with our case, he had multiple relapses on minimal steroid tapers, kept coming back for admission. Etoposide was started, ruxolitinib was considered, but he eventually succumbed to severe bacterial sepsis. Young man, we couldn't save him. And there were myriad challenges here. The diagnosis to begin with, were we dealing with a new OI, a paradoxical TB iris, drug fever? Should we have continued the ART or not? He had repeated hospitalizations. He was immunosuppressed. We needed to keep ruling out neutropenic sepsis each time he came in. And as you know, he finally succumbed to a bacterial sepsis. And further immunosuppressants in form of high-dose DEXA, etoposide. So many things were considered, but there was a lot of fear of going ahead with these. Moving on to iris and infiltrative conditions. So again, looking beyond the usual suspects. Quickly, this case of a 38-year-old high viral load at presentation started on treatment, and 4 months later, these symptoms, subacute intestinal obstruction, an HIV viral load that is undetectable. We didn't have a baseline CD4, but you can see over there that there's an intraluminal enhancing lesion in the bowel, and this was a large B-cell lymphoma. So again, lymphoma iris is something that has been well described. About 12% of lymphoma patients in this study met criteria for unmasking lymphoma iris, like this patient did, with a median CD4 of about 170, frequent associations with Hep B, Hep C, not in our patient though, and overall survival at 5 years was similar between the iris and the non-iris groups. These two cases, which I saw perhaps year before last and last year, both of these young men had been started on antiretrovirals within 6 to 9 months of developing skin lesions like this. These are, of course, florid skin lesions, but they had started very subtly, one actually even before starting ART. Now, in this current era of practicing physicians, these were not initially picked up. Both of them had a low CD4 nadir, but they were treated as PUO. Both of them were surprisingly on empiric AKT. And finally, a diagnosis of Kaposi sarcoma was made at Tata Memorial for this patient and by Dr. Sapre at JJ Hospital for this patient. So Kaposi sarcoma iris, again, well described within the first 6 months after starting ART and defined as more than or equal to 2 of the following, which is increase in size of lesions, number, and appearance or exacerbation of visceral abnormalities. And then the usual CD4 and viral load decline. Some things, lung involvement, thrombocytopenia associated with worse outcomes, and corticosteroid therapy actually associated with exacerbation. So I won't take you through this in great detail, but suffice to say that the management of iris for mild cases is purely sort of symptomatic, syndromic. For severe cases even, apart from just life-threatening CNS iris, ART should not be interrupted. Corticosteroids are the sort of mainstay of treatment, but they're not recommended in some cases like cryptococcal or Kaposi sarcomitis. And there's limited data on other immunomodulators. We're still learning that. So coming back to beyond the usual suspects, a suppressed HIV does not suppress epidemiology, and the vulnerability to common infections persists. Remote CD4 nadir may predict future vulnerability, and that should be kept in mind while you're evaluating such a patient. Immunizations are essential, but with unpredictable efficacy in this population. If the fever began after a new pill, please trust the timeline. Think about it. With HIV, the immune system doesn't always recover gracefully. It often overshoots before it recalibrates, and that's something that we need to keep in mind with iris. And the unseasoned next-gen ID physician, which I consider myself as well, must be watchful for atypical, exaggerated presentations of now uncommon OIs presenting as iris. And so if we were to move beyond the usual suspects, perhaps we don't need to think so much out of the box, just out of the box at new avatars of old suspects or usual suspects sometimes. Thank you. Happy to take any questions.
Thank you. Thank you, Dr. Aisha, for a wonderful presentation. Very informative. I think questions will be taken at the end of the session. I now with the pleasure of inviting Dr. Bharat Brandre. We will be talking on cryptococcal meningitis.
To ASICON 2026, Mumbai. A respected clinician from Pune, he plays a pivotal role in managing advanced opportunistic infections, particularly severe CNS complications in HIV. Today, he speaks on cryptococcal meningitis, old pathogen, new lessons.
Thank you. And I thank Dr. Prapti, Dr. Trupti, Dr. Gilada sir for giving me an opportunity. So it's a big topic, cryptococcal meningitis, old pathogen and new lessons. So not possible to cover in just 15 minutes, but the salient features we will discuss. It is a critical topic for HIV physicians, and today I will be focusing on the cryptococcus species, primarily two species, neoformans and gattii. And these both species can cause severe meningitis in HIV patients. And there have been certain recent advances in the management of this infection, especially the WHO guidelines have been updated. There are novel therapies which are coming up, and there are simpler, safer treatment options that are being available. And there are still ongoing challenges such as the flu cytosine availability. So let's discuss the epidemiology of the cryptococcal meningitis. This remains a leading AIDS-related AIDS death cause. And annually, there have been 150,000 cases all over the world and 112,000 deaths. Most of these deaths are happening in sub-Saharan Africa, and it's nearly causing 20% of the AIDS deaths. And I'm sure that the audience sitting here must have witnessed many patients who either had it or who had died while being treated for cryptococcal meningitis. In HIV patients, especially those with CD4 counts less than 100, the incidence is high despite of the ART scale up. And there is a rising risk of this infection because there have been certain funding cuts in some of the countries and the advanced HIV infection that we still see in our OPDs. The mortality of the infection is 20 to 30% in high income countries, but it can reach up to 70% in Africa because there have been diagnostic as well as treatment gaps. So to give you the overview of the cryptococcal species, it's an old pathogen, it's not new. Actually, this pathogen was first discovered from the peach fruit, and that was way back in 1894. And it was found to be human infection cause in the same year. These yeasts are actually predominant in the environment. They grow in the soil. They are present in the barks of some plants, especially the eucalyptus trees. They are present in bird excreta such as pigeon guano. The genus Cryptococcus species is comprising of 30 species, and that belongs to the Basidiomycetes group of the fungi. But clinically relevant infections are caused predominantly by the two main species. One is Cryptococcus gattii and Cryptococcus neoformans. The yeast forms of both these species, they actually appear as spherical cells of 4 to 6 micrometer in size. Under the microscope, there is a surrounding distinctive polysaccharide capsule. And these fungi, especially the neoformal species, they cause disease in HIV positive or immunocompromised people, and gattii can also affect the competent persons, and therefore it is considered to be more virulent. How does the infection spread? The infection generally is a pulmonary in origin. We inhale the spores, then they go into the pulmonary circulation, and then they gradually disseminate into various organs, including brain. And the polysaccharide capsule of the fungus evades the phagocytosis. What are the new lessons in this infection? The fungus is gradually becoming resistant, especially to single drug therapy, such as single drug therapy with fluconazole. Gattii has been causing many cases in immunocompetent people, and the climate change is expanding the range of the infection in various countries. How does the disease clinically present? So it presents as a subacute headache. It's not an acute illness, although sometimes it can come on acutely. Most often it will present as subacute onset headache, fever. Headache can be such severe that patients want to bang their head on the walls. And sometimes the headache is also related by certain things such as even smoking. Patients do come with low-grade fever, altered mental status some of the times. Neck stiffness is not that common, and only half of the persons can actually present with neck stiffness. The disease can come with debilitating cranial nerve palsies, papilledema, and the main killer in this disease is the high intracranial pressure. Focal signs in disease are rare, although they are not uncommon. The disease closely mimics TB meningitis, and I have seen several patients being treated with empirical ATT and turned out to have cryptococcal meningitis later. So screen all your patients with CD4 count less than 200, especially if it is less than 100. Please screen all your patients for cryptococcus antigen. How do you diagnose this disease? The diagnosis, the gold standard is demonstration of cryptococci on the CSF. So you can demonstrate them by indent, which is a very simple test, and it shows you encapsulated yeasts. The other simple test that is available is Cryptococcus antigen lateral flow assay, which is a point of care test, and that can give you a diagnosis in 30 minutes. The sensitivity of this test is more than 95%, and fungal culture also is the gold standard for diagnosis of this infection. However, it will take some time for the fungi to grow. Typically, it will take 1 or 2 weeks in most of the laboratories for the CSF to grow this fungus. The CSF will usually show lymphocytic pleocytosis. Definitely, most of the people will have low glucose there and high protein there, and culture will confirm the diagnosis. There are certain poor prognostic markers as clinically as well as in the CSF. And for example, a CSF low white cell count or high titer are having poor prognostic markers. We have to remember as physicians that we have this multiplex PCR called as BioFire for diagnosis of meningitis on the CSF, but it has a slightly limited sensitivity to pick up this cryptococcus, and actually the performance of cryptococcal antigen on the CSF is better than BioFire. Serum cryptococcal antigen screening for patients who have got CD4 count of less than 200 can prevent overt disease, and we actually give somewhat called as a preemptive therapy with fluconazole in this setting that I will discuss in the next slide. So the treatment for a diagnosed case of cryptococcal meningitis, the WHO in 2022 has preferred this regimen. There are actually 5 regimens which can be used, but the preferred regimen is a single high dose liposomal amphotericin B, which is given at the dose of 10 milligrams per kilogram on day 1. And this is followed by flucytosine plus fluconazole in a higher dose for 2 weeks, which is supposed to be the induction regimen. And this is supposed to be non-inferior to 7 days amphotericin B deoxycholate. This is associated with fewer adverse events. So this AMBILOTE trial actually informed this recommendation by WHO. The alternative in the resource limited setting could be 1 week of deoxycholate amphotericin B, which is given typically at the dose of 1 mg per kg per day along with flucytosine. And later on you transition these people after 2 weeks onto oral fluconazole. It is very important that we manage intracranial pressure. This point is often overlooked while treating cryptococcal meningitis. And sometimes we have ended up doing daily lumbar punctures of all these patients if the opening pressure was more than 25 centimeters of water. So out of the 5 regimens, actually I have just put here 2 regimens of cryptococcal meningitis because they are the most commonest ones that we are likely to use in our setting. And so currently we are using this first regimen, single high dose liposomal amphotericin B followed by 2 weeks of oral flucytosine and fluconazole. When coming to the consolidation phase, so after first 2 weeks of the induction phase of cryptococcal meningitis, we go on to the consolidation phase. The consolidation phase lasts for 8 weeks, and here we give a higher dose of fluconazole orally, 400 to 800 milligrams per day. And thereafter, there is a maintenance phase in which we give them fluconazole for 200 mg per day for nearly 1 year. And after that, after certain indications are met after 1 year, we can stop the maintenance regimen. The ART, when to start ART in this patient is the key issue. And this court trial actually informed this decision that we have to start ART a little later, like 4 to 6 weeks down the post-induction phase to minimize the iris. For those patients who have got asymptomatic cragemia and don't have overt meningitis, generally after finishing of first 2 weeks of the fluconazole, we are going to give them the antiretroviral therapy. What are the new lessons and challenges in cryptococcal meningitis? There is a flucytosine shortage all over the world. It's a global shortage. Initially, we used to get flucytosine in a big box, which costed some 18,000 rupees. Now we can get in strips. Sometimes it is available, sometimes it is not available. But there is this new trial which has started in Malawi and Tanzania last year, which is an open label randomized phase 2 trial for the new sustained release of flucytosine formulation. So it actually simplifies the doses of flucytosine from 4 times daily, which is a standard dose, to twice daily. This comes in a pellet form. This makes it easier to take it with water, or it can be also given through the nasogastric tube, and it is suitable for outpatient self-administration. Cryptococcal iris is an important challenge during treatment, and you have to differentiate it from relapse. And typically, it is negative CSF culture will tell you that this is a cryptococcal iris and not a relapse. The shorter treatment regimens which have come in vogue for this cryptococcal meningitis have reduced toxicity, and the crack screening uptake is still low despite of the guidelines. That's what has been observation. Generally, for cryptococcal meningitis treatment, we don't give any adjunctive steroids. In fact, there was a trial called as CryptoDex trial, which actually said that it could be even detrimental to give dexamethasone during the intensive phase of the cryptococcal meningitis, and we have to actually monitor electrolytes, creatinine, when we are giving amphotericin B. What are the newer avenues for the treatment? So there is a formulation called as coagulated amphotericin B, which is endocoagulated oral formulation that has been now being under evaluation for various fungal infections, including cryptococcal meningitis. There are newer antifungal agents such as voriconazole, posaconazole, isavuconazole, fosmanogepix, ostaseconazole, and quileseconazole, and micrograb. So here I am going to talk only about micrograb. So micrograb is a recombinant human monoclonal antibody which is targeting the fungal heat shock protein HSP90. This is being investigated as an adjunctive therapy for AIDS-associated cryptococcal meningitis. The drug has been developed by Novartis, and this micrograb has showed in vitro synergy with amphotericin B against Cryptococcus neoformans, and it enhances the fungal clearance and disrupts the cellular stress response. Actually, the drug was in the phase 2 trial, but somehow the trial was prematurely ended, and we don't know the reason why the trial got ended, and this data is yet to become available. People have also used adjunctive therapies for cryptococcal meningitis, such as many new or repurposed drugs such as sertraline, clofazimine, miltefosine, cyclopirox, oranofin, mefloquine, tamoxifen, and benzimidazoles. So here I'm going to talk only about the sertraline. So sertraline was evaluated in AstroCM trial for adjunctive therapy at a dose of 400 mg daily for 2 weeks during the induction therapy of cryptococcal meningitis. But unfortunately, there was no reduction in the mortality or fungal CSF clearance, and the trial therefore was stopped for futility. Another new avenue for cryptococcal meningitis is this new technique called as neuroaparesis. This is the CSF filtration therapy. This was originally designed to actually treat hemorrhagic stroke to remove the blood from the CSF. But here, what is being done is that CSF is removed and filtered and reintroduced into the CSF space via double lumen cathode, which is placed in the mid-thoracic region. And there have been in vitro studies in cryptococcal meningitis that have shown rapid yeast clearance, but it is in the rabbit models and it is still under investigation. But it is one of the new and promising therapies for cryptococcal meningitis. The preventive strategies: screen all your patients if they are asymptomatic, if their CD4 count is less than 100, especially if 100. But now guidelines are also saying that sometimes if it can be below 200 also, you can screen them. And those who actually turn out to be positive, then give them a preemptive treatment for cryptococcal meningitis, which is 800 milligrams per day for 2 weeks. And later on, it goes into the induction and consolidation and the maintenance phases. But for this preemptive therapy, patient should not have any meningitis. The ART initiation is critical, and the right point of time you have to do the ART initiation. For those having symptomatic meningitis, it is 4 to 6 weeks after induction therapy, and for the preemptive, it is 2 weeks after the induction therapy. And you have to target the advanced HIV disease which has caused this infection. The vaccine research for cryptococcus is ongoing, but it is not yet ready. Coming to the last slide. So the key takeaways from today's talk were that we have to adopt a single dose, high dose liposomal amphotericin regimen wherever it is possible, because it is simpler and it is safer and requires less hospitalization for less critically ill patients. We have to combat the 5-FC shortage and push the screening to prevent the cases. So it's an old pathogen, and we are now going to get gradually new tools for it. And early diagnosis and updated treatment will save lives because of this infection. Thank you.
Thank you, Dr. Bharat, for your, explaining this complex infection in a short time of 15 minutes. I would request you to come here on the dais, even Dr. Aisha for that matter, because we'll take questions at the end of the session. I now request Dr. Vasant Nagvekar to talk about re-emerging viruses.
Suswagatam. Welcome Dr. Vasant Nagvekar to ASICON 2026, Mumbai. A distinguished infectious disease expert from Mumbai, he plays a pivotal role in strengthening preparedness against re-emerging viral infections. Today, he speaks on re-emerging viruses, preparing for the next viral challenge.
Good evening, everybody. At the outside, I would like to thank Dr. Trupti and Dr. Ishwar Gilada for giving me this opportunity. Trupti gave me this topic about re-emerging viruses, preparing for the next viral challenge. And a few weeks back, a film writer had met me and he was asking me that he wanted to make a Zenji film after COVID, which can create a havoc, in the world. And I think after this chapter, I gave him two ideas. One is Ebola and second is yellow fever. So I think I'm going to take you through. So I'm going to speak about viruses predominantly which are sexually transmitted and one virus which is not. So sexually transmitted infections remain prevalent in the 21st century and constitute a health and economic burden globally. As a long-term goal, the WHO has endorsed global STI strategy that targets to eliminate the STDs by 2030. Regrettably, more than 50% of new STI cases are found among adolescents, and 80% of the infections are widespread in developing countries which have limited resources. To this point, about 30 types of known infectious agents such as bacteria, viruses, fungi, parasites, and whatnot, I'm going to talk to you about today is about the viruses. And the outline of my talk is about the HTLV1, HTLV2, monkeypox, Ebola, Zika, Porapauchi, possibly we've not heard about this, and the yellow fever. So let's come to HTLV1 and HTLV2. I think we have heard about this virus during our MBBS and MD days, about the ham and the tropical spastic paraparesis, what it was associated with. So HTLV1 and HTLV2 are strikingly different in terms of clinical impact, as the only HTLV1 is conclusively associated with neoplasma, that is adult T-cell lymphoma or leukemia, which develops in 5% of the infected individuals. There's no specific test available, but the reliability of this test in India is not really the big question mark. A similar percentage of HTLV infected persons develop a neurological disease, that is HAM, that is HT will be associated paraparesis, or we call it as TSP, that is tropical spastic paraparesis. In contrast, HTLV2, though persistently associated with elevated lymphocyte and platelet counts and with an increase in overall carrier mortality, cancer mortality, does not cause hematologic disorders and is only sporadically associated with myelopathy. If you see the two main viruses, one is predominantly seen in Japan and the other one is seen in Europe, South and Central America. Coming to monkeypox, it's a DNA virus, and you can see that it has basically three clades. The clade 2 has been further divided into clade 2 and clade 2b. And if you see, it's predominant in Central Africa, West Africa, and new from West Africa again. This is how the spread occurs. Actually, though we call it as monkeypox, but exactly whether it is the monkey which transmits or whether it is other animals is not very clear. It could be the rodents, it could be squirrels, or it could be monkey, and it transmits to the humans and then humans to other humans, and then it keeps causing a global transmission. And what we saw that in India also we had few cases. So till 2024, India had confirmed cases of more than 30. That is not a big number. What we saw in the last case, I think what we saw was in 2024. This data is of 2024. If you see the features of classic monkeypox and the new clinical epidemiologic form, it is seen especially young men who have sex with men. It is exclusively human to human transmission, mostly sexually networking, condomless sex with multiple male partners. Whereas symptoms in the classic forms is usually with lymphadenopathy and lesions on the face and extremities, centrifugal. Whereas here, the new clinical epidemiologic is with penile rash, perianal lesions, ulcerative lesions, and vesicular rash, painful inguinal lymphadenopathy, pharyngitis, and proctitis. So these are the monkeypox lesions which would be seen, and it sometimes becomes difficult to differentiate between chickenpox, histoplasmosis, penicillium barnaffe, which is called as telomyces. I think these are the differential diagnoses, and of course molluscum contagion, but molluscum will not have such extensive involvement. So these are the few pictures I've taken from NEGM, which because India we have hardly had 30 cases proven. So these are how it could present, and it could be a future problem for the global if this keeps spreading. These are the evaluation of cutaneous lesions. You can see that day -4 condomless sexual contact. On day 0 single genital lesion. Day 4, day 6 feeling unwell, having systemic complaints. Day 11 confirmed as monkeypox, the facial and the genital lesions. Day 20 a follow-up. You can see the series of lesions, that is follow-up facial lesions where the PCR is become negative, and day 28 follow-up genital lesions, again the PCR is becomes negative. These are the oral and perineal lesions, how it would be presenting. I mean, extremely difficult sometimes, but this is how it would be present. And I think we should be knowing about this in future, because I'm sure that in future 10 to 15, 20 years, we'll have more and more such cases being. These are the one how you can have perianal, anal, and rectal lesions, which can present as monkeypox. And if you see the about monkeypox, it's a viral zoonosis caused by the monkeypox virus of orthopox virus genus. The disease was first discovered in 1958 in monkeys and 1970 in humans. Transmission occurs through direct contact with lesions, body fluids, respiratory droplets, and contaminated materials. The cessation of smallpox vaccination campaigns has contributed to the rise in the cases. Traditionally, monkeypox prodromal phase presents with fever, headache, and lymphadenopathy. followed by characteristic rash that progresses through macular, papillar, vesicular, and pustular stages. However, the clinical features observed in the current outbreak are typical. The presence of fewer lesions with localization to anogenital and perioral regions and development of complications like proctitis, tonsillitis have been reported more frequently, making diagnosis really challenging. Conventional and real-time PCR or the lesional fluid can diagnose 97% of the cases. If you see monkeypox, experts give this virus variants. That is, as I said, clade2 has two subclasses, 2A and 2B. Whereas if you see the viral persistence kinetics, the fever is there only for first 2-3 days, and then the lesions come up. And if you see, from the nasopharyngeal swab or from the lesions, it will be detected up to 21 days. From the lesion, majority of the lesions, your RT-PCRs would be positive only up to 21 days, and beyond that, it is not positive. And this is again about how the kinetics about monkeypox DNA works. The differentiation between monkeypox and chickenpox predominantly, measles is simple. I think monkeypox, if you see the rash, lesions often in one stage of development, whereas in chickenpox, lesions often in multiple stages of development. Monkeypox rash development is slow, whereas in chickenpox, you'll see within 48 hours, the full body being covered. Rash distribution is more dense on the face and it is centrifugal, whereas in chickenpox, it is more dense on the trunk, absent on the palms and soles, whereas in monkeypox, predominantly it is seen on palms and soles. Lymphadenopathy is absent in chickenpox, whereas in monkeypox, lymphadenopathy will be present. So lesions, centrifugal with slow spread with lymphadenopathy may make you suspect monkeypox. And these are the differential diagnoses what you can have because of monkeypox. Coming to the Zika virus. The Zika virus, so far, if you see, maximum cases were predominantly from Maharashtra, and that is from the Pune, in and around villages from Pune. Mumbai, very few cases reported, but predominantly it has been from Maharashtra, 151 cases into 2024. Coming to Zika virus, the discovery was from 1947. Then it went up to Asia at 66, and then to America in 2015, and back to again to Africa in 2015 from US. If you see this Asia, I think India, the first case detected was in 2018. Zika virus, it's a mosquito-borne flavivirus, primarily transmitted by Aedes mosquito. The primary mode of transmission is though through the bite of infected Aedes mosquito. It can also be transmitted to blood transfusions, sexual contact, and from pregnant females to their fetuses, leading to congenital Zika syndrome. Sexual transmission has been documented in both heterosexual and homosexual encounters. The virus ability to persist in semen and vaginal fluids, making sexual transmission through oral, anal, and vaginal intercourse possible is a significant concern. The last line is very important. Zika virus RNA has been detected up to 188 days in the semen, 3 days in the vaginal fluid, 11 days in the cervical secretions RT-PCR, 69 days in semen by culture, and even the virus is no longer detectable in blood and urine. This proves that the virus poses risk of transmission long after its initial infection. Most patients with acute Zika virus infection are either asymptomatic or they have mild symptoms. In symptomatic infections, usually fever, rash, conjunctivitis, which clearly differentiates it from dengue virus, because dengue usually is not associated with conjunctivitis. And the rash also is, though we see in dengue, it is more predominantly seen in Zika virus. Less commonly is edema. Edema feet is another feature of Zika virus, which is again not commonly seen in dengue virus. Conjunctivitis and rash are more commonly seen in Zika virus infections than dengue fever or chikungunya. If you see the modes of infection, it is mosquitoes, sexual transmission, blood transfusion, pregnancy. 80% of them would be asymptomatic. Complications are less than 1%, and serious complications are associated with Guillain-Barré syndrome, ocular hypertensive iridocyclitis, thrombocytopenic purpura, transient myocarditis. A pregnant lady, if you see, if she is infected with Zika virus, 70 to 80% of the times, it is the neonates are without infection, but 20% of the time, 20 to 30%, the fetal or the neonate would be affected with infection. Fetal loss in 2%, 5 to 14% congenital Zika syndrome, and in asymptomatic around 80% or uninfected. This is how actually the left-hand side is how a normal baby is. If you see typical head size, baby with moderate microcephaly, baby with severe microcephaly, and this Zika is also sexually transmitted, and that's why I'm talking about it here. Zika virus, this is another picture again from NEGM, which talks about calcifications, about the brain size became smaller, and there is increased ventricle size. This is how the Zika virus affected boys, children would look after their mother has been infected. Coming to mortality associated with congenital Zika syndrome, this is very, very interesting. If you see this, this was a study which was done in Brazil. A total of 11 lakhs, almost 114 lakhs live-born children were studied. In fact, in that they saw that the deaths in the children who are associated with Zika congenital syndrome was much more higher compared to those who are not affected. And this graph clearly tells you those who had congenital Zika syndrome, the mortality is much higher. The graph is much wider compared to people who did not have congenital Zika syndrome. Most Zika syndromes are asymptomatic. Treatment is supportive and abstinence from sex for at least 3 months. I think that's important for all of us to note. Abstinence from sex for 3 months after the symptom onset is very important. And women who are trying to conceive who are infected should not getting conceived for at least 2 to 3 months after the Zika virus infection. That's very important. If you see the differentiation between dengue, chikungunya, and Zika, fever is the predominant feature in dengue. Chikungunya is arthralgia, whereas if you see maculopapular eczema in Zika and conjunctivitis, which is most important feature of edema and conjunctivitis, that's that's a feature. And if you see the amount of people who have developed Guillain-Barré syndrome after Zika virus, it is close to 7%. It is 2 to 5%. If you see the number of people who are affected and number of people who develop Guillain-Barré syndrome, it is around 2 to 3% of the people who are affected with Zika who develop Guillain-Barré syndrome. And this graph tells you that whenever there is Zika virus, there is increased incidence of Guillain-Barré syndrome. So one is microcephaly and second is associated Guillain-Barré syndrome, which again this is sexually transmitted. The persistence of Zika virus in the body fluids, I'll just say the last slide, the median 95% of Zika virus RNA detection were 15 days to 41 days in the serum and 11 days to 34 days in the urine and 42 days till 3 months in the semen, which we discussed. Next comes is the Ebola. It's a monster actually, and it is again transmitted through bats, gorillas, chimpanzees to humans. And most important is the infection control practices, which is very, very important in Ebola virus because the mortality is extremely high and they come with general symptoms, and detection of these general symptoms in an outbreak is very, very important because it is highly contagious because it just gets transmitted to the skin. Even little secretions from the patient who is infected would make the other person get infected. So Ebola virus is a member of filoviridae known as causing severe hemorrhagic fever. And if you see, there were 28,000 confirmed cases and 11,000 deaths. Significant. So every second or third patient dies because of Ebola because of this. So human to human transmission occurs through direct contact with blood, body fluids, and vertical transmission from mother to fetus and resulting in stillbirths and miscarriages. Sexual transmission through semen has also been identified in Ebola virus. The incubation period is 2 to 21 days, and Inmazeb is the first approved monoclonal antibody which can be worked. If you see the progression of this disease, it has initially febrile and predominantly it has a GI symptoms. So people mislead it. Very important about Ebola virus is that this important component of the main is Ebola is just not one of the many neglected pathogens which we are still ill prepared. And here, I think even keeping the religious matter side, the person who dies because of Ebola actually has to be buried and not, going through the Hindu ritual way. That is very, very important part about Ebola. This is a differentiation slide, how differentiating. Just a couple of slides. This is Oropauchi, another sexually transmitted virus, not seen in India, but we have to be aware about these viruses which are again sexually transmitted. Yellow fever, again, this is I think we have the Aedes aegypti mosquito in India, and I think it's only, we don't know whether it's 5 years, 10 years, 20 years, but we should be aware about yellow fever. And this is quite a devastating, because the mortality associated here is around 15 to 20% those who develop yellow fever. infection. So coming to my last slide, apart from recent increases in the curable STIs, newer and emerging STIs pose a significant challenge to healthcare services and infrastructure. Newer infections include viruses that persist for long in the bodily fluids, requiring prolonged testing and abstinence, and as I said, 3 months sometimes, and resulting in congenital infections. Epidemiologists and specialists should keep themselves updated about these diseases to identify them early and reduce the resultant morbidity and spread. Thank you for your kind attention.
Thank you, Dr. Vasant, for giving a detailed account of rare viruses which can be transmitted sexually, right from HTLV to Ebola and yellow fever. I request you to take chair here. Last, invite Dr. Subramanian Swaminathan to deliver a talk on HIV and transplantation, breaking the myths.
Welcome Dr. Subramanian Swaminathan to ASICON 2026, Mumbai. A leading expert from Chennai, he plays a pivotal role in integrating HIV care with transplant medicine and challenging long-standing misconceptions. Today, he speaks on HIV and transplantation, breaking old myths.
Good evening. I'm sorry, I was just stunned by the visuals. So, first, let me thank the organizers for the opportunity to be here, and always lovely to see my teacher. My involvement with HIV was about 20 years ago. My involvement with HIV now has moved to specific areas, and transplant is one area where I still keep in contact with HIV. So,
Slide changer.
okay, slow the slide changer. Okay, awesome. Okay, got it. We're good. We're in business. Awesome. Okay, so we're going to, I see two groups of people here. One group is people who already have patients who have HIV and transplant. And the other group are people who are going to see patients like this. How many of you currently have a HIV infected patient who has undergone a solid organ transplant? Okay, the rest of you don't have to worry. It's only a question of time. It's going to happen. So why am I saying that? The whole day we've been talking about how there is so much more treatment options available, how we are able to cheat death today, almost like a Lazarus effect in the last 25 years, where patients are now living better. But that also means that we now have people succumbing to other problems, cardiovascular, renal, liver, and cancers and things like that. DAD cohort showed that AIDS-related death has fallen off in the 12 years that they started measuring. And if you were to follow this up further, you'd see the numbers falling up even further. But that basically means now patients are dying of non-communicable diseases, which includes cardiovascular, oncological, and things like that. So obviously, care of these things become more important. And the problem is these people are more vulnerable to liver and kidney and such diseases. And we'll talk about that. Why is that so? So in the pre-heart era, till about 2010, nobody talked about solid organ transplants or any transplants for these patients. Why? Because the outcomes were uniformly disastrous. Pittsburgh data in the early days, survival was 3 years. So in 3 years, what about 46%? Pretty bad. Most of them died of AIDS or HIV-related disease. So doing a transplant was considered wasting a good resource, wasting an organ. And unfortunately, while it sounds very cruel, it's the absolute truth. And therefore, HIV at that time was considered a strict contraindication for anybody undergoing a transplant. And therefore, this was based on previous data which said the outcomes were very bad. And at that time, when they assayed people, when they talked to people, everybody said they would not do it. And they would definitely not recommend people to do a live transplant because, you know, can you mobilize a person to part with a precious resource like a kidney when you know the outcomes are really, really horrible? Things changed, of course. And over the last 25 years, we've come a long way. It started off with recipients who are HIV infected getting organs which are HIV from HIV negative donors. From now to a situation where the Hope Act said it's okay to go ahead and start giving HIV infected organs to HIV positive recipients. And we now have case reports of HIV positive donors to HIV negative recipients. And we'll talk about that very briefly. So the data on this, a lot of it is from the Western world. It is a little troubling that we don't have good quality Indian data. Outcomes is pretty good. The graft survival at 1 year and 3 years and the overall survival is pretty decent, and it's comparable to HIV negative cohort. Liver, as you can see, kidney, really nothing much happens. If you lose your kidney, you can always go back to dialysis. Liver is not so forgiving. You lose your liver, well, either you get a new liver or you die. So you can see it's pretty good. The 3-year survival and the 3-year is comparable to those who are HIV negative. If you have hepatitis B, it's a bit of a problem because hepatitis B adds a further complication to it because your treatment options become a little more complicated. We'll try and talk about it. Hepatitis C, again, in the pre-DAA era, before sofosbuvir and drugs like that became available, it was a lot more complicated. Now, of course, even that is no longer a big issue. So, where do we stand right now? Right now, when they looked at a prospective non-randomized study looking at kidney transplant, their inclusion criteria was CD4 of at least 200, viral load suppressed at least for 6 months, and no opportunistic infections. And they realized that patient survival and allograft survival was very, very good, which basically became the holy grail for the guidelines with regards to kidney transplant. So right now, this is basically where we stand. If your patient has got a CD4 of at least 200 and your viral load is well suppressed for a decent period of time, you can go ahead and do a kidney transplant. We generally don't want to do any organ transplant in patients who are profoundly immunosuppressed or with uncontrolled viremia, not just for the patient's safety, but also for everybody else's safety. So, rejection rates was noticed to be slightly higher in HIV-infected patients. Why is that so? In the early days, one, there were much more interactions with the drugs we were using. Before INSTIs became available, we were using boosted PIs and NNRTs, which had multiple drug interactions. And the second thing is that we were also more petrified in using immunosuppression to the level that we normally use. So with better understanding, we are now going ahead and giving them the immunosuppression that we would do for normal patients or non-HIV patients, and therefore it's probably better. But as you can see, in the older days, we saw a lot more rejection. And this was something which everybody jumped on saying, are we doing the right thing? Well, we were doing it wrong, and that's why our results were slightly skewed. And then liver transplant recipients. Again, here they looked at CD4 less than 200 would be bad, and outcomes not necessarily horrible as compared to patients who are HIV negative. So outcomes were poorer if they were HCV co-infected. Remember, from the US, you're not going to see a big cohort of hepatitis B infection. For them, hepatitis C is far more common. So HCV co-infection was bad. A CD4 which was very low pre-transplant was bad. And patients intolerant to medications was a bit of a problem. And remember, this was very long ago. So therefore, when we say intolerant to medication, you're primarily talking about boosted PIs. And boosted PIs in the setting of your immunosuppressive medicines is an absolute nightmare. So later data actually shows that the survival is slightly better, and HIV HCV is almost getting to the level of HCV alone. And what they did notice was that if you have an older donor, your outcomes are poorer. But then you know what? An older donor, your recipient will struggle irrespective of who it is. And combined liver kidney generally tends to do a little poorer. Spanish data again, HCV genotype 1 was not so great. MELD scoring and centers doing low volume transplants. But all of this is from this pre-sofosbuvir era. This is all in the era of where we were using interferon with ribavirin. And honestly, we all know that was very, very horrible times those days. Today, with in the DA era, these things really don't make much sense. So when we look at hepatitis B, which is probably what we see a lot more on, and in fact, that discussion also happened when we talked about 2-drug versus 3-drug therapy and all that stuff. One of the spanners in the work was basically hepatitis B. So how do you handle that? It becomes a little more challenging, but not impossible. So earlier, the recommendation was hepatitis B immunoglobulin to be given to patients who are HBsAg positive undergoing liver transplants. But now current recommendations are very clear. You don't need hepatitis B immunoglobulin. We have stopped doing that. And you need to be on anti-HBV effective nucleoside inhibitors. Now, obviously, that would mean tenofovir, because entecavir is not going to be very great for your HIV. But then tenofovir can be a challenge because when you start now, of course, the preferred immunosuppressive regimen is tacrolimus based. And tacrolimus with tenofovir is not necessarily that great for your kidney. And that still represents a bit of a challenge. And sometimes you have to resort to a little bit of jugaad. So obviously, you want to start with tenofovir based therapy as your backbone. And with that, we actually have very good outcomes even in the long term. So when we look at drug interactions, that's a major issue. In the pre-INSTI era, drug interactions were almost to be expected, and that did make a big difference to the regimen in terms of how complicated it became for the transplant physician. As it is, trying to dose cyclosporin in those days was more of an art than a science. You kind of keep doing levels and you keep doing some jugaad. Tacrolimus is so much more easier that way. But again, with boosted protease inhibitors and with efavirenz, your cyclosporin A levels were really, really difficult to handle. Now with INSTIs, of course, yeah. The other issues were that ATG, anti-thymocyte globulin, which is also something which is fairly frequently used in the setting of kidney transplants, does cause CD4 reduction. So therefore, in the post-transplant setting, be careful about analyzing the CD4 counts because those counts are not necessarily reliable. I mean, the viral load is still good, but the CD4 nets may not necessarily tell you what to do. And keep in mind that the HIV infection let's say you have a HIV infected donor and the donor is completely virologically suppressed. Does that mean that the kidney is safe? Well, the HIV does tend to go to sleep inside the kidney as well. Even if the viremia is undetectable, the virus can persist in the kidney. And in the long run, there is some data to suggest that it can increase your renal dysfunction in these kind of patients. But again, the data is not very, very sharp, and therefore it's not considered a big deal. So we still accept HIV-infected patients who are virologically stable as donors as well. So, basically, what about HIV to HIV kidney donation? ESRD, HIV to HIV kidney donation, CD4 more than 200, like I said, viral load undetectable, no opportunistic infections, and if there is TB, treatment for at least 6 months. And with that, the outcomes were pretty good. Overall survival and graft survival was pretty decent and reasonably comparable to non-HIV individuals. So basically, you don't have to worry too much about it. This was a landmark publication last year looking at kidney transplants and donors from HIV. And as you can see, whether it is with HIV or without HIV, the donor, whichever the donor is, the outcomes tend to be pretty good. So graft loss and rejection was comparable irrespective of who the donor is. So that's really a vote of confidence saying, don't worry about HIV infected donors. They do tend to do, they do give you good organs and there's no reason to be petrified about it. Same thing with liver. Liver, as you can see, HCV was a big bugbear in the earlier days when we didn't have really good quality therapy. Now, post 2014, once we had the DAAs, the outcomes are significantly better. Lung transplantation and heart transplantation, unfortunately, we don't have very good quality data. There is very limited data that's come out. This is 25 centers who have reported 22 patients. And again, no PI therapy, viral load being fully suppressed. Primary pulmonary hypertension was the most common reason why this happened. Maybe it's HIV related. And post-transplant follow-up rates were reasonably similar to what you would see in HIV negative adults. But then again, these numbers are too small for us to make any kind of conclusions. I have not handled any heart or lung transplants in HIV infected patients. I have not had a patient come in that way. But liver and kidney, we have lots of it. HSCT, again, numbers are very small. And again, the treatment is based on the primary condition. OIs are a problem. And also keep in mind that GVHT tends to be a problem as well. As far as curing a patient of HIV with transplant is concerned, if they have the CCR5 delta 32 mutation, the donor homozygous, yes, it could result. The 3 cases, long-term survival, pretty good. But then we would not recommend this as a measure to cure it because hematopoietic stem cell transplant by itself is a pretty ghastly procedure. We're getting to that. So what is our current eligibility criteria? Most recommendations would be things like CD4 of more than 200 for kidney and more than 100 for liver. The reason why we say 100 for liver is because in patients with chronic liver disease, they have hypersplenism and their counts tend to be lower than other people. So therefore, 100 in them is probably comparable to a 200 in normal people. but the HIV RNA should be undetectable, preferably for at least 6 months, and optimized NRT heart regimen, which basically means integrase inhibitor-based therapy, no opportunistic infections, and the contraindications would be CNS lymphoma, PML, and chronic cryptosporidiosis infection, because cryptosporidiosis after transplant is a misery and it's very difficult to treat. Pharmacological considerations, keep in mind that interactions are going to be significant. Basically, what we have shown is that, interactions, especially with, like I said, boosted protease inhibitors and NNRTAs like efavirenz is a major concern. The recommendation is for integrase inhibitors, and that makes it so much easier. Obviously, it reduces the risk of rejection and reduces the risk of toxicity as well. Now, what is the ideal therapy? So for my patients who are undergoing transplant, I always do a abacavir eligibility assessment, because while I do go for tenofovir-based therapy, sometimes if the creatinine starts taking a beating, I cannot continue them on tenofovir-based therapy, so I have to switch them to abacavir-based therapy. So obviously, you want to give them INSTI. Dolutegravir is probably easier. Altegravir is messy. So abacavir lamivudine, abacavir emtricitabine would be nice. Problem would be if you have patients with hepatitis B, in which case you will have to use tenofovir. And it doesn't mean that you cannot use tenofovir in all your patients. Most of your patients can use tenofovir, but you have to be ready to switch to abacavir if necessary. I'm almost done. What we do know is that the outcomes are just as good as in non-HIV patients. Rejections are slightly higher, and today those numbers are equalizing. Liver as well, the outcomes are much better, especially with hepatitis C patients with the advent of DAS. And obviously, it needs a multidisciplinary team-based management along with the transplant physician and your clinical pharmacology to help you with this. Transplant safety obviously is very important. We do hear reports of inadvertent HIV positive to HIV negative donations. And of course, we are worried about the possibility of HIV viral mutations being transmitted, although it has not turned out to be a problem thus far, knocking on wood. The only one patient that we know of HIV positive to HIV negative transplant was a mother who had to donate her liver in South Africa for a child with primary biliary cirrhosis. They could not get a liver for the baby, and the baby is doing well when I last checked. And so therefore, today HIV is no longer a contraindication for transplant, and with our patients living longer, I'd expect to see more patients coming up for liver and kidney transplants, and therefore it's only a question of time before you start seeing them in your regular practice. Thank you.
Thank you, Dr. Subra. Now the session is open for discussion, and let me start by asking a question. Tenofovir is nephrotoxic. So, I mean, post-transplant, are we justified in giving a tenofovir-based regimen because potentially the kidney can go for a toss again? And these patients also have comorbidities like cardiac. So, abacavir becomes a problem in that way. So, I mean, it is a difficult situation, but
the rule of thumb is if the patient already has a very optimized, well-working regimen, don't mess with it. Can the person develop nephrotoxicity, especially on TAC, and does it become more difficult? It's possible. But that's where you work with the transplant team and try and figure out how you need to change it. So what I do is I always check the HLA type before they go for the transplant and document it. I have few people who are B5701 positive, in which case I'm a little uncomfortable. There, I'm starting to think about dual drug therapy and things like that. Not because it's awesome, because I don't have a choice. But if I have abacavir-based therapy, I start going for that because I don't want to additionally burden the kidney, because nephrotoxicity is an independent risk factor for poor outcomes. That's true for every disease for that matter. So I think you need, the recommendation is don't routinely change it. If tenofovir-based therapy is doing well, leave them be. There's not enough data to show that TAF is significantly better for tenofovir for this situation because the numbers are very small. So one option is to try and switch to TAF. But my worry is with TAF and dolutegravir, the weight gain can be astronomical. And that is not something the transplant physicians will ever forgive you for. So I think every option has its own challenges. You kind of roll with the punches.
Thank you. Any other questions?
One more question. We conclude this, please.
Thank you, Subrat. It's a great talk. I know we will be keep seeing cases, I'm sure. You'll be handling some of our cases soon. Now, coming to this interaction between tachylimus, in the initial days with the efavirenz, we had struggled a lot, doing all those levels, and it's a very tough time. Now, with the current guidelines, with the current lot of pharmacokinetic studies done by the Liverpool group, now tenofovir is very safe with tachylimus. You don't need to do any dose adjustments. TAF safe, MT7 3DC, dolutegravir, and bictegravir. Only worry being the darunavir, ritonavir. And again, with the lower dose of ritonavir, they are just working on tachylimus. Thinking we'll have more and more patients might go for transplant in future. There's something, a new evidence. Now it's been very recently updated by the University of Liverpool, who governs all those pharmacological interactions on this. That was a great talk. And again, coming to this choice of therapy, I think you should leave that to the ID doctor to handle. What is good for the antiretroviral drugs? I know there is tenofovir is the main culprit. We are not going to give them. We have to work on the other way. And it's not easy in a transplant patients, depending upon what transplant they are doing. Or they're doing on the liver or on the renal or on the lung or whatever might be. I think we should work on that. Here comes again the two-drug therapy. We had a lot of argument in the last session. I think that can be a great escape. If the patients are very virologically suppressed, hepatitis B negative, I think that could be a great option.
Yes, Atul. Yeah, so I think, this is very interesting to have, the two-drug regimen. So two of my patients who has received renal transplant, one patient has completed 2 years on DTG3TC and maintaining excellent suppressed viral load. And the second patient has completed 9 months on dual therapy post renal transplant. Both are doing great. So I think I'm nothing to worry about keeping this patient. Those who are receiving immunosuppressions on two drugs works well.
I agree with you in that I think dual drug therapy will probably do just as well. I have a couple of patients. The only time it becomes a headache is when they have hepatitis B in addition to that. So, one option is to do Jugaad, like you put them on dual drug therapy and also add entecavir on the side. I mean, short of that, I can't think of any other ideas.
Thank you very much. We'd now like to call upon the chairpersons to felicitate our speakers in Memento. We would like to ask Dr. Dilip Mathai to please come up on stage to felicitate our chairpersons.
With that, we move to a very, very exciting last session, which is the Great HIV Brain Teaser Quiz, which is open to everyone. So it's not just for students or residents. Everyone is welcome to stay back. And after that, we will have a beautiful musical evening, which will be by very passionate, talented doctors. At 8 p.m., we will also be joined by our chief guest, Mr. Bhushan Gagrani, who was unable to come this afternoon, who's the Mumbai Municipal Commissioner, and he will be joining us too. So with that, I would like to invite Dr. Wasim Khot and Dr. Smriti Bajpai for the quiz. Do we have enough energy or is everyone tired? Yeah.
Thank you, everyone. So we are going to have a great HIV brain teaser quiz prepared by Dr. Smriti Bajpai and me. It is for everybody, and it is app-based. So I request everybody to scan this QR code and please scan this QR code to join the quiz. Once you have logged in, enter your name, and then we will start the quiz.
I am sure this is going to be sort of a revision for every one of us. The entire day has been really hectic with so much of bombardment of information. This is like a recap. And I'm sure most of us would enjoy this with the new technology of app here. So we give 2 more minutes to everyone to log on to this. Are you guys able to scan and get it? Maybe some show of hands. Yes, the ones who are able to log on, very nice. So do we begin? Do we begin? Yes. Okay. Wasim, so
Can we go live? Okay. Technology comes with challenges also.
yes.
We are used to the routine PowerPoint and the presentation, but for to involve all of us, this app-based was the best thing that we can do.
We have to bring something new every time in ASICON. And I think so this is the way Sir Swaminathan sir was saying, those visuals are really nice when everybody comes on the stage. So is this quiz. So before we carry on to this, I don't see Gilada sir. What is the prize we are having, Trupti, for this at the end of it? It's a surprise, right? So whoever gets the maximum answers correct, there's a surprise at the end of it. Yes.
You can see it in your phone. The first question is Indian, the NACO was constituted in which year?
Is it visible on your phones? Yeah, please answer.
Answer. A, 1986, B, 1990, C, 1992, D, 2004.
No loud answers, huh?
Yeah, please answer in the
In the app. It's all anonymous, huh? One of the
Give us-
choices, yes.
No, only one choice.
Single choice, so one answer.
Is multiple choice.
Yes. It's not working?
Uh-oh.
Oh, give us some time. Okay.
Can I do the resume quiz?
Is it resumed?
Not in our control. Just give us 2 minutes. Can we put the scanner on the screen?
Is it opening now for others? It's stuck after the first question? Yeah, it is. So that's the app person is actually working on that to resume from question 2. But some people were not able to open it. How about them? Now is it? Should it be working? Yes. Can you see now? Question 2.
Question 1.
Maybe have the show of hands for whom it's not working. Maybe he can, quite a few of them. Huh? Okay, so what we'll do is now we'll give him 2 more minutes. If that doesn't work, we'll come back to the conventional PPT. Is that okay? Come back to the conventional only then. Yes. Yes. We are still at early phase of AI. actually, so refresh and try, please. I just tried from it and it's working. Yes. 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 Failed to submit answer is what's happening. Yeah. Submission is taking a little longer time.
So one so just till the time we sorted few questions, we had extra, which are non-academic but HIV related. Uh, uh, First one to answer.
You raise your hands.
Yeah.
So whoever raises the hands will get the chance.
Which legendary rock singer, lead vocalist of Queen, died 1991 due to AIDS-related complication? Hollywood related Hollywood movie. Yeah.
Sir,
What name of the movie and the actor who played it? Actor who played him.
ooh, great, great. So 1 point to him. I'm keeping your name ready for the surprise by Trupti. Okay. Fine.
27-year-old MSM presents with fever, rash, sore throat, and lymphadenopathy. Rapid third generation rapid HIV test is negative. What is the clinical suspicion is high? What is the next best step?
Raise hands.
Yeah. Yes.
Viral load.
So this
Testing is what we look for.
Yes, viral load. It is an acute seroconversion.
I like that. मत देखो.
In
Yes.
in HPTN 052 trial of serodiscordant couples, what was the primary prevention related finding regarding early ART?
हाँ. Raise hands.
Yeah, so early ART reduced link transmission to uninfected partner by more than 90%, that is 96%.
Are we likely to get this? Or we can. What else we should ask you? So we begin. Okay. So we begin. Yeah, let's start with the PPT. Coming back to our original format, and I would request all to come back to your paper and pencil. Okay.
Right.
We can do that. We can do that. So let's bring the PPT, I think. We just ask questions and give them options. We started?
Started. Varun, uh, is
What do
it
you say,
possible to
Varun?
load or? Yeah, yeah. So we are getting started. Hopefully this time there won't be glitches. Yeah.
Yes, in the app. Did you remember this? Let's try again. Yeah, it's coming. I'm so thankful that people are still excited for the app. And we are going to give strict feedback about his app.
Can I give the QR code? Please give the QR code. Scanner, please. Scanner, please. Pray for the best. Everyone ready? Across. Start the quiz.
Yeah, start.
ASICON was constituted.
NACO was constituted in which year? Mark it, submit the answer, and please move ahead. Question number 2.
In which year HIV was isolated by Institute Pasteur team led by Lou?
Question 3.
The Berlin patient achieved long-term HIV remission after ART intensification, allogenic stem cell transplant from CCR5 donor, therapeutic vaccine, broad neutralizing antibodies. Which study confirmed U is equal to U applies to MSM population?
Question 5.
Lenacapavir targets which viral component? Reverse transcriptase, integrase, capsid protein, or protease? UPOA measures what? Plasma RNA, latent replication competent virus, quality of life in HIV, pro-viral DNA. Moving to the next question. Rilpivirine requires which of the following? High gastric pH, acidic environment, renal activation, thyroid cover. Next question. Which of the following is an immune exhaustion marker? CD8, CD1, CD4, CD8 by CD4. Next question. XLA B5701 predicts hypersensitivity to which? START trial showed benefit of immediate ART even when CD4 count was above what level? Last but one question. Patient previously exposed to raltegravir present with a DPG-based regimen genotype shows Q148H and C140S mutation. Best next step feels DPG dose, switch to boosted ritonavir-based salvage therapy, add lamivudine, start myrogram. Last question of the online thing. Able to upload only 12 questions. 35-year-old woman on BPG plus TAP FTC, 15 kg in 18 months, lipids are elevated, no other cause found. We were able to upload only the 12 out of 30 questions and the quiz. You all ready to see the results? Let's see. I hope everybody has answered it.
So we had a mini quiz, so to say. 12 questions, everybody answered. Now we are ready to see the results.
Only 2 people have answered 11 out of 12. One of them is the and
So not
second is no, that question is unfortunately wrong there. I take that question. Yes.
Yes, yes.
Because he copied in the law.
Okay, so who's the second one?
Second one is
Yes. Can we have a round of applause for sir? Now, as Gilada sir said, he's not. No, yes.
The next is Nishad Afroz with 10 points. Sudhanshu Deshmukh, Hardik Jain. So a lot of one with 10.
So how many of them are with 10?
Hardik Jain, Sumit Arora.
Can they stand, please?
Sumit Arora, Khushbu Agrawal.
Khushbu. Let them stand. We can have a tiebreaker. One question, huh?
Nishant Afroz.
Nishant Afroz. Yeah, please keep standing.
Sudhanshu Deshmukh.
Sudhanshu Deshmukh. Yes, please.
Hardik Jain.
Hardik Jain.
Sumit Arora.
Sumit Arora. Sumit Arora.
Khushbu Agrawal.
Khushbu Agarwal.
Kunj Dabuwala.
Kunj. Okay, so we have 1, 2, 3, 4, 5. Can you come ahead, please? And we'll have single tiebreaker. Single question as a tiebreaker, right? Fast. Fast, fast. Khushbu, fast. So how many winners we need? 3. Okay, so we'll have 3 questions. With first tiebreaker question, we have the first one, and please. Okay. Yes. The one who raises hands first has to answer first.
Will not be option.
Yes.
This basketball legend announced in 1991.
Okay, very good. So we have the first winner. Please. Now amongst these 4.
Year-old girl presented with gradually progressive painless diminution of vision in left eye. Fundus is showing headlight in fog appearance. How will you treat it?
How will you treat it? Okay,
This is
correct
a
answer. This was toxoplasmosis, as you said. Please, our second winner. Yes. Big round of applause, please.
What was the theme of World AIDS Day 2025?
Hello.
Overcoming disruption, transforming the
Very good, very good. Thank you, and both of you, well done, please. So we have 3 winners here.
They will have cash prize.
Yes.
Please contact Dr. Trupti.
Dr. Trupti, she'll be giving you cash prizes at the closing ceremony. I'm really thankful to all of you for withstanding all these disruptions.
It's substantial amount. And apologies for the
Yes,
inconvenience.
yes.
We had something else in plan, but
And yes,
unfortunately,
but
execution.
it was our first attempt, I think so. For keeping everybody engaged. Thank you so much. I would like to thank Gilada sir and the entire team of ASICON for giving us this opportunity. Thank you. Dr. Gloria Alexander, please could you really thank our grand quiz masters? Thank you everyone for all the patience, and thank you to the quiz masters for the patience with all the technology glitches. No, next time we will keep a backup also ready.
Important announcement. We have the AGM in Hall 4, which is just next to the registration counter. So I request all the ASI members to kindly join in for the AGM, which is to follow soon after this. Thank you. Please do not go back. Please join us for the AGM. Yeah, and the musical evening to follow. Yeah, the musical evening will begin in another half an hour, 45 minutes. So the AGM will be in Hall 4, and please join us here for the musical evening and for dinner.